Where it's worker
Don't have a
That's
top.
70.
The subintimal there.
Give a talk.
Yeah, that's why it's always say that watch the wire with your life ones, particularly these dissected channels. And usually whisper with being a hydrophilic usually goes and helps us out. But in this case, it's not helping now. It's still same. And then
No,
you
I
can
think
leave
it's
one wire
70.
and then go with the second wire.
Yeah, it's not staining, so I think you are in a little septal, so I would just come proximally, and I think that might be okay there. No, that's the same channel.
Yeah, same channel. But remember, even the initially was initially was not difficult, and Amit, my associate, was able to wire it easily. But now it's a little difficult because of our obvious the channels which we have created not only by rotablation, by the balloon also.
Yeah, I mean, the image after the
It's
balloon
that
image, there was a
aneurysmal
clear
area
linear
that you
dissection
might be
there.
getting.
So say
to
it
the
looks like I'm getting a message from Dr. Keeney that she's
Yeah.
ready there.
Well,
So
while
let her
you're
go.
doing
She
that,
wants to
which
go
I'm
there?
sure
Yeah,
you'll be
yeah.
successful, let's go to Dr.
Yeah.
Kinney and then
Yeah.
we'll come back to you. But
Yeah, and we are
we're
going to
definitely
record,
coming
hopefully,
back, so
everything,
you
yeah.
better get that wire
Yeah.
in.
Get a
Let's
field
go to the
also.
next, let's go to the next
Field
room.
also.
Feeler 180.
They probably need microcatheter.
No. We are live, yeah.
Yeah,
This
you're
is
live.
another
See,
tough case.
tell us what
Pull
you've
back, pull
done.
back. No, I know trial is one, and what we see in Mount Sinai is a different, okay? This calcium, I'm telling you, you need special devices to open the calcium that we find here. So LED we wired, right? So we tried to balloon, but nothing is getting into the LED. No wire. So we are trying to do rotational atherectomy into the LED now.
Okay. So you've
So only
got the
thing is, people
rotational.
will now tell me that why you're doing rotational atherectomy, do imaging, maybe do IVL, but since the
No, but
balloon
you
is
can't
not
cross
crossing,
anything. Nothing is
yeah,
crossing,
so
right?
nothing you can do.
So
Good.
that's
Okay,
it, but
good.
it's the same
No,
burr,
that's
the same
one thing.
1.25
I know
burr?
you were discussing about imaging, but let us try to do here. No, go magnify. This is low mag. Yeah, good. Okay.
So what, is the same burr
So-
size, or did you go up higher?
No,
it's
we went
1.25.
higher, 1.5. Remember earlier, Greg was discussing also that why don't we go higher burr size in the LED? So this is where we are, where nothing was making a turn.
Okay, you're making progress. And what's your speed there? Is it 170?
155 now, going up to 160. Asif is listening. Yeah.
Yeah, and with the 125
So the
in
pressure,
particular,
you can see the hemodynamics as we are doing it,
Yeah.
right?
yeah.
A little bit of EKG changes we are beginning to see. Yeah.
There you go. With that 125 in particular, you got to go so slow and be careful not to get it stuck.
Is this a 125 or a 15?
1.5. This
This
is
is
a
the
I think it's a
1.5.
1.5.
This is the 1.5.
Why the pressure is like that, guys? Why is it all over the place?
So the tracing looks kind of funny, but I don't know why that is.
Yeah.
It's probably 1.5 burr, and the guide is not
Here we go.
coaxial, so it's probably changing the
No, no,
pressure.
no.
Once the burr comes out, it'll probably be okay.
Okay, good. You made a little X-ray.
Okay,
good.
you got
At
it
least
now.
here we were able to get our lumen, yes. Okay, that we were able
Okay.
to do it. Okay, so get me a fielder and a run through. So we'll get the fielder into the diagonal and run through. Into the LED.
Okay,
So we did try dilating, you were there when you saw us dilating the LED and diagonal, right?
mm-hmm.
We're going to take a picture now. Yes, done. Okay, take a, right?
Yep.
This is why maybe the guide. Okay, good.
Like your pressure's good.
Yes. Wow. Now everything opened
Now we
up.
have
I think
an
we needed that
artery.
1.5 bar.
See,
Yeah.
I was more worried about that lesion than Samin's lesion, because Samin's lesion had the wire bias, and you know that was the straight path. This was more concerning, but that's a great result.
So now you're going to dilate and then image, or when are we going to see some imaging here today?
No, yeah, yes. Let's just wire it and then decide, because
The
I think
imaging-
we call it
imaging ain't
artery in
gonna go.
pieces.
Yeah, you don't,
you're
you don't
right.
want to mess around now. Your angioplasty.
Balloon
then you
is
image,
not
yeah.
going to go, means imaging catheter is not going to go. That's number one. And
Well,
arteries
you
in
just did
pieces, we need
Rota,
to
so
dilate
let's
and
see after
stabilize.
your
I actually think
balloon.
I think you could put a long 2.5 balloon in, get this whole thing open, and then image to find
Yeah,
out
that's right.
where you're going to put the distal stent and how large you're going to expand it. Yeah, no, that's what she's doing. I think that's
That's
probably
what
right.
I'm sure that's
Absolutely.
what she's doing, but we want to make sure
Yeah,
we get to it.
That's a great result, though.
Yeah.
Anu, nice job.
Yeah, thank you. And now get us the balloons. At least what, 2.5?
Yeah, 2.20 we have.
20 we have, right? Get it.
I
So
mean, if we
now,
were in Italy,
the
maybe
dissected
Davide-
vessel, let us try to get in the lumen with the entire vessel that's dissected, yes.
If we were in Italy and Antonio was there, I think, Davide, you want to say what he would do? He'd probably put a bunch of drug-coated balloons there. Would that be wrong? Davide? Capodanno?
No, you know, what he's now saying is that it's not the DCB per se, but the strategy. So DCB plus bailout
Yeah.
scaffold is these days, rather than DS, but
Fielder?
it's Antonio.
So we need data
Yeah,
on
but
that.
if you do that, you better do it without imaging.
Take the
Because
rotavirus.
if you image this, there's no way you're going to do anything but stent it.
Yeah.
Bruno?
Yeah.
Okay,
But
2.5 balloon, so we'll do it. The diagonal we've never dilated.
Okay.
You have to do lesion prep. You have to dilate all these things because, you know, we are all
Yeah, that's
about
what she's gonna
drug-coated
do.
balloon, drug-coated balloon, but luminal gain is
Yeah,
still
we
the
got
most
that.
important
We
thing.
got that. I just want to hear, I've got all these experts here from around the world. So Bruno,
So if
what do you think
if you do
about that concept?
If you do simple soft bifurcations, I think you do not need necessarily imaging. But in this highly calcified lesion, you should do imaging to see what you're doing.
You know, that they
Okay,
will.
balloon, quickly.
Good.
You know,
So,
an important bifurcation and long calcified lesions. I mean, this is the sweet spot for intravascular imaging.
both imaging and I think.
Okay, but
the-
everybody
the
agrees we
future-
are going to do the balloon and then we get the
Yes.
IVUS ready? We have?
Yes.
Okay.
Yeah, we have.
So we're going to get into the LED. Hold the wire for the LED, yes. Leave it. IVUS is there?
Yes.
Get the IVUS. Yeah.
Samir
we do that.
Kapadia, you're running a huge health center
Go.
at the Cleveland Clinic on cardiology. Now, you think we're using too many things here, too many devices with this? Should this patient have gone to, this patient has had previous bypass, I think, but
No, it did have bypass, but yeah, no, I don't think, this
Guide.
imaging is necessary because it is going to actually save the cost at some point.
Down.
But I do agree that we are using a lot of devices in
Come on.
general,
Come on.
because,
But if they wanted to use a drug-coated balloon in combination, would you even allow that? Because we heard from Sunil, he's got it locked up in the cabinets. He's not letting people anywhere close to it unless the patient is in a
Okay,
trial.
down.
Is that what's happening at the Cleveland Clinic too?
not
Dr.
really,
Kapadia?
we are still using
the
it.
Diag,
I
get
agree that
me a
it is
2 balloon to the Diag.
financially very difficult,
Two
but
five
still
may
we
not
are
go, no?
using it. We are not locking it up yet.
All right. So, Dr. Kinney, you've dilated the LA, it looked like the LAD, right? First, or I don't.
Yes.
Yeah. And now, you're going to do the Diag?
Now
or you
we
wanna
will go to
image?
the Diag, but to the Diag, distally, remember our
Yeah, you had some
bar
issues.
did not
Yeah.
cross. Yeah, so I'm going to go with the 2O balloon.
Yeah, go a little
Dilate
bit.
there and then
Yeah.
IVUS is ready for the LED. Yeah.
Okay,
And then we can
excellent.
decide, did we do enough for debulking or do we still prox LED, we need anything more?
Okay.
Yeah, that diagonal
And
will
we
be hard
actually
to
are the
cross.
one, we have the algorithm for management of calcium that came out in, branch of JAMA cardiology, as well as then we have, which we presented in the ESC last year,
Yep.
management of, calcific nodule, because that is where all the discussion is yes, we do imaging, we see things, and then which device do we use? COP.
It looks like your balloon went, so you did do something there.
Yeah, no, but way further down.
Not the lesion.
Did you go all the way down?
I think the lesion is
to the
distal.
distal?
More distal is where the question is.
Yeah, distal. I may need a new balloon, I think. This is not making
So 1.5,
anything.
probably 1.5.
I mean, if it really is that hard and nothing is going at this stage, I will leave it alone because we got to focus on, look at, everything came out,
Yeah.
Okay.
telling us that there is still so much calcium. Can you do the imaging of the
LED.
LED then? The other thing is there could be interaction between the impeller and the guide.
That's what it looks like to me, actually.
Yeah.
I kept seeing that throughout the, and that's why maybe even I see it. There's like a bend the way the
Impeller is
guide and the
sitting.
impeller is
Yeah,
sitting.
Yeah.
The
Yeah,
interaction between the impeller and the guide is.
Yeah.
it's not in the right spot. It's going behind and then coming forward.
Right.
Yeah.
Yeah.
Okay.
Okay, let's at least
You
image
guys
the
have
LED.
4 minutes,
Then I'll
and
wire
we
that
gotta
up.
see the other case and what's happening in the other room. So maybe, what should we
Okay.
do?
Go
What do you
there.
wanna
Yeah,
do?
yeah.
Can I go to the other room, or are you gonna?
Yes.
Because you're gonna cross
Well,
that diag
No, you
again?
want to see the LED imaging?
I do,
So then we
yes,
can make a
please.
decision, yes.
So Anu, do you prefer IVUS or OCT in this situation, or you don't care? Either one?
So, interesting, of course, OCT is the best because two things. The thickness of the calcium, and to really understand, have we done enough debulking? OCT is the issue with OCT is say multiple runs without dye. I know people are doing without dye-less, but without dye, you don't see it well. So if you need multiple runs, and especially then left main is involved here, left main is not involved, IVUS is probably the best, yeah.
And do you have a preference
If you want to
of,
see the cuts, if the calcium modification has happened well, you definitely need OCT.
and which kind of IVUS device do you use preferentially?
We
Looks
go?
like the Boston.
We go and we like to use 4 millimeter. Remember, it comes in 8 millimeter to 1 millimeter. So we do it in between 4 millimeter.
Okay, start fullback. It's a little bit myocardial breach. Yeah, some hematoma here.
Hematoma?
Yeah, but so far not much calcium.
Yeah.
Here a little bit. Yeah, here's calcium.
So now tell us at the proximal LED, right after the diag.
Revelation.
Yeah, 360 degree.
Yeah, prox LED is 360 calcium. Yeah, I will stop it. Yep. So I will quickly check. So I will show you this. So like a 2.1 vessel, very small vessel.
We use 2.5 balloon.
Here looks like 3 o'clock. Here is a hematoma here.
Okay.
You should cover here. So this landing zone is gonna be like a 2.2 vessel. Then, yeah, mid to distal, yeah, as I told you, there's not much calcium actually. But around here, the calcium stud.
But it looks
Then-
like you've ablated the calcium quite nicely.
Yeah,
There's
yeah, well,
lots of
come to the
cracks
proximal
there.
LED.
This is
Okay.
actually we are like proximal LED, and a lot of revascularization, and the surface is like smooth. It's like shaped by the loader.
Yeah, you saw that reverbs.
So-
Those reverbs are typical
Yeah.
rota artifact.
Yeah. So
Okay, pull back, come to the proximal.
There was a
I
nice.
Because we need to know, are we okay? Have we done enough in the proximal? So looks like a mid to distal LED, good modification, ready for stenting. Proximal.
Yeah, here's
another point
here's
is
the
that-
question. So
Stay in the
there you-
proximal, 360 degree.
yeah, and actually not good landing zone. It's gonna be on the 360 calciums. So maybe the best size might
Do
be.
you think, I know IVUS is not the best, that you see at 4 o'clock, 5 o'clock, that there is an, you see the calcium plate has been,
I mean, yeah, it might be some dissection. Even the angio shows some like
I feel
haziness.
like
It might be some dissection but because of the calcium artifact, you cannot see the behind calcium any dissection or something.
Yeah.
It looks like some hematoma here. So
come
hematoma in the revascularation.
proximally, come proximal.
Yep.
More.
Yep.
Oh, yeah, right there.
It might be our landing zone.
Yeah, you look at that 4 o'clock.
Yep.
It's a break in the calcium.
Yep.
I think
Or
you've
some
broken it enough
can
to
just
be
stent
able
it,
to go.
yeah.
Yeah. I would use a larger balloon.
Yeah,
I don't think you, I
you
don't
could
think you
go
need
ahead.
another, it's not that long a
Yeah,
lesion. The
I think
vessel's
you can go
large.
ahead.
And I think you do have one fracture in most of the places.
Okay,
Yes.
So I would
so,
just use
One fracture is probably-
I would use
yeah.
a larger balloon.
so, anybody,
Okay,
I
then
want to go
again,
to
the
Dr.
question, Raja
Sharma.
balloon, regular, Raja high pressure balloon?
High
or you think
pressure,
You need a
yeah,
cutting
high,
balloon?
high
cutting
pressure
balloon.
for sure, high pressure.
Okay, so, Dr. Kinney, tell us what
Give me a note.
you're going to do next, because I want to go to Dr. Sharma.
Okay, we are going to do a high pressure balloon
Yeah.
in that approx LED, and we have the mid to distal just stent it, depending on how the Diag is
What's
going
your
to
plan
behave.
for the Diag? Are you going to crush, or are you going
We
to
are
just
going-
do a provisional?
Yeah, no, first we need to dilate it well, the second lesion. If it does not
Okay.
dilate it well, maybe, let's see, do provisional and come out.
Okay.
Give
We're
me
going to
the
go,
2
we're going to go to
12
Dr. Sharma, and then hopefully you will show us your final results. Dr. Sharma?
Yeah.
Yep. We are struggling too here. We are
Ah,
struggling more than others.
that's not good.
Yeah, I know. But let me tell you where we are still. So
Okay.
basically, you remember here, such a view is so much ahead of the game.
But you see that deep dissection there, that's why.
Yeah, this is where we were. And of course, we knew
Losing
about the
that wire
dissected
was
channel, but we
bad.
are able to do that burr without any problem. We did a little dissection and the wire, removing the rota wire after the balloon dilatation came back. And since then, we are trying to get into the main lumen. And I'm having a double wire now, parallel, because we keep going into the dissected channel. So that's where now putting a whisper wire.
Okay.
We tried a few other wire techniques. None of them has worked. So that's a run-through wire on the side. And I'm putting, again, whisper, which was the original wire, which we tried. Although we had tried that whisper 2 times since then, it's not finding the true channel. So other thing is that the proximal, there's still a lot of dissection. The lumen is not completely open. That should we just dilate the proximal with a 3O balloon and then see. So this is the whisper now. Let's see now. where we
One
are.
suggestion, Samin, you can IVUS it because it may be that very proximally you are in the false channel. So if you have
Yeah.
one wire, just because already it's dilated, so you can IVUS it to see where your wire is going, because this may be too distal and your wire may be in the false channel higher up.
So,
Yeah, it's actually, we did that's why we did this picture now. See this here. That's where we are now. We were.
Right.
So
But see,
remember,
the-
until that septal and diagonal looks okay that we are there, but then everything else is the dissected further down. And wire keeps going into that septal. So yes, we
up
are
to
we ready with
septal,
the
you are
IVUS?
okay, I know, because wire goes in the septal, but
So-
after that, there may be an issue.
Yeah.
okay, so Dr. Sharma, if you don't mind,
Yeah.
what we
Yeah.
need to do, because we're about 30 minutes behind, and you know, I'm stickler on the
Yeah.
time. So what I want to do is get into our first, our session on artificial intelligence.
Yeah, that's okay too. Yeah, and
And-
let them play this on the side if need to be,
Yeah,
that's
if
fine.
you need
Yes.
to, when you
Yeah.
get a big successful thing, you could put it on the side, but we are going to move ahead, and then
Yeah.
we're going to come back to you. Hopefully, you'll show us.
Yeah,
What we're
exactly.
going to do now is to move into, thank you very much to my panelists. Thank you all. Congratulations to Dr. Kinney, Dr. Sharma. Hopefully, we will congratulate you, Dr. Sharma, when you cross that. And then we'll come back to you soon. Okay. Thank you. So we thought this year that the topic of artificial intelligence is so all over the place, especially in healthcare, but more importantly in cardiovascular disease, and I think it's definitely incorporated. We have some of the best experts here. To begin with, I'm going to start with Dr. Samir Kapadia, who's the Executive Director and the Chief of Cardiovascular Division and Department over at the Cleveland Clinic, the #1 hospital in the United States. So we are extremely lucky to have Dr. Samir Kapadia. I know that he's innovative because he does have this MBA from Harvard, not just too long ago before he became the head of the health systems there over on the cardiovascular side at Cleveland Clinic. And I asked him, what is he and how does he envision the use of AI in health systems and quality improvement? We're so lucky to have you, Dr. Kapadia. Thank you for traveling over.
Thank you so much. Thank you again, and I know that we have an exciting case that we broke through, and now we are talking about AI. But I think this is also an exciting part in my mind, that what are the things we are doing. So I think the most important things, I just outlined 4 areas that we are interested in, and one of them is to have as Dr. Leon also mentioned, that we need to have some models to combine different parts of the domains and different biology. So to have the data properly curated to be able to analyze in the AI is the first step. And then we have to have, there are so many different therapies that are targeting mostly imaging currently by the FDA. And so again, if you are going to focus in a healthcare system, imaging is one of the areas where you want to first focus, meaning ECG, CT, MRI, angiography, to understand that where we can, in cardiovascular medicine, to understand the purposes. And on my screen, I don't have the slides anymore. And then the risk prediction, can you please, okay, thank you very much. And the third thing is to have different risk prediction models where we can say that how we can predict the risk of either heart failure rehospitalization or a lot of different social or healthcare related areas. And then CDS, the clinical decision support system, to say that if somebody comes to the emergency room, as Dr. Leon was mentioning, whether we do an ECG, and that is going to help us to say that how we triage the patient or how we can decrease the door to balloon time or whatever different things we want to do. So these are the basic structures by which we are working. Of course, the promise is real. We know that this is already happening. A lot of us are using this in different ways. So this is no longer a question whether we want to participate in this and be part of this major upheaval. What Cleveland Clinic has done. So Cleveland Clinic has done at least 3 important areas that I just wanted to highlight. The first one is with the Akasha. Akasha is Akash is like sky. This is the Indian word, Sanskrit word, and this is the company that has a very transformative way of revenue cycle, meaning that how you do prior authorization, how you can do, these are kind of stupid things that we need to do, but very important to make the payment come through. But these are very painful points for a lot of physicians, especially all of us that work in the healthcare. Every day they keep asking you that why do you want to do this or that, and so this pre-authorization, coding, then the claim management, and then finally the collection. So this is very important part of the revenue cycle, and we have collaborated with Akasha to make sure that we can have a revenue cycle organized. The second most important thing, life-changing for myself and a lot of other physicians, is the ambience. So we connected with ambience. So this ambience is a software that you turn on your phone, and when you go and see the patient, and at the end of the visit, it generates the beautiful note. It's an outstanding note. So it tells you that what happened to the patient, what you recommended, whether, if I do a TAVR or SAVR discussion, it tells me that we did a SAVR or TAVR discussion and what I said about the risk and benefits, or multivessel angioplasty versus CABG. And then the beauty is that you can organize all these things for the reimbursement purposes, or for suggesting that how you can get prior authorization, or even for quality. So if I am not discussing SAVR, or I'm saying something wrong about SAVR, it may be able to tell you that this is a wrong thing that you're saying, or you forgot to say about SAVR when you're discussing TAVR in this patient. So there is a quality element that you can put, and also timing, that how much time I spent with the patient is also documented. So we have now 3,800 providers, 76% utilization of the AI scribe, so everybody loves it. So even though you're very good with typing this, that, whatever, it still is beneficial. And there is a 30% reduction in the documentation time. Everybody closes the chart at the end of the day, so the pajama time, as we say, is also increased. And so it is a tremendous help to all of us. The third thing that has happened is that Cleveland Clinic in Abu Dhabi is run by the M42, is a government organization, and now the G42 is their AI AI engine. And the AI engine worked with Oracle and Cleveland Clinic together to have a AI platform. Again, as I said, that this is the idea is to have many scalable, cost-effective care models that we can generate and then use to then do diagnostic, personalized medicine, outcomes, reduce costs. So all major areas where healthcare has to improve, we can work together. So these are the 3 organizations in the large scale that we have collaborated with. Now, in cardiology, of course, the complexity of cardiology is the rising volume, complexity, workforce is strained out because we don't have anything, from the technicians to the nurses to the physicians, everywhere there is a shortage. And of course, there are a lot of mandates from the payers to say that your door-to-balloon time, your heart failure rehospitalization, how you treat with medical management, proper GDMT, all these things have to be managed in order to get proper reimbursement from the, and of course, we have to have documentation such that we can have risk-adjusted outcomes that are very important for again, the survival, financial and otherwise. So again, this is, I'm not going to go over all these different things, but the idea is that it has several different areas where we can work together with the AI. AI is just a tool, but you have to understand that this tool is a very important tool to decrease our cost and increase our efficiency. So this is the most important thing. And of course, in certain areas where the human brain cannot function as well as in imaging or in some data understanding, that the AI can help us. And it's a deep, it's a continuous learning. That is also very important, that we can keep learning from our new data. We have, these are a couple of examples I've just put together to say that in MRI, we have now, this one is just to say amyloid, and we published this to say that, MRI detects amyloid, you can detect it, but this AI does better. So a few patients you can miss can be done with the AI better. Hypertrophic cardiomyopathy, we see so many patients, but still we miss some of them, and the AI engine can identify those things. We are also doing MRI where, just like CT scan, one button placed and the entire MRI is done. And this is a huge advancement to say that it's so painful to do MRI in cardiac MRI, but now there is a single button MRI available with the AI to help this happen, and we have just submitted the manuscript to Nature. I again put these things, I know we are going to discuss this in the subsequent talks, that what are the things that are happening, but there is, I just said that most important thing to understand is that the imaging is the key, so echo, automation, lot of different automations, I just put some examples there. CT, plaque quantification, CT, now we are doing the chest CT scan, where a regular chest CT is done, we can identify the patients with high coronary calcium score and aortic valve calcium score, and then automatically send them to cardiology consultation so that we can properly manage this patient and prevent their problems from worsening. So 400 we use as a cut point, we use, so different cut points we can use to say that when you do echo, when you do a cardiac consultation for aortic valve. So this is already in place. MRI phenotyping, as I said, that is again a lot of different methods. Even the way that you measure MRI volumes has decreased our MRI reading time by almost 40%. Same thing with the ECG. Again, we are working with Tempus. Tempus already has a AF prediction model where you say that how you can predict who is going to get atrial fibrillation. Now, after ablation, who will get atrial fibrillation? After cardiac surgery, who will get atrial fibrillation? All these things can be fine-tuned by just getting an EKG. So these are very important things. Of course, as Dr. Leon mentioned, that finding valvular heart disease, AS, again, a lot of different methods. So ECG is a simple way because it's readily available and large number of ECGs are available. Cath lab wise, again, I think the real-time QCA is happening. This is very important. So we are doing some studies where we are saying that real-time QCA. So after you do a cath, it can tell you that, hey, listen, in proximal LAD, we couldn't tell how much lesion was there. So this QCA is not possible. So either you were streaming the dye or you didn't have proper angles. So maybe improve your angiography. And it is surprising that how many angiograms we see that we can do a little bit better. But this is after the fact. So if you have real time, then you can just take one more picture to make sure that you got the right pictures. So this is very, very critical. That's the simulation Dr. Leon mentioned. And then the cath lab workflows, again, super important to say that how we schedule, how we don't get patients out and things like that are very important. Clinical decision support systems, so many of them. Again, I put some numbers there that we are using. But again, to say that there are ways to say that when you do the ECG, the cath lab in the emergency room, or you do the real-time STEMI pathways, CHF system we already have in place where people before discharge, we would recognize that these patients are going to come back. And so these patients have a different kind of a follow-up with the nurses, with the home health care, or with the things. So this is happening. And then I put some AI benchmarks that you can also use AI for to say that these are different ways that you can determine that you are doing right thing or wrong, and you can monitor it. So the different dashboards are created with AI, and these are, again, super easy to do with AI, and you don't need that many resources, and the money used in the system is less, so it's very efficient to do this. There are a lot of challenges, so I don't want to say this all roses. So there are a lot of challenges, how you share the data, how you monetize the data, how you regulate the data. Again, all these things are important, and at an institutional level or at governance level, you want to come up with the proper solutions. But in order to, you don't have to be so conservative that you don't allow your data to be used for these AI engines, otherwise you will be behind. So we got to be more proactive to say that how we use our data to help grow our understanding. So we are working in a lot of different fronts to make this happen. Of course, you don't need to know everything. As I said, that a lot of people get afraid that what is this AI? We don't understand the ideas. But just like how you drive a car, how you use the different tools, you use it as a tool is also very important, especially like, especially when you're seeing patients, how you now use different, just not PubMed or UpToDate, but there are a lot of different ways you can use the data to help you also. So the future is, I said that the AI is not artificial intelligence, but augmented intelligence. So you can augment your intelligence by using AI. Just don't do, complementary system, global transformation. So these are all happening currently in the world. So, just stay tuned with this and use it every day. So thank you again for your attention.
Thank you, Dr. Kapadia, and thank you for joining us for the panel that we will have. Also, we'll invite Dr. Bhatt and Dr. Leon up here for that discussion session. I am really, really very, very excited about this next talk. Dr. Charalambos Antoniadis is our next speaker, who is the chair of cardiovascular medicine and director of the Acute Multidisciplinary Imaging and Interventional Center at University of Oxford. He's come all the way here to tell us about his discoveries, which are tremendous. So if I would make sure you pay attention to this, because this is truly the future. And Dr. Antoniadis is right on it. Dr. Antoniadis, welcome to New York.
Thank you, Roxana. First of all, thank you for the invitation to participate. It's, believe it or not, it's my first time in New York. I've been to the US maybe 100 times, but it's the first time in New York. Yes. These are my disclosures. Probably the most important one that is not listed is that I'm not an interventional cardiologist. Just keep that in mind. So for many, many years, we have been looking into ways to find the vulnerable plaque. Then we went to the vulnerable artery, and then to the vulnerable patient. But in reality, what we have learned over the years is that it's not these very big plaques that tend to rupture. especially if they are calcified, is the middle-sized or small non-obstructive plaques that very often rupture, giving heart attacks. And what triggers this plaque rupture is inflammation. We have heard a lot about inflammation earlier, and I'm sure we'll hear more in the subsequent talks. Now, in a recent study that we have published in the UK, from a UK population, we include 40,000 patients having coronary CT angiography because of chest pain. Only 18% of them had obstructive coronary artery disease, but 2/3 of the heart attacks happened among those who did not have obstructive CED, among those that were discharged home as needing no further intervention. And we have seen very recently the PREVENT trial showing that if you identify the non-obstructive high-risk plaques with revascular imaging and you stent them, you improve outcomes. At least you push events 2 years later. And now, with all the AI revolution that we have earlier, it's the industry standard to use AI and perform automated plaque quantification, identify the high-risk plaque, quantify it, and then identify the patients who may need some additional interventions. However, we focus a lot on non-calcified plaque, but non-calcified plaque is not necessarily inflamed, because there is non-calcified plaque that is not inflamed and is not high risk and is not going to give heart attacks. How can we do better? In my lab in Oxford, we have used translational methods, ex vivo models of human vessels, etc., to study how the fat surrounding the vessels interact with the vessel itself. And we have seen that when you have an inflamed artery, before you have any plaque, you have changes in the fat surrounding these arteries. If I get a biopsy of the fat around an artery, I can tell you whether the artery is inflamed without even touching the artery. But of course, you cannot open the chest of the patient to get these biopsies. And of course, this happens before any plaque is developed. With coronary CT angiography, we get these nice black and white images that do not show what's going on around the vessel, because that area is black. We develop a method that uses an AI modeling of the perivascular space and essentially brings this information to the surface and turns our black and white pictures into colorful images. And you can essentially identify the inflamed artery by looking into this distribution of the red color in the perivascular space. If you have red, it means that the artery is inflamed. If you have blue, like what you see here, it means that the artery is severely inflamed and then there is an imminent cardiac event, even if there is no visible plaque. And I'll come back to this in a second. Now, we are lucky in Oxford to have this hybrid cath lab where is combined with a photon counting CT scanner, and the table of the cath lab slides into the photon counting scanner, allowing us to visualize rupture plaques even during primary PCI. So you get these acute cases and you don't add any time to visualize, to perform a photon counting CT angiogram on the acute phase. And this has taught us a lot. You can see how nicely this lesion here lights up as red, identifying that this is indeed an inflamed plaque. And we have now, by using this method, sensitivity and specificity above 90% to find these culprit lesions. When we developed this method, the fat attenuation index, we had to turn it into a clinical application that will be robust, applicable in all 3 coronary arteries, and reproducible across different scanners, different settings, different countries. And that's why we essentially developed the fat attenuation index score, which is an AI-enhanced metric of these changes that happen in the perivascular space, that has received the label in Europe and in the UK as the only imaging biomarker of coronary inflammation. And you can see more in this recent clinical consensus statement by the European Society of Cardiology on this topic. What does it capture? This is from post-mortem studies. You can see that if you measure inflammation by using this AI technique, you can essentially capture very nicely the infiltration with CD68 positive cells, and it's also very specific for T-cell immunity in the vascular wall. Now, if you can measure inflammation, you can predict risk, and this is exactly how you predict risk by using this approach. If you see here, in this CRISPR-T study, 2,000 patients from Cleveland Clinic with Millie Desai, 2,000 clinics from Erlangen, led by Stefan Eichenbach. And you can see that in a model where you have age, sex, risk factors, calcium score, and non-calcified plaque, high-risk plaque features, you gain an area under the curve that goes up to 7.5 units on top of that if you add inflammation. So this is something that we have been missing for many, many years. Of course, when you run this AI training, these models, you need big numbers. And this is what came to change completely the landscape. The orphan study aims for 250,000 patients with coronary CT angiograms linked with lifelong outcomes data. We are now at 210,000 patients, and we are essentially expecting to meet the target of 250,000 by end of this year. Now, a big number of these patients, aiming for 200,000 of them, are from the UK. And these are the first pilot data published a few months ago from this orphan study. You can see that if you measure inflammation by using phi score and your arteries are above the 75th centile of the distribution, you have 10 times higher risk to die from a cardiac event if you have no obstructive disease, and 5 times if you have obstructive CAD. Now, we have plaque. We have all these tools that measure flow, hemodynamic significance of lesions. Do we need to know about inflammation? Yes, because if you look into the 40% of the patients who have no plaque, so they came back as calcium score 0, no plaque, this is what happens with their risk. If you look into their 10 years risk, in those who calcium score 0 and no visible plaque, you see that if you have inflamed arteries, you have 10 times higher risk to die from a cardiac event over the next decade. If you have cataract 0 or 1, so you may have some irregularity of the lumen, but again, no calcium, you get a 9.5 times higher risk for a fatal cardiac event. If you have a small plaque, again, similar observation. And again, when you have large plaques, if they are inflamed, then these are the plaques that are going to give you the cardiac events. And all this on top of calcium score and quantitative plaque assessment. How do we treat inflammation? That's very simple at the moment. The only tool that we have that is very, very robust is statins. Within a year's time, after you start statin treatment, you reduce inflammation in your coronary arteries by at least 30 to 40%. And of course, biologics, like for example, this randomized controlled trial with ortikumab, which is an antioxidase LDL monoclonal antibody, leads to a striking reduction of inflammation in the coronary arteries. But of course, we are waiting to see the results of large randomized clinical trials with the novel biologics to see how we can treat these patients. Now, I talked to you about plaque, quantitative plaque assessment. We have the risk factors. I'm telling you about inflammation. We have our stethoscope. Are you not confused? So how are you going to use this information, make decisions for the patients? So AI is here to help us give some order to all this information and allow us to translate this into what we know how to treat best, which is absolute risk of the patient for a cardiac event. And this is exactly what we have done. We have trained a model that gets coronary CT angiograms, performed as part of clinical care, extracts information about plaque automatically, about inflammation. It takes into account the risk factors of the patient, and then it gives you a prediction of risk. This model was trained in the CRISP-CT study. It was then validated as a locked medical device in the UK population of the orphan study, giving you a C index for cardiac mortality 0.84, which is, it sounds unrealistic, but this is what you can achieve with this AI. Now, in clinical practice, we treat levels of risk in a binary way. All the guidelines, they tell us that if, I'm mentioning here the NICE guidelines, but the AHA-AC guidelines are more or less the same. If you have low or medium risk is lifestyle and diet. If you have high risk, start statins, increase dose, or if you are at very high risk, start additional treatments. And colchicine is also one of those, despite the results of the clear synergy study that was published recently. Now, what you see here are events predicted by the AI model, are not true events. When we plotted this graph, we then opened the labels and recorded the true events. And these are the true events. The solid lines are the true events. So this is what you can achieve with this kind of technologies. In the UK, this has been commissioned by NHS England, is being used, and we record changes in management. And as you can see here, 45% of our patients change management when this information is taken into account. 24% start sudden treatment, 13% increase the dose, 8% go for the additional treatments, including colchicine. Now, in conclusion, coronary inflammation drives atherosclerosis, atherogenesis, and plaque rupture particularly. Measuring coronary inflammation is now possible with CT, with the fat attenuation index score, and you go beyond calcium score and visible plaque. And of course, you will need AI to put all of this information into perspective, turn them into risk, and then guide management for our patients. I will leave it here, and we'll have discussion later. Thank you.
Thank you. Fascinating, Dr. Bhatt. Please join us, and I know Dr. Leon will come back, and we'll have him up here. Let's go to the cath lab first, because I know that those guys were working. Dr. Sharma first. You're up first. Oh, what do we have?
All right, can you see us?
Yeah, I can hear
Okay,
you.
good. Show this patient's ECG first. Show the EKG. To me, EKG is a good marker of what's going to happen. Look at this, completely normal. All the 12 lead, completely fine. That basically means patient did very well. We have a policy. Any patient who have a trouble in the cath lab or any residual chest pain, ECG is done in the lab before patient comes out. So based on that, good. And now let me take you where we left. Okay, go to the angiogram now. Okay, so remember the
We don't see the angio.
play.
Okay, this
That's
is where you
yeah,
left
you
us.
have it now. Yeah, you have left there. We are trying to struggle so basically put a second wire and the parallel. So actually we recorded this. I say, once you have a dissected channel, your first wire is your whisper wire or hydrophilic. So whisper didn't do the job. So then what you do, leave the whisper and then go side by side your workhorse wire. So this is the run-through wire which has gone to the apex without any problem. So this is the run-through wire further down, and we just dilated with the balloon, put a long stent, short stent, and this is where we then finally came. And Kiski may show the quick angiogram. I'm sorry, IVUS, this is where we left. No EKG changes. Patient doing fine. All the branches are intact. And we are able to
intravascular
complete this case.
ultrasound, the imaging.
Okay, let's show the IVUS.
Please.
Let's show the IVUS. Against I still did it. I knew that will be the question.
So this is sort of the distal LED, like a residual plaque, but it's not dissection. And all the catheter is intra two lumen. It's not subintima. Edge is on the plaque. So the expansion, of course, it's a small vessel. The MSA of the distal is 3.2. A lot of calcium behind. But the proximal LED like area is like a 6, 7 well expanded. Right? And the proximal edge is at the ostial LED. And no dissection, no malposition. So proximal well expanded. Distal is like area 3, but small vessel. We stop here.
That's okay. So anyway, we are done with that. And I know you have the roundtable discussion. AK is not ready yet. He'll give her lecture a little later, right? Yeah. So she'll give the lecture later. You start your roundtable discussion.
Sounds
and
good.
Once you get time, but I just want to say, the technique wise, I just want to emphasize on one point. When you have a dissected channel, leave one wire. Of course, your hydrophilic should go. If not, leave the one wire and then go with your hydrophilic in the dissected channel. That kind of occupy the lumen and then go with your non-hydrophilic wire side by side. That's what we did. And we actually had done this many, many times with a great success. And thank you very much.
That's beautiful. Thank you so much. Dr. Sharma, one last question before you leave us. Dr. Kinney is still in the lab working on that other case?
Yeah, she's still working on it.
Okay, so she'll show that to us later. So just to keep we're going to have a little roundtable about AI.
Beautiful. Yes.
If she's still not ready after this roundtable, we're going to go to our hot topics and come back to her. Okay?
Yes.
You'll let us know when she will be ready.
No.
Is she ready to show us something?
Yeah, I know. Yeah. Okay.
Yeah?
Good. All right. Very good.
Okay,
so
sounds
combine
good.
first and second roundtable together. Yes.
Okay, sounds good. All right. Well, thank you so much. It was great to see that and a final great result. So thank you all for being here. We talked a lot about AI. We heard Dr. Leon talk about the today, the past, the today, and the future, and the excitement of interventional cardiology and how we're really incorporating a lot of actual AI into guiding us through so many of our procedures. It starts with structural heart. In the early days, Samir, you couldn't do valves without having all the imaging and all of those things and that kind of a guidance for us. In the lab, imaging guides us, but now we want to use AI, an augmented intelligence, an external force to help us make our job better. You're using it in your health system. We are too. What's the future?
I think the future is the young people, first of all, because they need to, we need to recruit, have good people who are interested in this thing to lead each of the field for AI, because it is a tool, as I said, so you cannot have one person leading all the AI efforts. So, if you have a structural imaging person, in the echo lab, they are different than the CT lab, than the MRI lab. So I think it is super important to create teams where they all work with the same tool, with a different expertise or different perceptions that what really they need to do. So that's number one. And number two is that this cannot be done, as you know, that the AI talent from the engineering side is also very limited. And especially nowadays, it's even more limited because there are not that many experts. When we recruit people from very good universities with AI, they are not really experts. So this is a real challenge. And so I think the globalization is necessary. So if you can use the talent that is available anywhere in the AI world, and so industry partnering with different kinds of institutions that have the AI expertise is important, because they may not know the healthcare side, but they are experts in imaging side of AI, like how the Tesla and things like that work, that they can see the road and tell you. So the same concepts are there for this. So yeah. I think these two elements, if they're there, and then from the healthcare side, we have to share our data. So the one challenge Cleveland Clinic and everybody else has is to say that our data are very precious and we want to monetize the data. But in order to monetize the data, we are a little bit conservative in sharing the data. So this is where we have to find the right balance, like how we did study with Oxford to say that 2,000 patients, we shared the data of our CT scans.
We did too, yeah.
So this is a useful thing because this helps to grow the field, but you cannot monetize that, immediately cannot monetize that information. So this is where I think from the people who monitor the data or people who are owning the data, we have to have committees, we have to have some kind of a system that we can benefit from the data, at the same time we can share the data.
Yeah, obviously as somebody who loves data, I see that the entire power of AI is based on data, except that the data is unorganized, and that without clinicians and physicians and those experts in the specific areas, the programmers, the data scientists are lost. And I think that is really why I believe that kind of collaboration is so critical. We're going to hear from Dr. Kinney of what she's set up with AI tools in terms of scheduling patients for cath lab and really taking the burden off of a lot of busy work that we are doing to focus on the things that we absolutely want to do. But without a clinician basically guiding those data, it doesn't work. Deepak, you've been looking at data for decades. Where do you see this going? And what was your take from Marty's amazing, unfortunately he had to leave because we're running late, but what do you think is the future?
Well, I mean, that was a brilliant lecture and two great lectures here as well on AI-related topics. I think AI is extremely powerful, as everyone knows. To me, it's like any tool. It's like when the internet came out, I remember that. And, there are people that said, oh, this is going to be awful. It's going to be end of the world. It's going to be end of libraries. All sorts of bad things will happen. But that hasn't been the case. It's like any tool. It can be good or it can be bad. It's really how you use it. And I think AI is the same, though on a much larger scale. And I think it'll disseminate and change things much more quickly than the internet did, which itself was revolutionary. But I think, what you said, we have to keep on our physician hat. That is, we can't just take that off. There was some interesting work that came out of Mount Sinai. It was led by Josh Lampert, one of our electrophysiologists, that took an off-the-shelf, FDA-approved, commercially available way of diagnosing hypertrophic cardiomyopathy off a 12-lead ECG. Dr. Kapadia mentioned these products are out there. So FDA approved, but when we tested it in the Mount Sinai Health System, it turned out that it didn't perform as well as it did in the data that led to its FDA approval. And this is, so that isn't just specific, I think, to that particular product or disease state. I think there's a larger lesson there. A lot of these FDA-approved algorithms, you can't just take them currently right off the shelf and use them. You have to test them again, calibrate them again in your own healthcare system, which takes time, effort, and money, as a matter of fact. So, I think we have to adopt new things, new technologies as they come.
Yeah, I'm ready here if I can start my lecture.
Okay. So, so that's fantastic. I mean, I think that's a really, really important one. And with that, and I do want to go to you, Dr. Antoniadis, because what you told us a little bit about the plaques makes me very nervous, because many of us are using that calcium score of 0 and telling the patients it's all okay, so your cholesterol is a little bit high.
But I'm lying.
You don't have anything else, we'll wait for it. So I think that's a really big question, and we'll come to it. I see that Dr. Kinney, because she's going to have to jump back into another case. How did your case go, Dr. Kinney? You're going to show that to us later?
Yeah, we are going to show it to you. We've finished
so
there.
let's begin with your lecture, and I think we really are anxiously waiting to hear about how you're using it in interventional cardiology in the next 12 minutes, you said.
Yes.
Dr. Kinney.
Thank you. And now I've listened to all the AI lectures that have happened so far. So my specific topic will be how we are using AI in interventional cardiology, especially here in Mount Sinai. So, are we sharing? Do you see my slides?
Yes, we see your slides. Go right ahead, please.
Okay.
And then we'll bring you
here
into
we are. So I just need to give you an overview what artificial intelligence is, and it's a large umbrella with multiple terms that we have used, and there are subcategories. And you will hear various terms during various talks, especially if it's given by a computer scientist or something. So what we'll see is various kinds of subcategory of AI has been used here in Mount Sinai, and we have done so many of our projects using them. The biggest and the newest that is coming up right now is the agentic AI, and we will talk about that more. So now, what are we doing using is, one is yellow studies and the AI genomics. So yellow one, we use yellow for the last 15 years. We are working on the various studies. And the first one was a yellow one where we used in obstructive coronary lesion with less FFR. We used standard of care with rosuvastatin, showed at 6 to 8 weeks there was a decrease in LCBI. Then in yellow 2, we used imaging, which was both NIRS and the OCT. Again, in obstructive lesion, lipid-rich plaque, what we used this time is to understand cholesterol efflux in patients to see how exactly there is a change in the morphology of these patients. So we definitely showed that by using just rosuvastatin single arm, that in 12 weeks, there was a change in fibrous cap thickness, which correlated with improvement of cholesterol efflux, the way we think the lipid comes out from the plaque. And we used what is called as understanding gene expression, why this happens in patients whose plaque morphology changes, 6 key genes that was associated with cholesterol metabolism and smooth muscle cell we came across. So this one, in 2019, we used what is called as machine learning. The entire gene panel was entered into a machine learning model, and we predicted fibrous cap thickness change to statin therapy based on their baseline genes. LO3, very complex study. Again, patient had to have a lipid-rich plaque. They had statin therapy. Once we knew they had lipid-rich plaque, all of them got avelumab for every 2 weeks for an addition of 26 weeks. When they came back, we repeated the imaging study. So what was important, we did a different kind of genetic transcriptomic analysis, which was a bulk RNA sequencing. If you see here, close to 329 patients screened and 110 patients completed. Very complex trial. So significant decrease in total cholesterol and LDL when they came back. And we know that avelumab does not change CRP. So improvement in fibrous cap thickness when they came back, significant improvement. And a change in LCBI when they came back, which means a decrease in LCBI, which we call this melting butter sign. That is what we see. We then grouped the patient who responded and who did not respond. 80% of the patient responded, what we call increase in fibrous cap thickness, and about 76% of the patient, there was a decrease in LCBI. Look at their LDL level, there in the left corner here, significant decrease in the LDL also. Then there was a group of patients where we saw, despite change in their LDL, so if you take their chemical markers, LDL baseline 78, when they came back, LDL of 7, but no change in fibrous cap, no change in LCBI. We call them as non-responders. Why does this happen? So if we are treating patient just looking at the LDL, is there something we can find with this patient? So always the question is, was a response in total cholesterol and LDL for the treatment was different? No, both of them decreased their LDL, total cholesterol and LDL to the same extent. So this is a heat map which showed there was a significant upregulation of some genes and downregulation of some other genes. Now we see the genes. So if there are genes, what does it we come up with? Means these genes are associated with certain pathways. So what we saw is patients who responded had upregulation of what is called as a mitochondrial translation, crystal formation, protein synthesis, very important for plaque stabilization. And there was downregulation of what is called as mitochondrial dysfunction. Then what we also found is responders, non-responders. We went deep and found out that in responders, again, mitochondrial function improved, non-responders, mitochondrial function did not improve. There was increase in neutrophil degranulation and inflammatory pathway. This is the key, that we used machine learning. The entire gene panel of 38 baseline gene, if you see here, was entered in the machine learning model, and we saw the important gene that we could predict that these people, if they have these baseline genes, they are likely to respond. Their fibrous cap thickness is likely to respond to treatment, which is one of a key finding. The same thing we also found for LCBI reduction, again, a machine learning model with 71 baseline gene. So essentially, what is it? Mitochondrial function improved in responders, and because of various other genetic changes, there was plaque stabilization. So machine learning model can now predict fibrous cap thickness and LCBI response based on their baseline gene. And that is what we are going to focus on yellow for, so we can get to a personalized approach for treating patients with CAD. So going to, how can we use AI in analyzing angiograms and doing reporting? Half our time goes in reading angiograms and doing this. So like I showed you, right? There is various subcategories of AI. Many of the models you do what is called as you give training. Some of the models you don't train. So what we did was, we did annotation. We trained this. This was a part of machine learning where we did 800 angiograms, did that training, and now we can get an automatic report as soon as angiogram is done. We have the software up here. So the question comes is, was your model validated? Yes, we validated our model with the gold standard QCA with excellent intra-class intercorrelation. So it is the key. One, who trains? It has to be the expert in the field, has trained the model, and the model has been validated. Now, what we are doing is, with the same QCA, we are going to bifurcation lesion, understanding bifurcation lesion. We are feeding, how do you treat this particular bifurcation lesion, the step-by-step PCI guide that we are doing. So the next one is, we have multiple, databases. One of them that we did, which we presented actually in EuroPCR, created a model that can be, by using various CT scan, that can we get valve sizing, and we were able to do that with a model that we have created. And this is the future, which is called the learning that we are going to be doing, which will be using an AI agent, but more important is to observe the environment and these changes. Now, let me tell you what is it that we are going to do by using what's called as reinforcement learning. This is coming up, and this will be the future of what we have to do. So multiple places we can be doing reinforcement, which is clinical operation, procedural support. More important is real-time understanding what kind of equipment you need. Right now, I was telling them, give me this, give me that. That is because how my brain is functioning. Question is, can we train the model to say which device you need to use? And hemodynamic monitoring optimization, that can you predict that slow flow is going to happen in this particular vessel? That is what we are working on. And of course, other things, patient encounter and various things will happen. Reinforcement learning is what we are working right now to understand, integrating angiogram. We have our cath report, we have ACC NCDR outcome, and we have our electronic medical record. This is an unsupervised part of AI. We are just going to give all the data and then see what we can find, or can it mimic human brain? Now coming to what is called as the patient encounter, one that we have created in Mount Sinai. So if you see here, Mount Sinai cath lab volume, almost 16,000 patients. Each patient takes about 15 minutes for the phone call. We created what is called as Sophia, who will be the virtual USA pageant with a beautiful Indian face and a Spanish name, Sophia. So listen to her voice.
I am Sophia, a virtual assistant specifically designed to assist patients like you with their cardiac care at Mount Sinai Hospital. My focus is on providing clear, accurate, and helpful information about your procedure, answering your questions, and ensuring you're well prepared.
So, how was Sophia created? When you call agentic AI, multiple agents are created. Each agent knows what topic they need to do, and there are guardrails, which means that Sophia was only made to talk on cath lab procedures. And if somebody asks some other questions not related to the cath lab, she's not going to answer. There's escalation pathway. She'll politely say, a clinical team will call you back. And this is the simple way that you have created. As soon as we have our procedure, Sophia is going to call them. They're going to give logistical questions. There's a portal to understand what is happening with each calls. Then we have already created the regime where if for logistical reason or for clinical reason, the nurse will call back, and this is predefined. Once it is done, nurse will verify, and then that will go into the EMR. This is what the conversation view looks like. Very important. The nurse can quickly go through the conversation. There is an AI call summary. This particular patient was taking blood thinner and wanted to talk to a nurse practitioner, which means a nurse practitioner should call back. And then it is already clarified that the patient said he's taking warfarin. And then what happens is the nurse will do a verification and it will go. So we already tested 90 days, 4,000 minutes of Sophia was done. And which I say that if I had not listened to her for every single minute, could have watched almost 27 Bollywood movies. But what we did was myself and my team reviewed every single call, 806 calls of Sophia, about 588 patient surveys we got. This survey again was IRB approved. Our oldest patient that dealt was 91-year-old. So this is what we found. The biggest thing is adoption of AI by the physicians, adoption of AI by the patients. And what we came to see that yes, everybody is adopting AI. Call completion 86.4%, non-completion 13.6%. The biggest problem everybody thinks is what is the AI system reliability? Biggest problem is hallucination. Like I mentioned, if they don't know the answer, the agent starts making up stories. Absolutely. Hallucination of 806 cases or 6 patients only, which goes to say that if you train the model and you have important guardrails, there will be no hallucination in this agent. So it has to be done well. So then these are our, what I would say is the questionnaire, IRB approved. If you see here is a customer satisfaction score, 8 to 10. Most of the places we got 10. This is the overall score we got from the patient, 94.88%. One of the important testimonial from the patient, extensive experience testing technologies like Mount Sinai Virtual Agent, Sophia. My interaction with Sophia was seamless. She was clear, concise, gave answers in written. Every hospital should have a system like this. What we are trying to say is this is the future. So in every way, she did very well, whether we go to performance, trustworthiness, efficiency, or empathy. So there are a couple of other things that we can talk more on. But now we go to outcomes. As an interventional cardiologist, what people want to do and continue to do is save lives. So what we worked on is creating the app for STEMI, which I showed it in the past. And we know there is only limited improvement that can happen. This is way back from 2010 to 2016. Door in, door out, which should be 45 minutes. But if you see what happens, even to this date, is 58 minutes. This is JAMA Cardiology 2022 publication from American Heart Association in America. Right now, if you see here, the only 25% of the cases of the transfers are meeting less than 120 minutes goal. So there something has to be done. What can we do? Because this is the only place where we know we can save time. So we have been working on this since 2018. The app has been working in various parts of Mount Sinai. Now in 2025, we are going to be using AI. So this is what we want to show. US average time was less than 120 minutes, was about 20 minutes, 20%. We were about 70%, but after using the app, less than 120 minutes. Okay, you did your case in less than 120 minutes. So what? Look at it. Look at our in-hospital STEMI death and compare it to the ACC NCDR. Our death is about 0.3%, whereas for USA is about 2%. So what are we going to do using AI in our version 2 is AI detection by EKG. EMR will provide summary details by this agent. All the various stakeholders will be called by the AI agent Sophia. And more important is it will automatically give you quality metrics. And other thing is you can use this for other disease pathway. So what we think how patient coordination is going to happen, Sophia is the one that is going to be making calls. So the ER physician talking to me, and this is the transfer center ready to send the ambulance. So let's see how it's going to happen. Movie is not playing.
Okay. Dr. Kinney, what happened to you?
No, that
Okay.
was a movie, but somehow
right.
it's not playing. So what is the future directions that using AI here in Mount Sinai? You guys did not? Movie is not playing. Anyway, machine learning to use definitive panel of biomarkers using proteomics, transcriptomics, metabolomics, so that we can do a personalized lipid lowering therapy. Like I showed you, PCI guidance, especially for bifurcation, then we will move on to calcification. That is based on deep learning and computer vision. Then goes AI-rich database, which is a reinforcement learning, which is the key. This is the future, and that's what we want to do. And Sophia, we know we are going to expand it to other use cases. So what does Sophia use? Natural language processing, deep learning, LLMs, and all of the above. Of course, our STEMI app will be the next one. So all of this has come from what we call is a Kinney think tank. The left side, you can see that is the think tank that's happening. And these are my people who are helping me to bring this think tank to the future. Any question, you can email me. That is the AI, Intelligence. Yeah, thank you.
All
I know I
right,
went over.
thank you. Amazing work. Thank you, Dr. Kinney. Not just great in the cath lab, but also in augmented intelligence, et cetera. Congratulations. We are really very, very late. People want to take a break, but we still have 2 lectures to go. I want one short comment from Dr. Antoniadis. You just heard about this AI tools in our cath lab. You saw that there's imaging involved. What is that? What happens? Many of us are score of 0, cholesterol high. What are we supposed to use your technique, or what are we supposed to do?
That's a very
Short answer.
That's a very good question. Calcium score 0 is a good indication that you are very unlikely to have an event imminently. However, there is a 5% event rate over the decade. Getting your calcium score 0 doesn't give you a warranty. You have to measure also inflammation because this happens before
C-reactive
plaque is
protein.
formed, and that's essentially what you need to identify, the inflamed arteries. CRP is not, it's a plasma biomarker, and it doesn't tell you where there's inflammation in the coronary artery. So you have to use a CT to get this information before plaque is formed so that you can prevent plaque formation, not only plaque rupture.
Fantastic. So thank you so much. Dr. Kinney, I'm sorry, any final words because we need to move on. We're literally 30 minutes behind.
Yeah, the new terms, everybody's talking AI, but the prediction I'm telling you is it is not easy to copy the human brain.
Oh, love that. Yes, thank God. Okay, thank you very much. We're gonna move now to our 2 lectures that are, and I promise you I will get you a break and we will have to come back soon because many of our speakers are anxiously awaiting, and of course the cath lab. So let's now move to the drug-coated balloon state-of-the-art ISR and de novo lesions by no other than Dr. Bruno Schleller. Bruno? Are you there? Oh, there you are. Bruno Scheller is here from Germany. We're really, really excited. You are probably one of the pioneers in drug-coated balloon technologies. No one better to talk to us about what's the hype all of a sudden. Dr. Bruno Scheller.
So thank you very much. It's a great pleasure and honor for me to be here. We started our first in-man trial end of the year 2003. This was the time when there were no drug-eluting stents available for clinical use. And at this time, bare metal stent instant restenosis was an unmet clinical need. And we had some animal experience with our self-coated balloons. And with these prototype balloons, we went into a small randomized trial and treated instant restenosis either with conventional balloon angioplasty or with this prototype balloon. And the main finding was that at 6 months, we could reduce late lumen loss from about 0.75 to almost 0. So this means we could see the balloon impact at 6 months again. And this was also clinically efficacious. This is the 6 years follow-up, and you can see that this reduction in target lesion revascularization, which was within the first year, remained almost stable over this long period of time. There were many more smaller trials, especially in Japan, also comparing DCB with POBA in the treatment of instant restenosis with similar results. And recently we had the results of the Agent IDE randomized trial here in the US, also confirming that with the use of a paclitaxel-coated balloon, you can reduce the event rate compared to uncoated balloon angioplasty in the treatment of instant restenosis. However, the more interest was in the comparison of using a second stent, a drug-eluting stent, for the treatment of instant restenosis. And so there were several smaller and mid-sized randomized trials comparing DES and DCB, and those trials were summarized in the patient-level Daedalus meta-analysis. And the main finding of this meta-analysis was that the stent approach is more efficacious in reducing TLR than use of a DCB in a restenotic stent. And this difference, relative difference in TLR rate was about 30% in favor of the stent-in-stent approach. On the other hand, especially if you look at the treatment of drug-eluting stent restenosis, there were some signs that this use of a balloon instead of a second layer of metal could potentially be beneficial for hard clinical endpoints like death and myocardial infarction. If we look more in detail to find an explanation for this reduced efficacy of DCB, we can look, for example, at the ESA Desire 3 trial, which was the largest trial including in Daedalus. And if you look at those patients with failure of the treatment, we see in both balloon groups for the PROBA group and the DCB group that more than 3/4 of all lesions underwent additional treatment, whereas in the lesions treated with a second layer of metal, only half of these lesions underwent additional treatment. So this means there seems to be a different perceptions what to do in case of failure of the therapy, and this amplifies the clinical difference in TLR between the two treatment modalities. Those initial trials that were part of the data loss analysis were done without clear rules for lesion preparation. We had no idea at this time that lesion preparation is essential for DCB treatment. And here we see an analysis from Korea looking at the treatment of instant restenosis with DCB, and they looked at quality criteria. And one was a residual stenosis of maximum 20%, the other one was an adequate sizing, a 1-to-1 balloon to stent ratio, and the inflation time of the balloon. And if you fulfill those quality criteria, you have a target lesion failure rate below 10%. If you do not fulfill any of these criteria, you're in the range of 66%. So this clearly shows that there's an urgent need for qualitative, high-quality lesion preparation. And if you compare, for example, the ISAIA 3 trial, which was part of Daedalus, with the agent IDE trial, then you see that 19% of the lesions in the ISAIA 3 had no predilatation at all. And those patients undergoing predilatation had no clear rules how to do a proper lesion preparation. There was also no intravascular imaging in these trials. For agent, for example, a successful lesion preparation was one of the inclusion criteria. And we had a relatively high rate of intravascular imaging also in this trial, 74%. So our practice is still what we proposed in this editorial several years ago, that you have first to define the mechanism of your instant restenosis by intravascular imaging. You have to do a proper lesion preparation, and if you fulfill the quality criteria, which is the absence of flow-limiting dissections and a reasonable diameter stenosis, then the recommendation is still to use the DCB first. Otherwise, you should use a drug-eluting stent, despite the fact that we have different recommendations in the guidelines at this time. Now, let's talk about the treatment of de novo lesions with drug-coated balloons. You know that beyond the first year, we have, with permanent implants, device-related event rate in the range of 2 to 3% per year, and this is, seems to be independent from the technology. And the recommendation for using DCB in de novo disease is called DCB only, and the focus is not on the DCB, the focus is on lesion preparation. You've seen this before, this slide in other presentations. And the goal is to do the best you can with lesion preparation and to reach an acceptable angiographic result, not a stent-like result. And acceptable means that there are no flow-limiting dissections, and you should be below 30% residual stenosis, but this is eyeballing, this is not by QCA or intravascular imaging. And this approach is safe. We looked, for example, in the Basket Small 2 trial, in the angiographic sub-study, there was no single occluded artery in DCB treated segments, but we have a reasonable amount of totally occluded stents at follow-up. And how can you do this lesion preparation? Here you can see this long lesion in the mid-LAD, which was pre-dilated with semi-compliant balloons. And what you can see here is a long dissection, high-grade residual stenosis in the distal part. This is clearly not the case for DCB. This should be stented. But we have learned, meanwhile, that we have additional tools in lesion preparation. In this case, for example, I used multiple long inflations with scoring balloons. And on the right, you can see that the dissection has improved and also the lumen has improved. And this fulfills now the criteria for the use of a DCB. And we treated it with 2 paclitaxel-coated balloons, in total 5 centimeters of length, and no implantation of the stent. What do we gain if you do not implant stents? We gain late lumen enlargement. This means you can accept a non-stent-like result at the index procedure, but you can see an improvement in lumen over time, typically starting at 4 months after the procedure. And we also learned recently that we can improve our outcomes when using intravascular imaging. And here the goal is to have an adequate one-to-one sizing. When you do angiography-based interventions, you frequently underestimate the real size of your artery. And we have also learned that dissections are not the enemy of our interventions, they help us. This is, for example, an analysis from the Transform-1 trial, where a sirolimus-coated balloon was compared with paclitaxel-coated balloon, and at least for the paclitaxel-coated balloon, we see a reduction of late lumen loss with increasing dissection volume. And this has also been confirmed by other papers here. For example, this Japanese group looked at the existence of medial dissections and the calcification, and the best outcomes were in those patients with the presence of a medial dissection and calcium arc of less than 118 degrees. So dissections are not the enemy, they are part of the DCB treatment. And this leads us to a new axiom in vascular treatment. In older PTCA times, it was clear the more you gain, the more you lose, because the injury creates more late lumen loss. And with DCB, we see with a higher dissection grade optimized to the real size of the artery, we can have a reduction in late lumen loss. Furthermore, we see some kind of local regression of arteriosclerosis, which has been shown in many series meanwhile, and we see some anti-inflammatory effect with the drug-coated balloon. Furthermore, we regain vasomotion, not only in the treated area, but also in the distal part. So what are the indications? Non-complex coronary artery disease is where stents perform the best, and therefore it makes not that much sense to use a DCB in this. We have seen the results of the RECADE-3 trial in the morning. The difference was in the non-small vessels. However, if you look on more complex lesions in this trial, the benefit of the DS over the DCB has disappeared, especially in small vessels. And we looked at the randomized trials comparing DCB and drug-eluting stents in small vessel disease here in the patient-level Andromeda study, which was recently published in the European Heart Journal. And we see at 3 years a significant lower MACE rate with the DCB approach compared to the drug-eluting stent approach, and no difference in target lesion failure. Another patient population at risk in the DS are the patients with diabetes mellitus. And here, the subgroup analysis from BASKET 2, where the highest event rate was in the diabetic patients treated with DES, whereas all other groups had similar lower event rates. And here we have a study label meta-analysis recently published looking at all-cause mortality at 2 years in those randomized trials. And here again, they report a lower mortality in those patients treated with DCB compared to DES. We have some data supporting the use in high bleeding risk patients, independent of the vessel size. And what's more interesting is this hybrid approach when treating multi-vessel disease, complex disease, is the combination of a DCB with DES to limit the number of stents and to reduce the length of stents. And this is data from Korea showing that there should be a benefit of such a combined approach. It is important to have high-quality clinical research in the future, and this is one of the goals of the ARC DCB consensus paper, which has been published recently. And my conclusion is that for the treatment of instant restenosis, we can avoid another layer of metal. DCB is superior to POBA, but it is inferior to DS in terms of target lesion revascularization. However, this is based on trials not focusing on lesion preparation, and we have to look in future on the impact of advanced lesion preparation and intravascular imaging in this situation. My best strategy, our strategy, is to reduce the number of stents we implant, and this means less ISR. In de novo disease, DES and DCB are complementary. DES do the very best in non-complex CAD. So we shouldn't challenge this indication. The place for DCB is in more complex diseased areas, and we have to take care on lesion preparation, and we gain late limb enlargement, potentially local regression of atherosclerosis, and we regain vasomotion. And future trial designs, in my opinion, should not be device versus device, but more strategic trials, a pure drug-eluting stent approach versus a combination of DCB and DS. Thank you very much.
Thank you. Fantastic. Thank you so much, Professor Scheller. It was fantastic to hear you talk about this. And at last but not least, before our long-awaited break, is calcific modification strategies. We saw two very complex cases. This is what we're seeing in many, many cath labs. And the modification strategies are fantastic and have really, really helped us in achieving successful outcomes in calcific lesions. No other than Davide Capodanno, who's professor of cardiology and head of the cath lab over at in Catania, a fantastic educator, but also editor-in-chief of Eurointervention. We are so pleased and so honored to have you with us again, Professor Capodanno.
Thank you so much for the very kind introduction. So my talk is calcific modification strategy, and this is my disclosure. So why calcium matters? First of all, because it's very common. Today it's 100%, but normally it's 20 to 30% of the contemporary patients who undergo invasive coronary angiography and need some kind of debulking. And also because it has an impact on the procedural success, on the prognosis of our patients, because of course, as you may understand, it leads to stent under expansion, it leads to some complications such as dissections, perforations, and ultimately higher rates of target lesion revascularization and MACE. This is how the calcification will look like. The same patient, actually these are arterial artery in the limbs, but I think these are nice illustrations of the deep calcium that you may see sometimes, OFDI on the left, IVUS on the right. And you see on the OFDI that this calcification is circumferential and it's deep in the media. And at IVUS, the same patient will look like a patient with high echoic signal and strong acoustic shadows. Of course, you may have also superficial calcium that we typically call intimal or luminal calcium. Here you have a calcification with a clear border, in this picture particularly on the luminal side, and at IVUS this will look like an high echoic signal with a strong acoustic shadow. One of the particular types of intimal calcification is the calcified nodule. At the OFDI, in this case, you see an irregular protruded mass with an attenuation signal in contact with this large bulky calcification. At IVUS, it's more complex to see, but essentially it's again a protrusion and an irregular mass with a high acoustic shadow. So IVUS and OCT, of course, intracoronary imaging techniques are very useful to detect calcification, but we do not have to forget, of course, CCTA and invasive coronary angiography itself, particularly for the global assessment of calcium in our patients. And of course, CCTA does less well in terms of volume calcification, quantification, as well as in the quantification of the calcium arc, the calcium thickness, and the longitudinal length. This is something you do much better with intracoronary imaging, particularly with the OCT. IVUS is not so good as OCT in detecting the thickness of calcium and quantifying it, as we have listened. Recently, we have seen this data that have been mentioned during the live case in the European Heart Journal, a sub-analysis of the Illumian 4. So essentially, in the two groups of patients with moderate or severe calcification and those with no or mild calcification, the results of OCT versus angiography had a statistical interaction. So essentially, OCT was better than angiography in reducing target vessel failure at 2 years, only in the group of patients with moderate severe calcification. Of course, there is a lot of confounding here, but it makes a lot of sense, of course. So imaging is particularly helpful in this setting. But we have to discuss dedicated devices, and I think we have to start with the balloons. We have standard balloons, we have specialty balloons. Standard balloons in this setting are the high and super high pressure non-compliant balloons, which have high strength and radial force. The specialty balloons, cutting balloon, scoring balloons, have blades, and these elements are embedded, and they concentrate the force locally and focally. So they are quite superior in superficial calcium. The standard balloon has some effect on the superficial calcium and are quite limited in the deep or nodular calcium as well. And of course, there are differences in terms of the risk of dissection and of course the deliverability. When we compare this kind of balloons head-to-head, we have some data that comes from the COPS trial, for example. The minimal stent area, which was the primary endpoint in this small study of 100 patients with more than 100 degrees of calcium by IVUS, shows that the cutting balloon was better than the non-compliant balloon with a P of superiority of 0.035. However, when you look at another study, which is the ISER calc, you don't see this benefit. When you compare super high pressure balloon, the OPN, versus the scoring balloon, there is essentially no difference in this small study of 74 patients with severely calcified lesions after unsuccessful lesion preparation. So the jury's out. Is not very clear whether one is prevailing over the other. Talking about atherectomy techniques, rotational and orbital, of course, the mechanism is a bit different. The rotating bar for rotational atherectomy, the eccentric crown for the orbital atherectomy. In terms of the calcium, you are able to ablate, essentially it's superficial for the rotational atherectomy, superficial to moderate in case you use the orbital atherectomy. And there are some differences again in terms of crossability, and the learning curve that is required by both is quite moderate, I would say. There are some trials of rotablator. I think the two most relevant are Rotaxus and Prepare Calc. Rotaxus had the primary endpoint of late luminal loss at 9 months, and it was better with the rotablator as compared with the no use of rotational atherectomy. In Prepare Calc, one of the co-primary endpoints was strategy success, which was better with rotational atherectomy as compared with specialty balloons. So there are some data that back up the use of rotational atherectomy, although of course these are small studies. And when you compare the rotational atherectomy with the orbital atherectomy, you find this small study that comes from Japan. The primary endpoint was a stent expansion by OCT in 100 patients with calcified lesions or angiographically moderate to severe calcification, and it seems that rotational atherectomy was better than orbital atherectomy in this head-to-head comparison. So this is one of the reasons why maybe the ECLIPSE study didn't meet the primary endpoint. You see that the rotational atherectomy apparently was better. And we have seen these disappointing results of ECLIPSE, where the primary endpoint of target vessel failure in this very large study of more than 2,000 patients with severely calcified lesions amenable to both procedures, there was no difference in terms of the primary endpoint between orbital atherectomy and balloon angioplasty, and there was also no increase in the minimal stent area. So ECLIPSE in brief tell us a story which I think is relevant. Remember that the patients who were included in this study were amenable to both options. So these were not the patients that were only intended for a rotational atherectomy. There are patients that we will continue to use orbital atherectomy or rotational atherectomy, and they are not candidate for ballooning. So atherectomy in this case increased procedural complexity without improving outcomes in most severely calcified but balloon dilatable lesions. So if you can use a balloon, use a balloon. And it's also relevant that in this study there was a very low crossover rate, 4.9% to atherectomy or lithotripsy, which suggests that balloon-based preparation was sufficient in most of the cases, if not all of them. So finally, lithotripsy and laser. I think this is also quite relevant. I would say other modification devices. The mechanism for lithotripsy, sonic pressure waves; for laser, UV laser. The calcium type that is ablated or eliminated is superficial and deep. For lithotripsy, it's mostly superficial for the laser. I would say that the deliverability is an issue here because for lithotripsy it's balloon-based, so it's moderate. For laser, it's excellent with small catheter profile. And of course, there is an issue of learning curve here as well, and also a different risk profile. This study that we have seen at the very beginning is comparing the three techniques. It's called the roller coaster EPIC 22. Intravascular lithotripsy was similar to rotational atherectomy in terms of stent expansion by OCT, while ELCA, excimer laser atherectomy, was inferior in terms of stent expansion. So there is a kind of gradient in what you can achieve with these techniques. So finally, I would like to show the algorithm approach that perhaps you may keep in mind when it comes to selecting this technique, because there are many, and therefore they can generate some level of confusion. So I think the starting point is angiography, where you see moderate to severe calcification, like in this picture, and then you do intravascular imaging, or you try to do it. And of course, you may have these four situations: deep calcium, you may have superficial calcium, you may have a nodular calcium, or the device doesn't cross, which is something that may happen as well. So if the device doesn't cross, then this is the space for rotational atherectomy or orbital atherectomy in this order, and this is followed, if you have it, also by ELCA. If there is nodular calcium, then IVL is the way to go, followed by orbital atherectomy in preference to rotational atherectomy. In case of deep calcium, this is a good space to start with the non-compliant or specialty balloons, followed by intravascular lithotripsy. And in case of superficial calcium, then the next logical question is whether there are iris features. In particular, you can use these scores, the OCT score or the IVUS score with different rules. I will not go into the detail, but OCT score of 3 or IVUS score of 2 or more identify the high-risk characteristics in those who have a superficial calcium. So in case of yes, you go for intravascular lithotripsy. If there are no high-risk features, you go and you start with the balloons. Of course, please keep in mind the combination therapy. You can also combine these strategies, but this would deserve another, of course, talk by itself. So if you achieve a full non-compliant balloon expansion after all these techniques of debulking, calcium fracture or nodular debulking on OCT or IVUS, of course, you can implant the DS. In case that this is not achieved, then you can start again with this sequence of IVL, OPN, rotational atherectomy, orbital atherectomy. If you implanted the drug-eluting stent, of course, it's important to post-dilate and then do again intravascular imaging in order to see whether there is underexpansion. And in case of underexpansion, again, IVL, OPN, and rotational and orbital atherectomy. So in conclusion, I would say that calcified lesions are among the most challenging patient subsets for PCI. There is robust evidence for the available calcium modification tools. No, because it's definitely limited. And the ECLIPSE trial is probably the main exception because it was a large study, but we have seen the results. In stable patients with calcified lesions, medical therapy is often preferred, so we have also to remember that there is this option, and surgery may suit young patients with multivessel disease and calcified arteries. PCI is feasible in selected cases with careful planning, as we have seen, with data integration, and of course with the expert use of the available devices. Thank you.
Wow. Who could do that better than Professor Capodanno? Thank you very much. Guess what, guys? We get a break, but 10 minutes, I need you back here. We're going to do a live case, then we're going to do the ACS guidelines. You don't want to miss that. Then we do case 4 and 5, then an amazing lunch. So 10 minutes. It is now 11:35. I want everyone back here by 11:45. Thank you.
check, check. Going. Ouais. Ouais, j'aurais dû le muter dans le fond, c'est 48 volts. Ouais, ok, merci.
everybody back in the room. We got to get started. We're going to go straight to the live case presentation number 3. If I can invite Dr. Bhatt, Dr. Capodanno, Dr. Lasala, Dr. Rao, Dr. Reitman, Dr. Scheller, and Dr. Sanjeev Sharma up here. We're in the lab with Dr. Kinney and Dr. Sweeney. You're live.
Yeah, case number 3. We have a 63-year-old female. You see that? So she had angina class 3 and a positive stress test. Significant risk factors. So what happened is she did echo showed EF of 60%. Significant disease. So if you see, she had an angiogram which had shown left main and 3 vessel disease. So was referred for bypass surgery. Again, now you guys may think, where are we getting all these cases? We do have a good heart team discussion. So when we have the criteria as per our OC criteria, appropriateness criteria, all that we do call the surgeon. Most of the time we take them out of the room and then they will be seen in the office, or sometime if it's really acute, they'll be in the holding area. That's where they're going to see her. So she was seen by one of our surgeons. Surgeon was still okay to do it, but patient absolutely refused having that. She did not want to have a surgery done. And then I think what also happened is she went for a second opinion and Joe saw her in the clinic.
Yes, I saw her in the clinic.
Hi, Joe.
Discussed with her, reviewed her angiogram. Hi, Roxana. Diabetic 3-vessel disease, including left main. Obviously, the ideal strategy would be a surgical revascularization, but she was very adamant that she did not want it.
And give me a little bit about her body habitus. So morbid obesity, BMI 46. I'm sure the surgeons are a little bit reluctant with that kind of with the chest situation. Was that one of the things that she was worried about?
Well, it was some trepidation with that, but they still felt they could probably get through that. But it was more really her unwillingness to proceed.
Okay. So show us the anatomy. We see a good LV function.
So normal, good LV function. Earlier you saw the first time round with a decreased LV function, complex disease. We decided we wanted to use in the first and second case. So this is RCA. Again, typical diabetic, right? Proximal is a moderate disease, but calcified, significant disease of the distal RCA. But look at her left system.
Oh.
So you have distal left main, calcified LAD, and maybe mild calcium angiographically of the ostial circumflex. Both are large vessels, okay? Look at the D1, diffuse disease, moderate size. So if you are saying anyone that should go for bypass should be her. Now, one thing the surgeon may say, but look at her distal LAD as significant disease. So many times they do double, in the sense they may put LIMA mid to distal, then they'll put a vein, or some of them will do endarterectomy, vein patch, and then connect something, because something had to be done to the distal LAD. So
yeah, I mean, it's not the best distal LAD, target there. Literally very diffusely diseased, and in fact, it would not be the best target. So I'm less worried about this now. I know that it's in your hands.
But let's decide beforehand, because we already learned our lesson in the first case where we went behind that Diag, which actually gave us a lot of trouble, which I'm going to show at some stage, that Diag.
So this is definitely without protection, is that correct? This is not something you didn't even contemplate protection here, and I think no one here on this. So obviously, just tell us, you're gonna wire both circ and LAD and then image first. What is your plan?
No. So here, let us tell you something. Look at this, 95% almost subtotal circumflex. So we will wire, and like we said, angiographically, most of the calcium is left main to LAD, possible circumflex. So we have to work on circumflex first. We decided we'll do atherectomy of the circumflex first, and then we will wire both. Once we wire both, then we will do the imaging of the LAD, because we think LAD can be managed with IVL.
I see. Okay.
That's one. Going back to your question, let me just confirm,
let me get some insights as you're wiring. We're going to watch your beautiful wiring, but at the same time, maybe we can hear John LaSala. How would you approach this?
Yeah, I think you've got enough calcium there to use all the strategies that have been mentioned. You know, atherectomy, certainly, IVL, I think that's a great strategy for the left main LED component. I don't know this is completely off because we're just looking at the angio, but there's not as much calcium at the ostium or the circumflex.
Right.
So you may not have to do like an IVL there, but just a rota balloon, NC balloon or specialty balloon. I think you should be able to get by with that. I agree with Dr. Keeney's strategy.
Sunil Rao?
Yeah, I mean, I think I agree with John and Dr. Kinney's strategy here. And I think I would probably just try to use a regular balloon for that circumflex and see if you can get it to crack. There might be a calcified nodule there just approximately the distal part of the left main, and I think IVL is a great strategy for the LED here. And then you'll have to decide what bifurcation strategy to use, and I suspect that, you know, this is, most of us would probably agree it's a two-stent strategy, and I'd probably just DK crush this.
Sanjeev Sharma?
Yeah, first is rotational atherectomy from left main to circumflex, and then wire both the vessels and image both of them, and then decide about the LED.
Yeah. I wonder, like, why didn't anyone say, why don't we image the IVUS, first? Davide, what do you think?
Yeah, especially
because we don't know if we need to do.
I mean, if the catheter doesn't cross, it's already the information. No? So I would start with the IVUS or a balloon.
Deepak?
Yeah, I like Davide's approach. I think I would also try to pass the IVUS catheter if it doesn't predilate. I think IVL is a great strategy here. I think Sunil's right, a two-stent strategy would be the way to go. I'd plan that up front. Maybe because I'm sitting next to Sunil, I'd also think, radial, even though it is a complex PCI.
At last but not least, Bruno.
Yeah, maybe for the strategy, depending on the outcome of the lesion prep, for me this would be a typical hybrid approach in this situation. So the stand from the left main either to the LED and then DCB circ, or stand to the circ and then do the LED ostium by DCB. It simplifies those procedures very much.
Yeah, so that's when that's a really good European approach with regard to hybrid approach for a bifurcation using DCB, except our DCBs are locked up at $6,000 a piece. So, and we don't have the data yet on de novo lesions, so that would not be, I don't think that's going to be the strategy here. So Dr. Kinney, where are you? You already did everything? Because I know.
No, we changed to rotawire. One other thing I needed to tell you, why? But this is a complex left main procedure with RCA involvement. If someone says, I want a balloon pump used in this case, that's okay, that's maybe a right thing to do, because if there is any vessel closure, slow flow, anything that happens, it's a catastrophe. But knowing this patient with her obesity, that was not an option here.
Yeah, I wouldn't.
Yes,
I wouldn't
radial fanatics will want to do this radial, but I'm still a believer.
I think her IABP and protection is you as the operator. So let's go. All right.
I think another good point to mention here, as Dr. Keeney's pointed out, is focus on the main things. I mean, you have a lot of disease here. You're not going to make this look perfect. You're not going to do that distal right. You're not going to do that distal LED, which is a 90% lesion. You may not do that diagonal. We'll see what the approach is there. But get the main things, the ones that are making this patient symptomatic, done first, and worry about the rest at a much later date.
Yeah, that's good.
Okay, good.
So what, the size of the burr is 1.5? Do I?
Yeah, 1.5. Everything went smooth, so we decided 1.5. So now the various strategies have discussed. Since the vessel that is tightest is a circumflex, right? So definitely have to take care of that first before you do anything. And in a vessel like this, trying to even image or do something can give rise to, vessel closure, slow flow. So let us get at least this tightest lesion under control, and then we can image. So we're going to start burring. We did our 3 steps.
Watch that distal wire all squiggled up down below. You might
pull back the wire a little bit. So the couple of steps here, you see that?
Yeah.
Circumflex, left main to circumflex is Achilles heel always for Now look at that. Her, heart rate.
I-
Can we?
I see
okay,
that
you're
there's
seeing it.
a-
Heart
you
rate
might
went
need a
down. Little
pacing.
ST depressions. Yeah.
You might need a
good.
pacing wire, no?
We have
A
one.
young lady. You pull the wire back a little bit more.
Yeah.
So we did not use the pacer. Oh, okay. Okay, we're going to come back. Up. Ready?
Go.
Give me a run through wire quickly.
Watch the
Fielder and
wire.
Run through.
Don't lose the wire.
Go.
You want to go?
Yeah.
No. What's that?
Yeah, I think it's important to point out too, while we're talking about pacing in the setting of rotablator, obviously right coronaries, we used to do all of those. Now we almost never do it unless the patient goes right into it right away. We can get by. Aminophylline still works for that, 300 milligram bolus. But you can still get the need for pacing with rotablator in very proximal circs, left mains, and when your bird artery ratio is relatively large, like it's getting up to 0.5.
Yeah. What I saw here when the bird jumps like that, you wonder how much ablation did you actually achieve. But we'll see now with your IVUS, I guess, or if you're going to do IVUS.
It is, no, more important is what you worry here, which did not happen, which is good. It looks the same. Otherwise, you will see the artery that is 3O becomes a 6O.
Yeah, well, no, we
Let
don't
us
want
just,
that.
now we are going to wire the LED. I was ready. And then we will get a fielder into the, and go as planned.
Sounds
So
good.
this is LED. So what we do, a plan is that we are not going to go to the distal area of the LED. So let us leave the wire in the mid LED. Hopefully we'll be able to get our procedure done.
So this was a relatively
And
discrete
fielder.
circ, and so it went through pretty quick. But the nice thing is you've debulked it enough so that you don't have as much plaque shifting and things going on when you try to work on the bifurcation.
Now, the way this behaved, if someone told me that they would wanted to do, means I agree with what John LaSala mentioned, that there was not a lot of calcium in the circumflex. Maybe we could have just done, atherectomy or IVL to the both branches.
I
right?
really would like you to also IVUS the circ too, right? You're planning
Okay.
for that
No,
too.
no, we are going to do that.
You want to do
Yeah,
circ first?
Let us
I
do
feel
that.
like you're going to
Now,
learn a lot.
we have an algorithm for management of calcific lesion. There are two algorithms. I'm telling my staff there. Andrew, the algorithm for management of calcific lesion.
Yeah.
So you're going to the LED?
We've got it.
LED.
We've got it. It's
Okay.
here. It's up and it's for the education.
So first and foremost, that if we think the IVUS catheter, imaging catheter does not go, then you got to do upfront. Okay, good. Where is,
Yep, right
okay, we are there.
Okay.
We will go with upfront atherectomy,
Ready,
whether
correct.
it is rotational atherectomy or vital
show the IVUS on
atherectomy,
the
whatever
screen?
people are comfortable
Can you
with.
show us the IVUS, please? We don't see the IVUS image.
IVUS, good.
Okay.
Okay, pull back.
Okay, start full back. It's coming.
And you
Eccentric
tell
plug
them what
here.
to pull back.
It's coming. Eccentric calcium here. Once open, ostium, left main, stop it. Stop.
Looks like we don't even need IVL.
So,
Huh?
I show you. So,
So
Let's
then,
see.
once you image, you see that we have to understand whether it is superficial calcium or deep calcium.
yeah, so,
So if it is deep calcium and your, like you see where our LED is, it is not tight. Those are the kind of cases you could probably do with high pressure balloon, opium balloon, cutting balloon. You don't need atherectomy. It's only the superficial calcium. Then you use your, calcium scoring using either IVUS or OCT.
this is
Now-
the osteo LED.
now show us the circ.
focal-
Go ahead. Sorry, go ahead.
Yeah, osteo LED has a 270 focal calcium.
Yeah.
And
I see
once
that.
calcium is gone, but Prox LED also has some 180 eccentric calcium. So 2 tandem calcified lesion.
Okay, let me go back, ostial LED.
Yeah, so this is the osteo LED. We see the circ wire from the 10 o'clock.
Okay, left main, show me left main.
Yeah, now come a little bit back. So this is a distal left main.
Okay.
Lumen is like okay.
Yeah.
But some plaque here, and not much calcium here.
Okay.
Left main.
So left main is how much? So
Area,
distal left main, your cutoff is about 7, and we are getting
Distal left main,
like
there is
what,
that
4.8,
focal
5.8.
area. There's a little
Yeah,
bit of a
5.8.
focal area of more than 270. I caught my eye there. So
No,
who
that's,
would do
not,
any more atherectomy here? Sunil, you see the IVUS?
I would just use a.
You would go with balloon?
Just balloon.
John?
Okay, now go to the Austrial LED.
sure.
3.2.
Yeah, once you get up to over 2 there, you don't really need atherectomy.
You
at
don't
that
need
point.
atherectomy.
Unless you had
Anyone
really
here
severe
would do
wire
any
loss.
further
Scoring or cutting balloon for the Australian.
scoring or for the, Bruno?
Yeah, me too.
You want to see some scoring. They want to do something a little bit more, but not specifically calcium modification, maybe a scoring balloon or something in that osteal LAD. What do you think? What's your strategy?
I
Dr.
need,
King?
no, I'm just making sure that is what we have to do. So show me again, is there anywhere? So it is 180. So same thing, if you are more than 3 quadrants, so this is superficial calcium, 2 quadrants for sure. Am I seeing 3 quadrants anywhere?
Yeah.
Is key.
Yeah.
Because the decision is, are we going to use cutting balloon or do we need to do IVL?
Yeah.
Oh, right there.
For first IVUS, so we cannot see the thickness, but the longitudinal length is less than 5. It's a focal by B180, by B270. That's the osteal LED.
So you see here, close to, 3 quadrants for sure, maybe 4 quadrants, that's what you are seeing it. But what Kiski is telling, remember we need the length also. We cannot get the thickness based on the IVUS. You need OCT for that. So you have more than 3 quadrants, which is one, and then based on the IVUS, and other one is, we think it's less than 5 millimeters. So let us go for a cutting balloon.
Well, let's hear, John, what would you do?
What do you think, Kiski?
John is
Chris,
sort of
you try.
shaking his head.
If the
John?
cutting balloon doesn't work, you can go then step up the IVL. So.
John?
I tend to favor IVL in these. I mean, I realize you can't get the depth here,
This
but
guy,
you
we're
have
gonna
a
image the
length and
circ.
you have the circumferential calcium, so that you'd like to get as many fractures as possible, and I think IVL gives you that.
You want a 3.25?
Okay, let's go IVL then.
Well, what do
You
you?
have 3.5 then, IVL?
3.5 IVL.
Yeah. Vessel size is definitely.
Okay. 3.5. Get
Sunil?
open IVL.
Sunil?
Like I said, I'm old school. I just use an NC balloon here. I mean, it's $80 versus $4,700. I don't know. I tried an NC balloon. If that didn't work, then I think you can pull the IVL out.
Davide Capodanno,
Okay,
you
go.
just told us about calcium modification therapies.
Go
What
ahead,
would you
Kiski.
do here now?
Yeah, check the
My
image.
first guess was for the angiosculpt.
Angiosculpt, okay.
Can you show the iris? Okay,
Go.
start to back.
This is the circumflex.
Circumflex.
It's coming.
Let's see if there's any calcium there.
Yeah.
A little bit.
Yeah. Look very similar.
That's left.
Yeah,
Good.
It's pretty.
Show the osteal
done.
circumflex.
Osteal
Yep, I'll show
circ
you.
looks like you broke up some calcium there.
Yeah. We did.
So this is
We
the distal left
definitely
main.
needed rotational atherectomy.
This
there.
is so
See that?
it's actually osteal
Yeah.
circ.
Okay.
But
So
if you don't use
it
all
is-
the energy on the LAD, if you're using IVL, can you use it in the circ too? Save some of the energy for the circ also. So
Okay.
Sunil doesn't get upset that we wasted so much money.
I'd probably start with the circ, actually, because I think once you deploy it, it's going to be very difficult to deliver across
Yeah.
the circ.
Okay, so.
Okay, show us. Do you need it may not, I don't know whether it will go.
So,
You know what? At least we did rota of the circumflex.
Yep.
Let's go with what we planned. Do the IVL of the LAD. If it does not go to the circ, that's okay. What do you think, Kiski? Go back to the osteal circ?
I
so
just
it's
don't
again,
think,
there is a
I'm
270
hoping you
calcium, but
could
it's very
save
focal.
some of the energy for the circ too.
No,
If you
we
can.
will. But the thing is, the balloon will go to the circumflex. That's why he's trying to tell you that go to the circumflex first.
Yeah,
No, what happened? Opened? Want to try circ first?
Yep.
Huh? Circ or LAD?
Yeah.
The
I think we
issue
do the
comes up
circ
about the
first.
sizing of the two vessels, if there's a disparity between the two, and you're going to use the same balloon for each one, always choose the larger one. The reason being is that you don't really have to be one-to-one.
We are using 3.5 to circ. Is it too big?
Yeah, you can.
We can, okay.
So you can
So
use the
what we have
3.5
seen
even though it's a
actually in
3.
at least 4 to 5 live cases that we have done to India, that when the calcium is not 3, if it's half quadrant only, that is 2 quadrants, 180 degree, and we have done IVL, we have seen a lot of hematomas.
Yeah, as I was saying, let's say, for instance, you had a 375 LED and a 3.5 circ. You could put put a 4.0 in there, because you're only going to 4 atmospheres. This is not going to be a pressure-related dissection there.
Okay, go.
This is the sonic pressure waves are going to be the same regardless of the size of the balloon.
Going up to 4 atmospheres.
We have seen the hematomas, we have seen contained perforations. Okay, ready? 4 atmospheres.
You can show Andrew.
Down. Okay, go once more.
We
are going with the suggestion. We went to circ first.
Can we see the angiogram? Yeah, there we go.
Yeah. Now it's not making the turn further down, but that's okay. Down. Okay.
I know with the hematomas that you mentioned, has that been with one-to-one sizing of the IVL or with even
no? What
less?
My concern is if you see what the IFU and what the company says that even if it is 2-quadrant calcium, the so-called normal vessel will not be affected by the ultrasound waves. But that's not we have seen. So if you have 3 quadrants, 4 quadrants, good, excellent. That what I think is even the uncalcified or the opposite wall can get damaged.
Yeah.
But have you seen that even if you, let's say it's a 4-millimeter vessel, but only use a 3.5-millimeter IVL, have you still seen that type of hematoma?
No, because we go with when we are using IVL, one place I would definitely do is we always image and we go 1-to-1 vessel size. So definitely it's 1-to-1 vessel size. Go up. And it's only 4 atmosphere. Like here, even here, we are just about 4.
So I'm sitting at 4 atmospheres delivering 10 pulses.
Yeah, obviously it's supposed to be 1-to-1, but you can get by if the balloon is a little bit larger because it's such low pressure.
Yeah. So I get your point, Deepak, that if it is a smaller vessel, that maybe you may not be able to. But if you are not 1-to-1, then I think the fact that you have to do calcium modification, it may not work. You definitely need the balloon size 1-to-1 when you're doing IVL.
No, I agree, but if you're
So how many left? Yeah.
So I think
4
if you're
left.
doing roto first, that sort of changes that equation a little bit.
Okay, ready?
If you look at the registry data for IVL,
Right.
there were perforations, but they're not related to the balloon component of it with the IVL. It's the post-procedure, post-IVL. Whether it's stenting, high-pressure balloon inflations in a calcified milieu, those are the ones that can perforate, and I certainly have seen a couple of those.
That's
That's a good point.
So what's the balloon for the circ? We said 3.0?
We have a 3.0. 3.0 15 as a.
It's bigger, no? 3.5. Okay, give me we're going to the IVL to the LED now.
Yep.
Okay.
And I know what Roxana is going to say. Image again.
Yeah, but next time, please tell Dr. Sharma we want to see some OCT.
Okay. We have OCTs.
Appropriate, obviously, and we don't want it on
Yeah, appropriate
severe
cases.
CKD patients or stuff like that, but.
Okay, this is another thing I have seen.
Joined.
Yeah. Now, see, already. Does not go.
Well,
It's not the first time, it's happened to me many times. Now we are stuck with no IVL.
okay,
Yes,
maybe you
connect.
just do a little pre-dill and then go.
Okay,
Get a 3.0 15 high.
high pressure balloon.
Yeah, the message here, if you have any difficulty crossing, you
Yeah.
don't start with an IVL. You gotta, don't frustrate yourself.
Don't frustrate it, yeah.
Do a prep first.
No,
Save-
this could be since it was used already in the circumflex. So that is
Yeah.
why
Right.
I was
And it's not
very
surprising because it
concerned.
was used already and it's really calcific there, so let's just use the balloon.
No,
and
hold
I'm
on,
sure
hold on.
it'll go.
Oh, we could
and
have used a
should
cutter.
definitely use it because we've got it open.
We have it.
You have a
Yeah,
cutter?
the analogy is if you've done balloon angioplasty in the early 90s.
I think a 3.0.
Hold on.
Hold on, don't open it.
Okay, I don't know, 3 to 5 cutter.
325.
Okay, we'll do a cutting balloon because that was what the suggestion by many people also for the LED based on the Let's do a cutting balloon and let's see if the IVL will go, otherwise we just stent it. Same, I think left main disease, large vessel, significant stenosis, like the discussion happened until we have data on large vessel and DES, drug-coated balloon.
I see EKG changes there.
Yes, EKG changes
Calcification.
has been there, consistent as soon as we finish rotational atherectomy.
I can see,
Okay,
you can
there.
see what's happening at the
Go.
bifurcation, that there's no way you can do this provisionally anymore.
10.
Yeah.
It's beginning to generate on both limbs.
This is a
Yes.
two-stent, I
Down.
think. Sorry, Bruno.
But this is AK and Roxana. I mean, when you look at the Excel data, I mean,
Down.
very clear, osteal circumflex disease,
Down.
40% failure rates.
Radial, right.
I mean, it's so critically important to get that right. And then the other comment I was going to make was, based on the IVUS, an old lecture that Dr. Rao gave years ago in
How
terms
far you want to
of
go? All the way
EEL
down,
to
right?
EL, if you can
You wanna
see
go
it,
cut that?
size it up.
Yeah.
And it
Oh, this is
measured,
3 to 5,
I
too
think
big?
3.5, something
Yeah.
along
it'll be
those
okay.
lines. So a 3.5 vessel is at the very least here.
Yeah. If not 4.0, I mean, it's a big circ.
Okay, someday, yeah. Yes. Okay, let me go to
Get
the.
wires in it.
So how's
small
it
vessel.
going now?
Now, what we are going to do is we want to decide how distally how far we want to go. Means we are probably so we have to stay there, stay in the LED right here, not go to distally. But look at where in our cranial picture, right here, up to the first septal. There was disease up to the first septal.
Yeah.
Yeah.
So we need to cover till there. So we
Your
are planning
landing
to
zone is
dilate.
just after that first septal.
Yeah, good. So it's a good sign that our used cutting balloon has made its way and the lesion is yielding. Right, okay, go up here. Down. Do we just stent or anybody wants IVUS again?
Well, I'd like to see,
Go up here.
you're not going to bring that IVL back? I don't know.
To
Let's
begin
see what
with,
it
we
looks
were,
like.
yeah.
I would just stent it.
Yeah, their EKG changes and.
I mean, the way that it has yielded, I think we can just stent it. Left main, you
really
want to
depends
do,
on
give me the IVL.
Depends on the
Osteal
patient's
LED,
stability.
maybe
With
we can do the
EKG
IVL.
changes that are this persistent, I think I would just move on.
Okay. And also what we do is once we have had a good result, the only thing is I'm not happy, you wanted IVL of the, we will do IVL of the left main to osteal LED at one spot. That's it, not going to way further down. In the circumflex, we still saw a little bit of dog bone. Whether we need to pre-dilate before we stent or we directly stent. Despite rota and we'll just go at one spot, okay?
Yep.
Okay, still not going.
Don't waste your time.
Okay, Roxana, we tried.
Okay, you did. All right, it looks like Dr. Sharma wants to go for a second. He
Okay.
said 10 minutes.
So
Let me
we are-
go
we are-
there,
we are
because
going
we
to
got to
use a
get to our
mini crash
guideline
tactic.
session, otherwise we're going to lose our speakers. So we're
Okay,
going to
so
go
we are going
to...
to do two stent mini crush technique. I know.
Yeah,
Sunil
but
Rao
you're going
was
to do
mentioning
that, and
about
then you're going
DK
to
crush,
image,
but-
and then you're going to show us everything.
Yep.
Let's go to Dr. Sharma.
No, but he said you are ready there. No, but she wants to go for the guidelines. Huh?
Dr. Sharma, ready?
Okay,
No,
got
he's
it.
saying we show mini crush.
You want a
Okay,
3, 2,
show
5.
the mini crush.
Picture.
Go back to Dr. Kinney.
So
Okay, you have to go. Okay, let's take a cranial picture. Okay, we never had one. Entire
After they're
case.
finished.
Good.
So 3, 2, 5.
Yeah.
33,
38.
38.
And the circ will be a,
3, 2, 5, 38.
what did we decide for the circ?
23. 3, 5, 23.
30?
20.
No.
3020.
Oh, no, 20 cannot. Okay, now.
Yep, go ahead.
Good. 30.
Yeah, 30.
Based on your imaging, what are you talking, Kiski?
Yeah, so vessel size 3.5, but eccentric on the calcium. So it's not a healthy landing
3.0.
zone.
No, I know. Circ, we will go 3.0.
3023.
Yeah, that's
Yeah.
safer.
And a 3538.
For the
32538.
Dr. Keeney, are we sure we can cross that circ in that mid-segment there, which is eccentric and calcified? I'm worried that the stent may get hung
With the
up
stent, you mean you have to pre-dilate first?
there. I would
that's
probably
a good
pre-dilate
question.
that area first.
You have a 3.012 balloon? You are right, because even the IVL never crossed.
I'd probably take an NC balloon there. You know, one of the things, of course, is
You want a 3.5 for the LED?
the vector is going to be towards the ventricular
3.0s?
side, right? So that's exactly where
3
the
to 5,
lesion
no?
is. So that's going
They're
to
not
be
very-
Would you change wires?
Kiski,
Dr.
LED
Vassell?
3 or 3.5?
I mean, on the plug, so 3.5 is kind of aggressive. So 3.25 or 3.0 is safer, I think. But
I think 3.0 may be
yeah,
safer.
but point is the left main is 4.5 vessel. So if you cross over,
3 to 5 you found? 38? No? Down. Okay, then 3.0.
No. 23.
so the key is left main is 4.5 vessel. Left main is 4.5 vessel.
Huh?
Left main is 4.5 vessel.
Go for here. 4.5.
Yeah.
Wow. Down. Okay, so the circ has expanded well.
And
Give
then
us.
one trick is after you've
What's
used
the
this
stent you
balloon
have?
and it's unfurled,
No,
pull it back into the guide and then go back down.
Go Zion.
See
No,
if that
Zion.
core profile crosses at this point.
Okay, so,
Yeah, 3 or 23. And a 3 to 5, 38, quickly. So show the mini crash, left main on the side.
yeah, we have it.
Give me, so we're going to the circumflex, the most difficult.
Yep.
So,
And then we're going to put a 3 to 5 because now Kiski is saying left main is almost 4.0.
yeah, exactly. So I'm worried
And
that you're
the
undersized.
LED is not 3.5 distally.
Yeah. This one on that.
I mean, we didn't cross that septal. So.
Oh, okay. So you go low pressure, okay? So what you can do is we deploy it low pressure, so you don't want distal edge dissection. And then proximally, we will do the proximal optimization of the left main with the 4.0 actually, with the very high pressure. So despite that, you see that? We will go. Okay.
There you go.
Yeah, it went further down.
That's good work.
Yeah.
So everybody agree with this mini crush? I didn't hear anyone wanted to do DK crush, you know. Davide Capodanno.
Yeah, because of the angle and because this is the most difficult, of course, to pass through. So I think I would have started with the circumflex as well. And tap or mini crush are options here.
But the size
Sunil?
of,
Yeah, I think that the big advantage of that mini crush is that it preserves your side branch. So once you get the proximal sort of micro part of the stent crushed, and then you do your first kiss, then the side branch is preserved. You can work on the main.
We see it beautifully demonstrated on this bifurcate app.
I have circ.
Dr. Sharma? You?
yeah,
Yeah, Sanjeev.
yeah, Dr.
Not the other Dr. Sharma.
Okay,
You,
sometime.
Sanjeev.
Dr. Kiri, for
Okay, no, no.
LM2 LED, I would like to have a 3.538 stand and deploy a little lower pressure if you feel the LED is 3.25, because the 3.25 expanding left
Sometime.
main for the 4.5 is too big. So better to go with the 3.5
Where's the
at low
circle?
atmosphere
This is the
and then optimize
Okay.
the LED with the 3.25 and left
Okay.
main.
Okay, no.
Dr. Kinney, tell me exactly what you're doing. No, it's a good point.
So, no, we are, you're seeing we're
Show
placing the
us
stent.
and talk through your work here, because we want everyone
Yeah,
to...
we are, you see that? We are placing the stent optimally.
Yeah,
Okay, ready? Go.
it's the marker, you see
So
everybody?
you see that, you see that very well, everything looking good, but we will answer Sanjeev Sharma. Yeah, go for the circ. Go with the circ. We're going up with the circ. First is the circ. You see that? It's going.
Sometime
Good.
soon. Yep.
Yes. Go 12, 14. Yeah, good.
14.
down.
It's a little bit
Now what we are
angulated,
going
and
to
I
do is
don't
go
see
for a
a
second
very
time.
good dilatation there, but it may be the fluoro.
Good. And then we are going to have the fluoro, you don't see it well. Good. And now we are going to do is remove that,
It's not,
confirm. Now he was
the
saying go
patient
with
is
a
obese, I think.
3-5 low pressure, which is also
I
doable,
don't see it.
but
You see it?
we took 3 to 5.
I
He's worried about 3 to 5 becoming 4-5 in the left main.
So we've modified this technique by, after you deploy the side branch stent,
Yeah,
take the balloon back 2, 3, 4 millimeters, and then do a high pressure then.
Yes, yeah.
to
So
be
you
done
expand
with
everything.
it.
Go.
And then you can leave the balloon out proximal to the stent in the main vessel. Deploy the main stent,
Down. No,
and then do one more low pressure inflation on the side branch stent.
Mm-hmm.
This prevents the closing the door that takes place.
Yeah,
So
yeah, yeah,
jail
that's
stent balloon.
interesting.
Okay, now get us a 8
sort of a
millimeter.
mini
We
DK
actually, the exact pot balloon don't exist. 8
It's the
millimeter.
La Sala
fluoro.
modified
Yes.
crush.
Yeah, it is.
Nice. I like
I mean,
that.
so this isn't classic, right? I mean, here they've crushed the side branch stent, which is a circumflex, with the LED stent. I mean, traditional DK crush, you'd crush it with a balloon, kiss balloons, and then stent the main branch.
Modified because it saves you a lot of time.
Yeah.
The
And-
downside
and
is
eff- and effort.
Yeah, you got to cross the side branch, which again is easier if you do the classic sort of kiss, the first kiss.
You can do the pot after this and usually get back in with this technique.
No, we know. They're just describing DK crush steps. I know. They know we're doing mini crush, and mini crush is being shown in the side.
I still struggle sometimes in trying to really nail that osteal circumflex with the stent.
Okay. He
Particularly
wants,
if
he
you have
wants to
trouble
be very
getting it
clear
in,
that we did mini
and you
crush,
blow it
not
up, it
DK
goes in the
crush.
same
Look at that
direction you were
beauty.
pushing.
Look at
You
that
kind of
beauty.
lose the
Okay, now get us
marker.
408. Then we're going to recross kiss.
2 mini track.
I don't know, it may go. 3 or 12 high pressure balloon.
So
So we are
now-
going to do
After
the
they cross.
proximal optimization, and then we will cross and kiss. You still want us to show the steps, or you want to go to the
Yeah,
other
I
side?
think so. I don't know, is Dr. Sharma ready? Because we really need to go to
Ready,
the...
ready, ready,
Okay,
ready,
let's
ready,
go to
ready.
Dr. Sharma. Come back and show us your final images. Okay, Dr. Sharma, you're
all
up
right.
next 10 minutes because we got to go to the guidelines.
10 minutes, yes. All ready?
Yeah, go.
Okay.
Not done
Beautiful
yet.
case.
Go.
No, but.
Go ahead,
I'm
Dr.
still
Sharma.
hearing room 1.
Case 4, we're in your room,
Okay.
Dr. Sharma.
Okay, beautiful. All right. So this case, as you can see here, the slides, please. The patient is 66-year-old, had a multivessel disease. We have done other vessels, LED, now has brought back for the RCA PCI, normal ejection fraction. I think that's what we need to do. Very calcific RCA. Let's go to the angiogram. Okay. So this basically, we always, as I said, we always take a picture of the previous vessel, which we did. In this particular case, Circ has a moderate disease, about 60%, had a LED diagonal. You see that nice, very good. And now patient is here for this RCA. Look at the very angulated mid RCA. It looks like a very calcific nodule, then very tortuous distal and distal disease, and then there is a bifurcation. PDA, although you can say RPL, you can ignore it. If need to be, we'll send some flowers. But it's a small vessel there. But clearly, distal RCA lesion and there is a PDA lesion. And then, since we have done 3 cases of the rotational atherectomy, the orbital atherectomy team called us, summoned us that how can we not do OA? So we said this case is a good case for OA. But before that, we showed the IVUS. How do you like that? IVUS before the atherectomy.
No way.
Kiski.
Sure.
All
sure.
right.
Yeah.
Okay, I saw.
But only thing is, did not do OCT. Next case will be OCT, Roxana, guaranteed.
Okay, Dr. Sharma.
Yeah.
So this is
Okay.
like
I was on the main screen. Yeah, good.
yeah, mid RCA has an eccentric corsal lesion, and the proximal has a definitely 360 calcium, and the diffuse looks like not protruding too much, but definitely severe calcium 360, and some part is eccentric, and the other half is normal. So this of the population. So
What size is the vessel?
distal reference is a 4.3 vessel.
Wow.
Yeah.
Mega vessel.
Yeah, lesion length is 38.
Okay. So, okay, we can go to angiogram again, please, now. So just to say, we thought it will be a calcific nodule. Remember, if you stop it, it looks like that maybe the nodule, but there's no nodule.
Yeah, not that much.
Yeah, but that's okay. So it's a very calcified 360. Look at this. Tram track.
Yeah, we could see it. We see
Calcium,
it.
but no nodule, which is okay. So this we are ready with the orbital atherectomy, with a 1.25, and we have Viper flex wire, and we are going in.
All right,
It's
so as you're going in, I'm going to
the-
ask this panel here, after Eclipse, where are you using orbital atherectomy, if at all?
Beautiful.
Sunil?
Yeah,
Ask
I
the
mean,
panel.
Down the line.
we occasionally still use it in specific lesions. So, for example, really, really large vessels where the high speed can be helpful. But our use is really, I think, decreased quite a bit, particularly after Eclipse.
Good.
Davide?
Only when other options are not available, including the non-compliant balloon. If it's not an option, then I would go in a calcified nodule like that with the orbital, but otherwise it's very limited use now.
Deepak?
Likewise, I initially when the device came out was somewhat enthusiastic because it was just easy to set up and control everything right on the table. But at this point, I think if I'm going to do atherectomy, typically we just go with roto.
John?
Yeah, I would say nationally, it's at least 2-to-1 in favor of rota. So the ones that I use orbital on, as has been suggested, that the less severe the narrowing of calcium, so that I don't need a front cutter, I'm likely to still be able to cross, and I still want to get some
Yeah.
debulking.
There definitely are
That's
cases
when I-
where
that's
we
when I would
see
use it.
this very beneficial.
In very tortuous areas like this,
Yeah.
you might have some better purchase there getting that down there. So this would be a good one for orbital.
And we see you.
what's
Dr.
problematic
Sharma,
here
you want
is-
to talk through how you use orbital atherectomy?
Yeah.
Like
So
you give the
basically,
forces?
remember orbital 1 millimeter per second, and you can go compared to rota where there is a packing motion. This you can go forward, but make sure and back and forth that because machine will stop at 25 seconds. So back and forth, you need to go forward and come back 1 millimeter per second. And even if you crossed it, compared to rota, when you are done, one polish. You don't need anything more here. Every time you'll do, and particularly if you will give you a better lumen, and we do 80,000 RPM. In our lab, probably we used to do like 10% of the 65 cases. Rotablation, atherectomy in the past. Now actually 10-15%. Now it's only maybe 1 or 2 cases per month, which I had to do it for the fellows because they may go
Watch
into
that
the
distal
practice
wire
and there they
again
have
with
OA
your
only.
fellow.
Yeah. Yeah.
I mean,
So
one of the biggest.
You've reduced your cases. Go ahead.
I was just going to say, one of the biggest benefits of the availability of orbital atherectomy is that it forced the evolution of rotational atherectomy.
Yeah.
So it made RotaPro, which was, I think, a good
Yeah,
outcome.
RotaPro, yep. Okay.
And not only that, the next is that we are getting the burr. I just went to their plant, the complete burr, that means on both surface, distal and proximal. So that we tested, the problem came out, 1.25 burr still gets stuck. So we need to work a little more on, but whole issue about the burr entrapment, which a lot of people are worried with the rotational atherectomy, hopefully will not happen with the new design, but that's a little far away. Until now, we do the same. And here, this is the typical of orbital. This is what we originally published when came out with the 20 cases. It caused a deep cut.
Dr. Sharma, look
which it
at
has
that
done.
distal
Yeah.
right there. Not
That-
very
so
distal
that's all
into the
pseudo-lesion.
PDA.
All that is the pseudo-lesion. Yeah, that's a
Yeah,
pseudo-lesion.
that's what I want to make
Yeah.
sure that because we didn't see it before. That's the wire. So
Wire,
maybe
yeah.
you,
Yeah, that's
because
okay.
that's a
Because we never
really
touched it.
important,
So not a
important
concern about
teaching
there.
point.
It's a
We never
kringle
went
effect.
that far. It's all the pseudo-lesion
It
of the
wasn't
wire,
there
even
before.
despite
We all
using
of
the
a
wire
sudden
for
see it. You see it, everybody? Good.
Okay, you want to emphasize this again here?
Yeah,
Right there.
yeah, see, you, all of a sudden you see it looks like someone took bites out of the.
No, not all of a sudden. Remember, we never took the picture with the wire.
Yeah.
See, picture was without the wire.
That's because
And
of the
you see that
redundant loop.
bend.
It's the redundant loop that is now in a kringle formation.
Exactly, it's the wire
Yeah.
straightening
the
out the
PL
vessel
system.
and showing the pseudo lesions.
PL
Okay,
system's missing, though. I
let's
think,
keep
right?
going. Now you're going to change the wire to a workhorse.
Yeah.
And
Yeah,
everything
Yep,
will
this
go
is the run
back
through
to
then.
this- that- Now,
And what
a little
I'm going
nitro
to dilate
or-
with a 3.530 balloon, and the stent will be what?
One of the other advantages of orbital is that the wire is a little bit easier to work with. And I think that people are just picking up atherectomy early on. They actually favor orbital because it's easier to use. A Viperflex wire is easy to steer, and it's easy to get it up there and into it. And because of the differences in mechanisms here, you want to take as much advantage of the centrifugal effect and stay on the lesion for a prolonged period of time.
Yeah.
Unlike Rota, where you're sort of pecking.
Bruno, what are your thoughts here on this case so far? You used orbital atherectomy?
Open it. So we do not have it in the shelf in our lab.
Yeah.
And we thought about taking it in the lab, but we decided to stay with IVL, Rota, and specialty balloons.
That's right. So no orbital. Arthur?
Same. I bet we haven't used it in 6 months.
But I mean, nationwide,
All-
atherectomy's been decreasing anyway with the advent of IVL.
With IVL, yeah.
But increasing in terms of the combination.
Yes.
Yeah. More on the combination
rototripsy,
therapy.
Yep.
Yeah.
You want to
Okay,
get
here
that?
comes the stent. Pretty long
Yeah, this
stent,
is the
Dr.
stent
Sharma.
now. Yeah, we thought that we'll use a long stent, but it may not, it
So
will not
long.
make the turn, despite do a good balloon dilatation. Get a fielder wire. Let's see. So question comes down, what you want to do? You want to
This looks
take
like you
out,
need a
put a
guide
guide liner?
Guide
Yeah.
extension.
Guideliner,
This
maybe.
was made for a guide extender.
Guide extender.
Fielder wire.
Your-
It's a
your
very
choice.
funny right coronary, it comes up
Yeah.
and down and,
I think from an operating standpoint, we're so glad we have all these atherectomy options, IVLs, great hemodynamic support. But from a practical standpoint, the thing that's made the greatest benefit is a guide extender.
yep.
Yeah, no question about it. If you ask that what has been the discovery of the century in last 10 years, not any of those stents or atherectomies. Atherectomy already has been done, but I would say the guide extender that made our life so easy. Although since we had the fielder wire before, I just want to see if we can work out with a double wire. If not, then we go with our guide liner. Yeah, looks like it's not going to work.
Yeah, you're going to need it.
It's a really long stent. So while you're doing that and getting us the guide liner, Dr. Sharma, we're gonna, if you don't mind, we're gonna go to Dr. Kinney to see how far
very
she's
good,
done.
yeah.
And then we'll come
Go.
back to you while you get yourself all together.
By the time she's done, we should be done here, hopefully.
Okay, great. Let's go to Dr.
Okay.
Kinney.
No flush.
What you got, Dr. Kinney?
Yeah, I mean, a guide
Okay,
extension. there
what
would-
you see here, can you see they got.
No, I only see your lab. I need to see you and your film.
Okay, you see the film. I don't know, you saw the steps of the mini crush, right? You were there when
Yeah,
we did
we
the
were
mini
there
crush.
for that.
Yeah, then we did the pot.
No, but
and
can
then
you
recross
show
kiss.
us the film, please, guys? Oh, here we go. Okay, good.
Okay, pot, recross, kiss, all went easy. We call it boom boom. And now we are doing imaging. Show the circumflex already.
Yep.
So you
Circumflex,
recrossed,
you see?
you recrossed, you kissed, and now we've got,
First, proximal optimization, because there will
Yes.
definitely is a 3 to 5 stent in the 4-5 vessel. We went 4/20 atmosphere with that 8 millimeter balloon. Then recross.
it
We have
seems
a
to me you have
3/20
more
in the
dilatation to do
ostium.
there, just looking at that.
And then
Quickly.
now we are going to the LED IVUS. Let's see if it's going. No?
Yeah, just ostial circ is kind of elliptical shape, and area-wise it's like around 4.6.
No, ostial circ we got 5.2, no? MSA?
No, this looks to me that needs a little bit more dilatation, Dr. Kinney.
Where, no?
Yeah.
Tell me.
That looks like a keyhole.
Yeah, only the ostial circ. Other part is very expanded. Left main expanded. Clock circ expanded. Just the ostial circ
Ostial what?
is kind of 4.5. around
Ostial
4.5.
circ needs more dilation. Everybody agree?
Okay, good.
Good.
Now it
Okay.
is, Kiski, go back. Measure
Yep.
it.
I'll pull back on this
Pull
first.
back.
Okay, do the LED pull back.
Yeah,
Okay.
here's where IVL may have made life a little easier to have done
It's
it.
coming.
Yeah.
Yep. Blocks LED. And ostial LED. Yeah. This
It's good.
This much better. Yeah,
looks
this
good.
much
Yeah,
better.
left
LED
main is
looks
good,
good.
everything
It's
is
the
good.
ostial circ only, as usual.
Yeah.
No, I go back to the,
So
okay.
this is the distal left main. and austere LED, there's some calcium behind, but area-wise it's 6.1. So optimal area, I think.
Okay, go back to osteal, sir.
Also needs
sure.
dilatation.
I mean, I don't think you
Left
can
main needs a
do
high pressure
anything
dilatation
more.
is 4.5.
The LAD,
Left main.
left main,
Left main also
okay.
disturbed.
Yeah, that needs help there. Okay. What's the plan, Dr. Kinney, before we go to Dr. Sharma? Because I got to move on to the guidelines.
Nothing, we'll go back to, we went with a 3-0, right?
Yeah.
High pressure.
Well, you
We'll
obviously
go 3
need
to 5
the-
high pressure, that's
Yeah.
it. And you have to kiss again.
Okay.
And then we'll image.
All
Yeah.
right, sounds good. Let's go back to Dr.
Okay,
Sharma.
bye.
Okay, we are back here.
Yeah.
Now we are ready to put our guideliner or Godzilla, what we have.
Guideline.
It's a guideliner, Godzilla. Okay. So same, we have to advance it on the balloon. So we are taking our same balloon first, although it may be a little too big now.
Get a new 3.5
Right?
balloon. Yeah.
Yeah, can get because that was a long balloon earlier.
12
Yeah,
is it? 12?
yeah. We can get a 3.5 12 balloon, and so that we.
Yeah, one other thing that could have helped, it's a little late now, would have been a support guide, like an
A different
Amplats-type
guide,
curve
yeah, I
guide.
was just thinking.
Yeah, no, we started this case with the Amplats guide, and that didn't sit well. So we thought that it will be you see this now. First picture was done with the Amplats guide. This is the Amplats guide. So that was not sitting well. So we tried to manipulate, and it did not, and then brought the Akari guide, 1.5 went very nicely, very set. And the only thing is, with as Roxana mentioned, this is very, we call a crooked band of the RCA, proximally as well as distally. So we are still dealing with the proximal, but remember it was a long balloon, which we have used 3.530. So came out, the guide is still moving, that's okay. We'll do it again. Practicing wiring few times. We already have paid a lot of big price, although we are able to do that case. When these wires do come out, anytime you try to move these tortuous, there's a little leeway and they just come out. Look at the tortuosity, see? Little tortuosity and this comes out. But we were right now, earlier, the first wire was the fielder and this is the run-through wire. But this is, okay, so what I'm going to do now, stop at this level. So once it goes to this tortuous segment is the trouble. Yeah.
Now
so
you
we
bring
will
your
our
guideliner
Godzilla.
with a smaller balloon.
And here we are going to do balloon, yes.
With a shorter balloon.
Not only balloon, a small balloon and the new balloon.
Yeah.
Not the used one. The earlier we
Exactly.
had the used one. So same that you have to. Now we advance the wire. Not pushing, still going to push the guide. Oh.
Oops.
Wow.
Okay,
So
wow.
pushing the guide. So looks, what happened is the probably guide became soft. We still have our AL 0.75.
Yes.
Deepak said maybe that's what will fit a little better now compared to what it did earlier.
That's a great point. I mean, equipment fatigue is a real issue.
Yeah.
When you're pushing this hard on things, you could lose your backup and support.
Okay, so I'm going to go with the balloon first only.
Yeah, that's what I was just going to
Let's go
say.
with the
Why
balloon.
don't you
Yeah.
bring the balloon
Yeah.
first, then
Yep,
the guideline?
that's what we are doing, yep, yeah.
Let the balloon go a little bit further. Okay, now work
No.
with the guide again.
Yeah, go up here, yeah. So once you do balloon, then adjust your guide. Now, get a better guide position, which we are doing now. Then advance the wire. No, still the same. Anytime we try to go with that curve, I think maybe we
I
go
think
back
you need
with
a
our
new
field
guide,
wire.
Dr. Sharma.
Yeah. So last try, if we still have it, then we have our old AL 0.75, which was the original guide. That's what we decided originally, actually, when we had discussed the case, that we are going to use that.
Maybe
Okay,
a
one more
second
try.
wire there too, maybe.
Yeah. Yeah, so maybe second wire, which we did originally 2 wires.
Yeah.
Did not work out.
Just to deliver
Go
the
here.
guideliner.
Go here. Yeah.
SS, what
Yeah.
about a anchoring balloon? Was there a small conus branch or something that we could anchor everything in?
But then the Gardiola has to come out. There
didn't
will
have
be
any.
2 balloons from Gardiola will be impossible. Yeah, let's see now. Delay, deflate. You see that? Now we are moving a little bit.
Yeah, you got
Little bit, little bit.
Inchworm your way down there.
Yes. Yeah. No, but I think it will not go yet till we get little purchase on the wire.
I think I would push the guide in first before you push the wire, SS.
Okay, go up here. Okay. Oh,
guide is
came
out.
out same. Yeah, I think it's basically will require the new guide, AL 0.75. I think that probably will be the best one now, in my opinion. Okay, deflate now.
Okay. Looks
Okay,
like
now
we
it's a
got-
nicely coaxial. Go up now. But every time we go a little further, it just pushes it
Pushes
back.
it out, yeah.
See that? Yeah, deflate again.
Okay.
Same, you have to deflate and slowly advance.
Decent shape there.
Okay,
Now,
let's see
can you
now.
push the
If I
guide a
can get
little bit more,
balloon.
SS? While you
No,
got the
guide will
guide,
come out.
make the
Balloon.
guide better now with the Godzilla in. 'Cause
Yeah,
the guide
now
is
go,
still
go
pushing
balloon.
out.
Yeah,
Look for a trio compliant balloon.
yeah. Otherwise, get a tube.
Give me
Yeah,
trio compliant
Yeah.
balloon.
yeah.
Trio 12.
Lectures.
There you go.
Okay, now deflate. No, lectures and then case number 5.
Okay, we got to go to the cases,
Yeah,
SS.
yeah,
Is
no,
that-
but here, you just 1 second, go to the step by step. So just like, if you
Okay.
go up again, that we are struggling, that means it's same
We're
thing again.
learning.
Yeah. All right, I think we reasonable case that we try to show everything possible, except that now the guide we need to change than anything else, because anything we tried did not work out. Yeah. Okay.
I would
Okay.
start with everything brand new. Besides the
Start
guide.
brand
new.
new,
That's it.
please
Get a
put
new
it on the
balloon, get a new
side,
wire.
but we need to go to our guidelines and come
Yeah.
right back to you,
Yes.
okay? We
Then
will
come back.
to
Beautiful.
both of you.
All right.
And excellent, wonderful. Thank you, Dr. Sharma. I would like to keep the panel here, please, because we're going to go back to the cases again. So please don't, so we don't have to go back and forth. Excellent. This is the controversy session number 1, where we discuss and didactically and very well the ACS guidelines that came out in 2025, with the first author being present here, the chair of the co-chair of the guideline, but now the chair of the entire guideline committee right now for the ACC-AHA guidelines, representing the American College of Cardiology. We're so thrilled and honored that, Sunil, you will be leading this charge. So as protagonists of the ACS Guidelines 2025, please give us your part. And then we got Sanjay. Ooh, good luck. Good luck. Sanjay's coming up next.
Thanks so much, and it's a real honor to be here. Thank you for the invitation. You know, when I got this assignment, it said ACS Guidelines Pro, and there's going to be an ACS Guidelines Con. I thought, you know, as I'm the editor-in-chief of Circuit Interventions, so I get about 2 to 3 hate emails a week anyway. And then when the guidelines came out, I got a couple more per week, and then it kind of died down. So I thought, oh gosh, what could be possibly controversial about the guidelines? But so we'll talk a little bit about where I think there are areas of possible discussion. And I know that Sanjay is much, much smarter than me, and he's going to make some really, really good points. But for those of you who have a water bottle, I want you to drink every time he says fragility index or cannot rule out. So I don't have any disclosure. Yeah, and then you have to go to the bathroom. I don't have any disclosures related to this talk, and any opinions that I express are not the official positions of any of these organizations. So what I want to talk to you about is, first, I want to start with the guidelines process, because I think that it's important for me to tell you that this is not done in kind of a back room with people who really don't understand what ACS management is about. It relies on an established process. It relies on collaboration. It's a multidisciplinary document, and it undergoes at least 2 rounds of peer review. And the ACS guidelines got a total of close to 250 comments when it went through peer review. And then we'll talk about areas of debate. So the guidelines process, I mean, this is the framework that we use. It's actually a very well thought out and fairly intense process where the Joint Committee on Clinical Practice Guidelines oversees all the guideline documents. And the writing committee comprises every single specialty that we think actually interacts with a patient with that particular disease state. So for the ACS guidelines, we had interventional cardiology, we had cardiac surgery, we had non-invasive cardiologists, emergency room physicians, EMS personnel, and patients were also involved in the writing committee, as well as pharmacists. This is also a collaborative document with multiple specialty societies. 5 specialty societies were invited to collaborate on this. The AATS and STS never responded to the invitation, but despite that, we did have 2 surgeons, one of whom was a co-chair of the guidelines with Michelle O'Donoghue. It's Mark Rule. So the ground rules of the guidelines are the following, and if you have questions about why things are phrased a certain way or why things weren't readdressed to reflect kind of contemporary clinical practice, it's because of this. Prior recommendations have to be carried over unless there are new, compelling, high-level evidence to revise them. So this is a classic situation where we have, the last, bypass surgery versus PCI trial was done, a decade ago. So there are no new trials to actually inform that evidence, so we have to carry over prior recommendations. The language of the recommendation should adhere to the language used in the cited evidence. So if you do a randomized trial of 6-foot-tall redheads, the way the guidelines are phrased is in 6-foot-tall redheads, X, Y, and Z. The class of recommendation is the strength of the recommendation, and the level of evidence is the quality of the evidence. So you can have a class 1 recommendation with level of evidence B, for example. And clinical judgment always has to accompany the implementation of the guidelines. Otherwise, we can just use AI and we can all go home and not have jobs anymore. So it's really about clinical judgment at the bedside. So what are the areas of debate? Well, I think these are fair areas of debate, and we certainly debated these as the writing committee. What is the role of beta blockers in acute coronary syndrome? What about single antiplatelet therapy? And then mechanical or circulatory support in acute MI cardiogenic shock. So, I'm sorry, this is a little bit blurry here, but so what did we say in the guidelines for 2025 with beta blockers? We did give it a class 1 recommendation, level of evidence A, in patients with ACS without contraindications, early, within 24 hours, institution of oral beta blocker therapy is recommended. So keep that in mind, in patients without contraindications and early institution of beta blockade. Sanjay put his thoughts down in this very, very nice paper published in JACC just a couple of weeks ago. And I think the challenge is that it conflates a little bit of early beta blocker therapy with trials examining long-term beta blocker use. So for example, Reduce MI is a long-term beta blocker use trial. ABYSS is also a long-term use trial. Whereas in the guidelines, we were very specific to say early beta blockade, because quite frankly, there have been there is not a lot of new evidence, high level, compelling us to change that from prior recommendations. But the supportive text in the document is important. It acknowledges the data from pre-reperfusion, which is really where most of the benefit was from beta blockade and the lytic era. It counsels to avoid patients with contraindications, including those with heart failure or those who might be in shock. And it recognizes that long-term therapy, which is really where the debate is, may not be beneficial in the contemporary era, because we had to have some cutoff for when we considered evidence in the guidelines, and unfortunately, Reduce MI came out too late for us to consider it. What about single antiplatelet therapy? We give several recommendations, a class 1 recommendation, and I think the one that potentially people have an issue with is single antiplatelet therapy with ticagrelor after some period of time with dual antiplatelet therapy. So what are the data? Well, again, I apologize that these are blurry, but these are 6 randomized trials, 25,000, almost 26,000 patients looking at ticagrelor monotherapy in patients with ACS. You can see that by and large, there is a benefit of the ticagrelor monotherapy over continued DAPT, but the more important thing here is that all-cause mortality, and again, this is blurry, but all-cause mortality was significantly reduced with ticagrelor monotherapy. That is very, very difficult for us to ignore in the guidelines, and so it does get a class 1 recommendation in the guidelines for ticagrelor monotherapy, and obviously Dr. Moran did one of these really important trials, Twilight. Now let's talk about the third one, just so we stay on time, mechanical circulatory support in patients with ACS and cardiogenic shock. I won't belabor the point about IABP shock and ECLS shock, which looked at both balloon pump and ECMO.
Those trials were negative, but again, a very different inclusion criteria than what was seen with the microaxial flow pump trial, which is danger shock. And we gave this trial a 2A recommendation. That is, it is reasonable to insert in selected patients with STEMI to reduce death. It's a level of evidence B. Why? Because it's one trial, but it is R, which is randomized. And I think this is one of the most important trials ever done in cardiology, the danger shock trial, 355 patients. It took a long time to randomize these patients, so these investigators deserve a lot of credit for adhering to their stated goal, which is to randomize patients to the microaxial flow pump versus standard care. And at 180 days, it is very difficult to argue that this trial is in any way should not be practice informing, because there was an absolute 13% reduction in mortality at 180 days. This is almost identical to the 180-day reduction in mortality in the shock trial. So, and the number needed to treat was 8. So why not give it a class 1 recommendation, right? Well, there was a price to pay, and that price to pay is an increased risk of complications like moderate or severe bleeding, limb ischemia, and renal replacement therapy. People have argued maybe patients lived long enough to get these complications, but at the end of the day, there were some complications with the microaxial flow pump compared with standard care. So on balance, when considering the risk versus the benefit of the microaxial flow pump in shock, the guidelines committee came down on the side of class 2A, again, with very, very careful wording, selected patients with STEMI and shock. It is reasonable to use the microaxial flow pump, and I think for this one, we actually got it right. So in conclusion, the guidelines represent a collaborative effort that synthesizes the latest evidence, and it did undergo intensive peer review. This is not an expert consensus statement where we were kind of holed up in a hotel and just sort of came up with the document. This was 14 months of considering all the evidence and 2 rounds of intensive peer review. But we agree there are areas for discussion. Are they controversial? Potentially. Beta blockers, I don't know that there's a lot of evidence to refute their legacy recommendation for in-hospital treatment. Certainly long-term therapy is something that the next iteration of guidelines will have to deal with. With respect to antiplatelet therapy, over 25,000 patients support, I think, the class 1 recommendation for ticagrelor monotherapy. And with respect to mechanical circulatory support in acute MI cardiogenic shock, the balance of benefit risk, I think, supports a class 2A recommendation, not a class 1. But again, I want to emphasize that clinical judgment should always be used when you're applying the guidelines at the bedside. Thanks very much.
And now for the antagonist of all times, Sanjay Kaul, professor of medicine at Cedars-Sinai Medical Center. I just love his commentaries all the time because he's true to the heart and extremely critical. So there you go.
Well, thank you very much. I'm delighted to be invited to this important symposium, and for that I'm grateful to the organizers, Dr. Sharma, Kini, and Dr. Mehran. I know I'm the designated antagonist, but a more appropriate characterization would be a dissenting minority report. I believe that all guideline documents should be accompanied by a minority report, just like all Supreme Court verdicts are. Okay, how do I move this?
Green arrow.
Yeah. Okay, these are my dualities of interest. I would like to take this opportunity to congratulate Dr. Rao for generating an outstanding guideline document, which consolidates recommendations from 5 previous guidelines. And 61% of the total of 103 recommendations are strong recommendations, class 1. And 27% are based on level of evidence A, high quality. These are among the highest numbers I have seen in any guideline document. However, there are 2 recommendations which I believe do not merit the highest imprimatur of the guidelines. And these are early initiation of oral beta blocker therapy to reduce risk of reinfarction and ventricular arrhythmias. And the second one is transitioning to ticagrelor monotherapy after 1 month of tolerated dual antiplatelet therapy. Now let's take the historical perspective with beta blockers. In 2013, the ACC/AHA STEMI guideline gave it a class 1 level B recommendation for early oral beta blockers. And it quickly became a quality indicator. And the evidentiary support for this recommendation was primarily based on trials that were conducted in the pre-perfusion era. There were about 48 trials, 36 of them were limited by high degree of bias. And these trials show reduction in mortality and recurrent MI. In the post-reperfusion trials, and in 12 of them, there's a reduction in recurrent MI, but it is counterbalanced by increased risk of heart failure, cardiogenic shock, and drug discontinuation. And vast majority of this evidence comes from one single trial, the CCC trial conducted more than 2 decades ago in China. So this is the evidentiary landscape for the beta blocker trials in the reperfusion era. There are 4 trials, CCC, which was a placebo-controlled trial, capital RCT, which was a primary PCI with or without beta blockers. Reduce MI was a registry-based trial from Sweden, again, with or without beta blockers. And then there was a randomized withdrawal trial from France called the IVUS trial. And no treatment benefit on either primary endpoint or death in any trial. But the MI was reduced in one trial, the CCC, which is the basis for early beta blocker therapy. I also want you to pay attention to the mortality in the control arm. The mortality at 28 days of follow-up in CCC was nearly 2-fold higher than the mortality we see at 3 to 4 years of follow-up in the other 3 trials, indicating that the prognosis of MI has substantially improved with contemporary management. And that's probably one of the reasons we don't see the treatment benefit accruing in the contemporary trials. So what is the weight of the evidence? One positive study from China conducted over 2 decades ago where beta blocker therapy failed to win on both co-primary endpoints cannot be the basis for a class 1 recommendation. There's a favorable effect on secondary outcomes in CCC, which is MI or ventricular fibrillation. It is at best exploratory and hypothesis generating with the possibility of a false positive result not being ruled out because it failed on both co-primary endpoints. Benefit risk is not positive as benefit on MI and arrhythmia is counterbalanced by higher rate of cardiogenic shock. No subgroup in whom benefit risk favored beta blocker therapy, including half of the patients who received fibrinolysis. Since 2030 STEMI guidelines, there have been additional studies that have failed to confirm the benefits of initiating early beta blocker, thereby challenging the old dogma. Instead of assessing the validity of the evidence and reconsidering the recommendation, the 2025 guideline elevated it from a class 1 level of evidence B to level of evidence A based on weak supportive evidence that is past its expiration date. So what appropriation action is justified by the guideline? A reasonable case could be made to retire it from guidelines based on the absence of evidence argument. A more charitable approach, in my opinion, is to downgrade it to Class 2B, wait for the 5 trials that are currently evaluating the role of beta blocker in contemporary management, and then for final adjudication. So I think Sunil already covered this commentary. Now let's switch over to the optimal duration of dual antiplatelet therapy in ACS. Shown here is the difference between American versus European guidelines, and you will notice they're more similar than dissimilar. Not at high bleeding risk, the default strategy is 12 months. It gets a level A evidence, class 1 level of A evidence. At high bleeding risk, it's a weak evidence that you can use 1 month of DAP followed by aspirin or P2Y12 monotherapy. They don't specify which P2Y12 therapy. In the European guidelines, if you're event-free on DAP for 3 to 6 months and not at high ischemic risk, they say switch to single antiplatelet therapy, and that's moderate evidence. And in the American guidelines, excuse me, if you tolerate DAP with ticagrelor, you can transition to single antiplatelet therapy. It has a class 1 level of A recommendation, but it does not qualify to which type of patients do this recommendation apply. Is it bleeding risk or is it the ischemic risk? And when you have 2 class 1 level of A recommendation, which one should be prioritized? How do you reconcile? Do you go for 12 months or do you go for 1 month? So this is the evidentiary landscape of ticagrelor monotherapy versus standard DAPT. As Neil mentioned, there are 5 individual trials, and there is an individual patient data level meta-analysis based on 6 trials. And what you will notice is that majority of the data comes from Asia, 47%. From North America, we only get 12% of data, all of them from the Twilight study. There are only 2 double-blind placebo-controlled trials, Twilight and the ultimate DAPT. And if you notice at the pooled incidence of 3 MACE and BARC 3 to 5 bleeding, it's not consistent with high risk. You have a risk of 0.8% bleeding and 2.8 risk of 3-point MACE. All of us would agree these are not high-risk ischemic or bleeding patients. So there are many trial design issues that undermine the quality and the reliability of the results. And I don't have time to go over all, but I'll touch on 4 or 5. The non-inferiority margins were not standardized. They were arguably wide. They were powered for 80%, and which is low for non-inferiority trials and is biased towards non-inferiority. If you include a component endpoint that is unlikely to be impacted by antiplatelet therapy, which is TVR, what does the antiplatelet therapy have to do with reducing target vessel revascularization? It introduces noise and therefore is biased towards non-inferiority. If you use a combined efficacy and safety bleeding composite endpoint, so-called NACE, it is also biased towards non-inferiority. And when you have discordance between expected and observed active control event rates, you also are biased towards non-inferiority. Let me show you the example of this discordance. The observed event rates in all 5 trials were lower than the expected event rates. In Twilight, the expected was 8%, but the observed was 3.9. In Ultimate DAPT, the expected was 6.2, and the observed was 3.7. This inflates the margin if it is fixed in absolute risk difference. For example, in Twilight, you would accept 41% loss of standard dual antiplatelet therapy, anti-ischemic efficacy, and would still be acceptable for non-inferiority. In Ultimate DAPT, you would lose 68% of your standard anti-ischemic efficacy and still be deemed non-inferior. So not surprisingly, in Twilight, where the margin was fixed as absolute risk, it met the non-inferiority criteria using the absolute risk margin criteria. But had they fixed it in relative risk, 1.20, the upper bound was 1.25, thereby not meeting non-inferiority. In Ultimate DAPT, it met non-inferiority criteria for both absolute risk as well as relative risk, but they used a 5-component ischemic endpoint, including TVR. If you just focus on the 3-point MACE endpoint, the upper bound is 1.67. Are you willing to accept a 67% loss of 3-point MACE efficacy, even if it comes with a reduced bleeding risk? So does the totality of evidence support class 1 level A recommendation for shortened DAPT following by ticagrelor monotherapy post-PCI and ACS? The verdict is in no. Insufficient quality and quantity of evidence. Non-inferiority would not have been established using rigorous methodological criteria. There is limited generalizability because it is based on low bleeding and ischemic risk patients, mostly enrolled in Asia. Bleeding risk is reduced as is expected in 2 placebo-controlled trials, but not without increased ischemic liability as defined by non-inferiority margin. Only 1 trial where bleeding risk was reduced without increasing ischemic risk, which is the TICO study. It was underpowered, stopped early, and open label, which might have biased the results. I don't want to go into the meta-analysis, that's another entire lecture. A class 2A or 2B level of B recommendation could be supported for high bleeding risk and or low ischemic risk patients consistent with the European guidelines. However, the jury is still out in ACS patients at high ischemic risk who are more commonly encountered in clinical practice than patients enrolled in clinical trials. You might think that this is the minority report. This is a great debate just published in the European Heart Journal, where the protagonists who argued for default duration of dual antiplatelet therapy being 12 months, I happen to agree with that conclusion. So this is for a deeper dive, I refer you to this commentary that was also published about 2 weeks ago. Thank you very much.
Dr. Call didn't ask you to read my response to his commentary, which I think is also quite robust, and obviously it'll be great for everybody to have a discussion. So maybe we now turn it to Professor Bhatt, who's going to put it all together with the top 10 takeaways. Sanjay, please join us up here. I will let you join us up here.
All right, terrific. I've got to say, of all the interventional meetings I've been to, that was the gentlest and kindest debate I've ever seen. I mean, next the two of you will be hugging and kissing. That was hardly an interventional debate.
I had to submit to Roxanne.
Oh, is that why? Okay. All right, so let me get started. I've got 5 minutes here. These are some disclosures. There is some research funding covering some of the trials that form the basis of the guideline. Okay, this is going to have to be quick. So in terms of take-homes from the guidelines, I'll start with number 1. Ticagrelor or prasugrel is recommended in preference to clopidogrel in patients with ACS who are undergoing PCI, who aren't at high bleeding risk. So for folks that are still anchoring on clopidogrel in the ACS patient, if they're not at high bleeding risk, there's not a good reason to anymore. This was already discussed quite a bit about 12 months or 1 month of DAPT, so I won't go into that. You heard enough of that. Another important thing in the ACS guidelines, I think this is a great job by Dr. Rao and group, is that they're thinking about other things other than just PCI or antithrombotic therapy, such as LDL lowering therapy, mentioning to add a non-statin lipid lowering agent if the LDL is greater than 70 as a green recommendation, just to keep it easy, and as a yellow recommendation, even if the LDL is between 55 and 69, to add a non-statin lipid lowering agent. So that's really good advice, I think. The next one has to do with STEMI and high or low risk of ischemic events. Basically, if patients are at high or intermediate risk, and I like the fact that they lump the two of them because most people just think high risk or low risk. So high or intermediate risk is a routine invasive strategy. Lower risk, you still can do a routine invasive strategy, or you can do a selective invasive strategy, what we used to call a conservative strategy with stress testing and so forth. So very evidence-based. Another couple of pearls from these guidelines is that a radial approach is preferred over a femoral approach to reduce bleeding and vascular complications and even death. Once again, great advice. Dr. Rao generated a lot of the data, but for folks that are still clinging to a femoral approach, certainly in the context of ACS, it's quite clear radial is superior. Likewise, we talked a lot about this. Dr. Moran brought this up a few times in the cases. Intracoronary imaging is recommended to guide PCI in patients with ACS, and certainly with complex coronary lesions, I would say probably as a routine, a good idea. Even outside of ACS, but certainly in the context of this talk in ACS PCI. All right, what about completeness of revascularization? There's been a lot of data that's come out on this topic, and in general, in the patient with STEMI, PCI of the non-culprit lesions is recommended. Whether to do it in a single procedure or stage depends on the patient, the practice, a number of other things. If the patient's in shock, of course, just go after the culprit vessel and don't routinely go after the non-infarct related arteries. In patients with non-STEMI ACS and multivessel disease, CABG may be preferred. Maybe that's an uncommon or unpopular thought at an interventional meeting, but that's what the data support and the guidelines also mention. That includes folks with significant left main disease, along with high complexity CAD, multivessel CAD with complex and diffuse CAD, diabetes and multivessel disease with involvement of the LAD, and multivessel CAD or complex left main with severe left ventricular dysfunction. What about the timing of the PCI or revascularization non-STEMI ACS? Well, an immediate invasive strategy is recommended for unstable or very high-risk patients. For patients that are high risk, not in that super high risk or unstable, but still high risk on the basis of GRACE risk scores or rising biomarkers or dynamic ECG changes there, a routine invasive strategy is of course recommended with coronary angiography in yellow there in the first 24 hours. For intermediate risk, again, routine invasive strategy and coronary angiography in the next 72 hours or so in yellow. And for lower risk, as I mentioned before, can certainly do routine invasive or selective invasive, but if one is going ahead with invasive, the angiography should be done before hospital discharge. This was touched upon already, the whole idea of the microaxial flow pump. I'll just say the Impella just to make sure everyone knows what I'm talking about. And there, I actually, Dr. Roy, we didn't hear from Dr. Call fragility index. He didn't say it, but I will. This mortality finding is actually very fragile, statistically speaking. It's a small number of patients. The p-value is 0.04. I don't remember the calculation, but it's either 3 or 4 deaths jumping from one arm to the other. Statistical significance is lost. So even though this is a finding that seems intuitive, that as interventionists we all want to believe, it's not clear to me if the trial were repeated that particular aspect would reproduce. So I really do think more data are needed in terms of the patient with shock and what the best approach is. This is another thing that was in the guidelines about transfusion, and transfusing might be reasonable for hemoglobins less than 10 based on the MINT trial, I suppose. I was on the DSMB of that trial. I must say my interpretation of the trials was very not definitive in the finding, and I was surprised that the guidelines we're giving this as an option. And if there's time to discuss, I would like to hear from Dr. Rao, since he's done so much about bleeding and our responses to it, whether this really is an evidence-based recommendation. The final point I'll make is, even though the guidelines are about ACS, there's an appropriate focus on PCI, which most ACS patients end up getting. There's also an emphasis on secondary prevention, reminding everyone that a fasting lipid panel is recommended 4 to 8 weeks after initiating or adjusting lipid-lowering therapy, and importantly, referral to cardiac rehabilitation. With that, let me close. Thank you very much.
Oh yeah, thank you for bringing up the MINT trial. So it gets a class 2B recommendation based on the MINT trial. The MINT trial, the p-value was 0.06, so it just barely missed statistical significance. All of the point estimates of the components of the primary endpoint fell on the side of more liberal transfusion. Cardiac death actually was significantly lower in the liberal transfusion arm, with the caveat that it was not centrally adjudicated. So you have to be a little bit careful with that. So that's what we get, is sort of a lukewarm recommendation. Transfusion to maintain a hemoglobin of 10 can be considered. I will say that I did a lot of the observational data looking at associations between transfusions and outcomes, and it was all completely wrong, I think. It was confounded by indication, and that's why we did the randomized study.
So, Sunil, what about the reality study where the restricted strategy was non-inferior?
Yes. So the problem with reality was that it was much smaller than MINT. It was 666 patients, and the primary endpoint actually was not mortality. The primary endpoint was cost effectiveness. They were kind of forced to report the mortality benefit by the editors of JAMA. So, and because they didn't have faith in their own results, the investigators from reality continued to randomize in MINT.
Yeah. Well, great. This is a great protagonist, antagonist, great consensus by Dr. Bhatt. This is amazing. Let's go back to Dr. Sharma, though, who is anxiously waiting to show us the final result of case number 4.
Okay. All right, guys, that's where we left you. That we were doing the orbital atherectomy for that 360-degree calcium in a large vessel. And then after that, this is the result, which saw a little dissection line, which is common. Then post-dilated with a 3.5, 30 high pressure, came out perfect. And then whole issue was advancing the guideliner. And therefore, it required a little time. And we went back and then able to put the guideliner there, post-dilated. And you can see a fantastic result. Now we needed to take care of the distal RCA, which was there, open the AV continuation, and then put a balloon and stent into the PDA. And this is where we came up. So with that note, I'm done, and Dr. Keeney is ready in room 2.
All right, let's go. That was terrific.
Thank
you, Dr. Sharma. Let's go for case number 5. Very quickly, case number 5, and right after was lunch. Let's stay with us.
Oh, wow. So you are keeping people away from lunch, so you got to be fast.
I know, I'm making
case number 5.
She does the case as well as notices what I'm leading also from here. Great. So let's see what's happening.
So you have a 87-year-old male, right? Okay, come here.
Yeah.
Yeah, down.
We can see the slide. Go right ahead.
No, more. No, this one, face, I cannot. Okay, good. 87-year-old male that we had seen with the CAD risk factors. Why I keep hearing my own.
We see the slide. We see the slide. Epigastric pain, CCTA, moderate left main stenosis, severe proximal AD stenosis, unable to perform FFR, EF 57% on great medications, including Plavix, and a previous cath with 3 vessels CAD, mid-RCA 90% ISR, cerebral calcific segmental proximal AD 70 to 80, and ostial D1 bifurcation, 111 proxarc 70 to 80 ISR, and proximal ramus 70 to 80 ISR. And planning today, mini crush, bifurcation standing of proximal AD diagonal with rota and IVUS as soon as the mask is all set for Dr. Kinney.
Yeah, so mask has been set. Now I'm able to speak properly. You see that the EDP was okay, EF near normal, and the right coronary artery.
Show us the angiogram, please.
That was done last time.
Control, AV control.
Can you see the
Switch to angiogram, please. AV control. AV control, thank you.
So I have Parasuram with me and Swati, who's our interventional fellow, going to stay here one more year to do CHIP fellowship. So this is the circumflex, what we saw. Ramus had PCI, but this is where we are. The distal circ, we have decided that we are not going to intervene anymore. Medical therapy.
Yes,
and
it's very small distribution.
In the cranial view, yeah. There's a diagonal stent from the past, but if you see, the ostium is not covered and significant disease of the LAD just at the level of the diag with calcium.
Yeah,
so
we can see.
I know everybody will ask imaging, and we know we could do imaging. We wanted to do imaging of both side branch as well as LAD. That's why we picked IVUS, but we definitely are going to show OCT in our next case. So we try to do the IVUS, if you can see there. Show the IVUS, Kiski.
Yep. Can you show the screen?
Dr. Yasumura, we can see him while he's explaining the IVUS.
You look at the All right, okay, I'll start to work. So this is a proximal LAD and eccentric calcium and the 360 focal calcium and the left main. Left main has some calcium nodule, but area is patent.
Yeah, the left main has a nodule, area is about 12,
yeah.
so I don't think we need to touch that, right, Kiski?
Yeah.
Is there a stent in the LAD or it's all calcium?
It's all calcium, looks all calcium, very focal, 360 calcium.
So we have shown our algorithm, so go back to the algorithm, but that algorithm actually is more for management of calcific nodule. So if we go here, 360 degree, stop there, 360 degree, and it's not even 5 millimeters, right? The length
longitudinal, less than 5.
12 millimeters. So it's only one criteria, and looks like it's a, it's not OCT, but even then we can say it is just like a superficial calcium, not deep calcium.
Of course.
So now if you take the diameter there, we are 1.9 to 2.0 at the tightest area.
MLD,
MLD. So in the situation like this, you need a large rotabur, number 1. 2, otherwise orbital atherectomy, but it's a short area, probably we don't need it. So despite we decided maybe we should do rotational atherectomy, before imaging we decided that we have actually a rotawire already. But looking at the imaging, depending on what the panel thinks, this is not a bad idea. Probably we can try IVL directly, shockwave. What do you think, George?
I think maybe that is possible. That would be a good one.
Yeah, I like the idea.
Anything from the panel?
Yeah,
I like the idea of
I think we're getting votes from the panel, positive votes.
Yeah, the lesion is not very tight, so IVL balloon can pass through easily. So better to go for IVL.
Yeah.
Okay.
Yeah.
Now, having had our previous case where IVL would not go any further, Parasuram told me, why don't we just dilate a little bit so we know. When we tried IVUS, it was a little hard to go through. Maybe that is that nodule, giving us a little, we said even prox LAD has a nodule, right? Yeah. Okay, so go up here, have the IVL ready. So if we need IVL, it will be 3.5, right, Kiski?
Yes, 3.8 vessel.
Okay.
So you're using now the 3.5 IVL, correct?
Yeah. But we pre-dilated to some extent. So we're going to do 3.5 IVL.
All right, very good.
And after that, we are going to wire the Diag.
Nothing wrong to
and
predilate
quickly
in
image.
order to make sure the IVL balloon passes, or why not? You don't want to
Yes.
have a lot of friction with that balloon and then, destroy the balloon while trying to deliver it. Why not?
The ramus stent.
Yeah. That's one. The other thing, I think, based on the way we are showing the algorithm from this particular symposium, one thing people should probably learn or take home message is management of calcium. So that's why we keep going over imaging and how to manage the calcific lesion. So just based on the angiography, we thought we will use, Rota 1.75 bar. But after we image, everything changed.
Yeah, I think mostly the calcium was at the 180 degrees, so I think that's, we can see. We can see how the IVL performs on its own and how it delivers.
Not going.
The most difficult part for the IVL is actually the proximal part, I think.
That nodule?
Yeah.
Double wire?
It just doesn't take the
Give me another
curve of the
wire.
nodule.
Fielder. Yeah.
Nah,
We'll try to use a fielder.
I'm not
We
sure. It's
expected
documented.
this.
Yeah. It is a combination of the original bend and the nodule, I think, that although a short balloon is a relatively inflexible balloon, so.
Now let's do double wire, and I'll try to go on the fielder. If it still does not go, maybe we just do a cutting balloon.
I mean, other options could be a buddy wire or a guideline extension.
No, I'm doing, we're trying buddy wire first.
Try the body wire, yeah. Try the body wire first.
Yeah, maybe one of those
But
two
looks
things
like
will
our
help.
wire also came all the way back. I think we got a lot of purchase in our wire distally, and then same for the guide wire. We have two wires all the way.
AK, what's the plan for the diagonal, proximal?
No,
to
we
the
are going to take care of the Diag also. That first we'll work on the LED and
Yeah.
then probably cut the Diag. We need to stent the ostium of the Diag.
Yeah.
Now let's see if the IVL goes on this one, right?
Yeah.
If it does not go,
So are you delivering the IVL on the fielder or on the other balloon? On the other wire?
on the fielder wire now.
On the fielder, okay.
Yeah.
Let's see how it goes on
And
the
the
flexible
great
rail.
thing about IVL would be that we can leave our buddy wire there if the balloon goes. Have a 3 to 5 cutter ready. If it does not go, right?
Dr. Kenny, can we keep?
I mean,
a
how would
diagonal
a
for
3
the
to 5
DCB?
cutter deliver also? You see it getting stuck there. I wonder if some kind of a,
Balloon there.
is there an
He's
interference?
saying we should. Okay.
There you go.
Got it.
It's just getting stuck there, making that turn. As soon
Yeah,
as it
a
went
little
over-
reorientation. Kiski already mentioned that there was a nodule in the ostial LED. Yeah, that Sanjeev Sharma was mentioning something.
Yeah. About the keeping it provisional and diagonal can be managed with DCB.
Okay, let's have a panel discussion. Because the ostium, you see that? The disease is where it's unstented. The stent itself looks okay.
Right, yeah, I'm not
Right,
sure.
so-
We can do
No,
cutting balloon
we
first.
like
Yes.
your idea, DCB. What do you think, panel and George?
I mean, I agree. Why can't, if you cut it, if there's still TIMI 3-grade flow, if there's no obvious dissection, why can't you just use DCB after
Right.
you optimize it?
Right, not a bad idea. The evidence
You
of
have
that
to
is,
get it from the safe, which
Very
is
good.
on
From
the 7th
agent,
floor.
it's, from agent, it's, as long as you optimize the lesion first, although that was in-stent restenosis, but
any other ideas
keep
about
going.
DCB?
I can tell you that we will address these questions in a new trial from the European Bifurcation Club, which will start this year. And we will randomize 750 patients to a provisional stent strategy or DCB-only strategy. This means that in the DCB group, we will predilate the main branch, prep the side branch. If the side branch looks okay, we will do DCB, then forget the side branch, and then decide what to do with the main branch. So that's, and I hope this will give us more data on this question.
Interesting, interesting.
You know,
But,
putting
yeah,
aside cost considerations, it seems like it'd be a nice use of a DCB here. Again, assuming that osteolesion opens well, isn't dissected, and there's TIMI3 flow.
Okay.
Right.
Don,
Well,
good.
let's see how that
Get-
goes.
Get IVUS.
We'll cross that bridge when we
here
get there. For right now, we're doing the IVL of the LED. That seems to be a lot of work because if we had trouble passing the IVL, we're going to have trouble passing other equipment also. So we'll do a good job, a good expansion, and then do an IVUS to see what we did.
So we've done 5 cycles. That's
I
done. Good.
don't.
So
I suggest we do as many cycles as possible.
Okay.
I guess that was a good idea.
Here, now it's going good. Go. As many cycles.
Yes.
Do not waste it.
Not risk it. You paid for it anyhow.
Yeah, you paid for it, mind you.
Yes.
You paid for 12 cycles. You had to use at least 10.
But how long ago was the diagonal stent put in, and what did the ostium look like at that point? Do we know?
When was that? Diag stent.
I'm not sure that it looks like the diagonal stent had missed the ostium, intended to go to ostium, but did not end up in the ostium.
Yeah, could be.
And the residual lesion is where the ostium
intended.
is. So.
2018.
Yeah, it was not done in Mount Sinai. It's an outside hospital many years ago.
Of course.
Mount Sinai would not have missed the ostium.
That's understood.
No, that for sure. That goes without say. I mean, of
Yes.
course.
But I mean, the main
It's
thing
not
is if it's
intentional
non-calcified, you could get a good result with a specialty balloon and then try to work from there. If it looks pretty good,
So
try to
what we'll
avoid
do
stenting
is,
it.
when I'm done here, I will take the fielder wire, get to the diagonal. We will image LED diagonal, and then we make a quick decision. Yeah, good. Okay, as George mentioned, we have finished 11 now. Okay,
All
we're
right,
coming
very
up.
good. Very good.
Okay, get us IVUS.
Yep.
So let's not give more dye. We'll just image.
Let's see. Are you continue to work on the fielder, or you gonna switch now
Yes.
and work on the other wire?
Now I will go to Ramus. I'll take the fielder and get into the Diag. Yeah, so now I am in the Diag.
Yeah, good. Let's see.
Yes, small vessel, right? Okay, good. Leave it there.
Yep.
Now let's get into the LED. IVUS both. Quick decision. It could be just a fibrotic tissue in the diagonal, right? Ostium.
Yeah, that's what I was alluding to, Dr. Keeney. I mean, if it's non-calcified and seems just fibrous like an edge restenosis, it should dilate up pretty well, and that would respond well to a DCB.
All right. Anybody, by the way, anybody who has a question from the audience, please go to either of the two microphones and you get to ask your question. It's a general comment, at least throughout the cases that I moderate.
Everybody why?
Again.
George, you better hurry up with the case. We're losing people up here.
Oh, okay, here.
Okay.
Quicker, IVUS.
Yep. Check the image. Yep, LED. Okay, start to work. Post IVL. Is the proximal LED. Yeah, some dissection. Yeah, much better. I see some fractures.
Okay.
Yeah.
Show them the fracture that you see,
Yep.
though not well. We'll do a quick IVUS on the fielder.
So this is the level of the diag. We see also the wire.
We can.
Just before that here. Yeah, here, like 3 to 4 o'clock, there's a calcium fracture. Yeah, here's also like a 3 o'clock and a 9 o'clock, there's a 2 calcium fractures.
I think that's enough. I think there's enough plaques, enough fractures.
Yeah, and the area was also, it was 3 point something, now it's a 5.8, so it's much bigger lumen also. And after the calcium part, there is some dissection between the calcium and the fibrous part. So we should cover here.
Okay, let us see whether it will go. Okay, good.
Check the image.
It may not go all the way, right? You cannot see it in the Diag ostium.
No.
You may not see it well. See?
Doesn't cross.
It's a short monorail, so it's not making a turn.
Yeah.
Can you see the ostium?
Okay, I check the image.
Yeah. No, you're still in LED.
It buckles there. It is not, it can't make the turn.
Let me try once more.
Yeah, I don't
see
know.
that?
Maybe the flexible wire is not helping there.
Yeah. I'll have to double wire. I think we let go. Let us just cut it. What did we decide? 2.5?
Yes.
2.5 cutter? Give it.
Yes.
Flush it.
Yeah. I think 2.5 cutting balloon is a good idea for that area.
Cut. So let us cut the side branch, and then angiographically we have to decide. 2.5 stent.
Well,
You have a DCB here if you need it, or do we have to go to the safe to find it?
It's not the typical bifurcation, this one, because there is an other stent that's widely patent in the diagonal. So we have to preserve quite a good flow here, because it makes no sense to have a patent stent and then you have a suboptimal result, even a relatively suboptimal result in the proximal part. Let's see how this expands and what we get afterwards.
I only wonder that is it a small...
What pressure are you using there? It doesn't seem that it opens.
22. But can you see that?
It doesn't open up.
Looks like it is calcified. Yeah, it doesn't open up.
It doesn't open much.
Okay, done.
Yeah, so this is becomes
It
like
may be
your
a
poor
small
man's IVUS.
size cutter. Okay, go up there. Yes.
No, come
Okay,
back
now
in.
it's opened up. Yeah.
Much better.
Yeah. Now we are, you want to go bigger size balloon, 275?
Yes.
Let us see how it looks.
All right, let's see now how it looks.
Wow.
Yeah.
I don't think anybody's considering a stent there, at least I'm not.
Yeah, this is not unexpected.
So
DCB.
Yeah, based on what, the consistency, I think
Now we
if
should
you
have sure.
saw the
275. Oh, you mean,
stent-
okay. Let us try, Parasuram is telling me try IVUS again.
So in our lab, this would be the
I
perfect
don't know
case
why.
for DCB
I
only
think we
studies.
go with a 275, no? Is that a 275? DCB? 275? 2.5 or 3.0?
You'd put a 275. I mean,
You have 275?
DCB.
No,
So
only.
do we go with a DCB to the side branch and a stent provisional?
Yes.
No, really.
I think so.
What does the panel think?
Yeah.
I think it looks good in the diagonal. I don't know that it needs anything.
Yeah, ostium is opened up well, so we should go for the DCB.
Okay, good. So let's go for DCB. We are going to go 275 and then we will stent across. That's it, 3.5.
I mean,
We will
without
do
having
a
the
3.5,
histology, I don't know what it really is there, but it
20.
behaves like restenotic tissue, right?
But just one,
Restenotic tissue
Other
dilates pretty
stents are-
reliably, it doesn't fracture,
Right.
it dissects.
What's
As
that?
long as it's not been there for...
Kiski, our eye says 20. What does your IVUS say?
Dr.
So,
Scheller,
like,
Dr. Scheller has a comment.
to the Diag is
just one comment.
20.
Do not use a bigger DCB
So maybe 20
than
or
your
18.
biggest predil balloon, because
But
then
at
you
least we need a
have
15
the
to
risk
cover the dissection.
create a dissection by the DCB, and I wouldn't do this. So if you end up with 2.5 predilatation, use the 2.5 DCB.
Yeah, 2.5 DCB.
Okay.
2.5
My only
DCB.
question was, we had to go really high pressure to open it. That 2.5 may be a small.
Yeah, but the point is you did your mechanical work with your predilatation now. So there's no need to go bigger with the DCB.
Well, listen, I have a vote to do nothing in the side branch also, so this alleviates the debate you're having now about the
So they want to
size.
stand across,
I
you're saying?
propose size 0 DCB.
But George, what
Okay.
about the data? What about the
No, yes,
DCB
restenosis,
versus
so you
PTC
cannot be, you have to do
versus
something.
POBA alone. POBA alone for
Yes.
instant restent. I mean, better for DCB than POBA alone, right?
Is it?
Yeah.
For something like that, at the
Well,
ostium of a
it's
diagonal
technically,
with
I
a
mean, it's
patent
instant-
stent?
It's instant restenosis,
I don't think
basically,
so.
because it's within a millimeter.
Not really. It's in segment, not in stent.
Nice.
Oh.
I checked the image.
It's peristent restenosis, right?
We are
5 millimeters
specific
outside
in
the
the
ostium.
ostium, so I'm not sure.
It's a Diag, previous stent.
Yeah,
Very
it's a
No near
3 meter vessel.
Yep, it's open. Osteo Diag is open now.
Okay, and what does osteal Diag tell you on the IVUS? So IVUS went after we pre-dilated.
So this is actually osteo Diag. Now it's very open. And now soon come the previous
Go for
stent.
lunch. So what is it, 2.5?
Vessel size is the 3.2.
No, 3
Like
over.
3 vessel.
There's no stent in the ostium?
No.
Not calcific down.
Yeah.
Yep.
And now it's well modified.
Okay.
Again, I would treat this
So
like
what, I think
stenosis.
the reason we have to do DCB is just because it's a restenotic lesion. And this patient has come with restenosis. So we will do a DCB, 2.5 DCB to the side branch. We will do a 3.5/20 to the main vessel, provisional, and we will image. So Dr. Sharma says now you guys could go for lunch.
All right, so you're gonna go break for lunch, and you're gonna show us a final result in the beginning of the next
Oh,
session.
yeah. You know what?
Exactly.
We needed to show you before you do that. Can you change quickly to that previous case number 2?
Yeah. All right, get ready. The lunch. Oh,
Quickly,
the lunch
yeah.
is gonna be
Give me-
exactly
no
half
lunch
an
yet.
hour.
No lunch yet. 1 second. Give me a few minutes. I'm going to show you the first case of the day.
Many people went outside, took the lunch, brought it inside.
No
Those
food
were
for you.
Very good thoughts. Very nice thought. So let's see.
So nobody's there to show the first case?
Everybody's here. About half the people are eating though. So please show the case
Okay,
of
let them eat.
previous
Let them eat and
case.
watch. That's better.
So then everybody can eat. Only half people eating now.
Yeah. So what happened is, I think everybody saw the wiring of the LED, right? We saw the wiring of the LED
Yeah.
there.
Okay, yeah, great. Yes.
Good. So now nothing was going in the diag. You see that?
Yes.
We dilated.
Uh-huh.
And we were able to wire the LED. I don't know, you saw this wiring?
Uh-huh.
LED wiring, yes?
Yes.
Yes.
No, man.
This
Very
was an
careful
amazing job.
wiring.
Amazing job.
Okay. So that was done. So we thought after this, at least we will be able to, we ballooned, nothing was going. So now we changed to 1.5 rota of the LED. I think that was shown. So we did 1.5 bar rota, but
Now
we went all the way distal.
The microcatheter went in order to do the exchange, or you exchange short?
Yes.
Not
It
right away.
went, was hard, but it went. So
Good.
I think we have seen all this all the way. So Diag, if you remember, only the ostium was done. The distal part of the Diag rota would not cross.
Right.
So look at the way it is, yes.
Yeah.
So now we wired we stabilized the LED, we put a 48 millimeter stent.
Great.
Now the question was, do we stent across, which is provisional,
Yeah.
and leave the diag the way it is, what we call artery in pieces, versus now we take care of the diag. So even while doing rota, I was very concerned about the second lesion. I was worried perforation, because that area of the diag always is it could be intramyocardial. So anyway, we went with a 1.10 balloon, 2.0 balloon, dilated, all these things, and we were able to put a mini crush right there, okay?
All right, very
Everything
good.
done, but now see what happened.
Got a perf.
Yes.
In the
We
tightest.
did not do so with the diagonal, but then to get the stent there, we really had to pre-dilate. We went almost like a 2 to 5, 1820 atmosphere. This is a 2 to 5 stent and dilated well. After that, it was not easy to recross was easy. Nothing would go. We had a 1.0 balloon, 1.2 balloon. After that, we used a Godzilla and then put a covered stent in that area.
Right. That was the
And
tightest
this
most
is
part
this
of
is
the
where we
diag.
are. Final.
Yeah, very good. You can see how it's bulging exactly where the wall gave. It was the area that the diagonal was the tightest point. Very good outcome despite this hiccup. Excellent.
Yes.
Great. Very
So
didactic.
that's where we
Excellent.
are. Now everybody
Congrats.
can go for lunch, enjoy
All right.
lunch, and meanwhile we'll work.
Well, everybody can be
Thank
back
you.
here at 2:09 p.m. We're starting promptly at 2:10 for the next set of cases.
She talked about using it, but I think she went over back to that. Everybody's talking about doing a lumen catheter, or supercross. I I thought that she went to a field and put her own bend on. The guy put her own bend on.
Comes down.
let's start gathering slowly but surely, start gathering. Let's start gathering slowly but surely, as I said before. Cath lab ready. Cath lab 1 is getting ready. And we will have Dr. Baber joining us up here, Dr. Moreno, Dr. Barman, Dr. Duvuri, Dr. Freeman, Dr. Moller. Of course, Professor Bruno Scheller, and Dr. Singh, who is joining us straight from the faculty lounge. Yes, of course, Dr. Srinivas Duvuri, of course. And we see Dr. Kini in room 1. Excellent. Dr. Moreno, you come on this this spot, please.
Live case number 6. Put it up.
Yes, you want to show us the end of the previous case or no?
Oh, I thought it was too simple to show after that.
Okay, maybe at
we
the end
did,
of this
yeah, it was good. So we did, DCB of the side branch, and then we did.
At some point,
actually, when we image, remember we did, and the IVUS, the vessel size was 3.0, diagonal.
You show us the final result at some point. Okay, let's go with this case.
We will, after this. So here, this is what you're seeing, a 73-year-old female, okay, who had presented with angina, shortness of breath, and some, EKG has shown some changes, significant risk factors. More important is active smoker. And I think one thing we already know that people who are smokers, two things, peripheral vascular disease and calcified coronary artery disease. Yeah. So she had a CCTA, and they said, of course, look at the calcium score, about 2600, EF was good, and showed multiple lesions you're going to say, showing it, right? LED as well as circumflex. So heavily calcified, had a significant LED disease, and significant RCA disease, so 2-vessel disease, okay? And then we did a rotational atherectomy of the LED, stent of the LED done. Today, if you can show the angiogram, she's here for PCI of this distal RCA.
Very
so
complex.
Calcified, and look at how the RCA takeoff is.
Highly calcific and highly tortuous in the proximal vessel, and a very big size as well.
Yeah.
So a lot of challenges and a huge distal distribution. A lot of things at stake here. So,
So we actually tried, this is a 7 French guide, we tried AL 0.75, and I did not like the way it's facing. Then I need to make have aggressive movements to actually get it coaxial. So now we changed to actually LIMA guide, which is sitting much better. So we will now ask the panel, yourself, how we approach. So we have various approach that we think we need to do. One would be that we thought we will go fielder fine cross change to rotawire, okay? And then we will have to get Godzillas. That's why we have a 7 French. Getting a rota all the way down to the distal RCA could be challenging. We could do dyna, try to see if it will reach there with a 1 fiber, versus we get a Godzilla, means we have to go side by side, wire, balloon, get a Godzilla down. But when you have a 7 French Godzilla, the max you can do is 1.25 bar. So you can get a lumen of 1.25 bar, and then do we do the same thing that we did in the other room, that then do we consider IVL to really modify that calcium in the distal RCA? What do you think?
Yeah, I mean, for sure you're going to need some sort of guide extension, and definitely the biggest size guide is size equipment. All the equipment is very necessary, because also with the tortuosity you may have to both do a lot of maneuvers as well as be able to do some injections and see what's happening and all that. So you really need the size.
So that is one option. Another option, Josun is just thinking, why don't we just wire it or balloon dilate and then try to get a IVL down there through a Godzilla. So that's another option that also is a possibility. But I think let's do what we initially planned. What do you think?
Yeah, I mean, I'm not sure how that's going to work. It's a very big IVL balloon. You need also, it's not a small IVL balloon. You need to go at least 4.0 here. IBL balloon.
Yeah, we have a 354 already.
Yeah, but you know,
let us see how the wiring.
Will it deliver this big balloon through a Godzilla? I'm not so sure. Particularly on the way out, you're going to take everything out together with it. I think better to go as planned.
Okay.
Any ideas from the Dr. Singh? Dr. Singh is here, and
no, I see your pacemaker. I know you're going to do rotablation, but the artery is pretty big. There is train track calcium in there, so it may not be unreasonable just to take a non-compliant balloon and see how it goes and angioplasty it. That to avoid trauma in the proximal vessel and stuff like that might not be unreasonable. Even though I'm as Anu knows, we perform atherectomy when you see these kind of things, but it's probably not unreasonable.
Yeah. Any other idea? Dr. Barman, idea from the west side of New York.
Some die?
I mean, all the thoughts are all reasonable. I think you can get quite a bit of feedback by just how the wire and the catheter behaved. It seemed pretty favorable here. So I think if you were kicking things out very early in this case, that might change my strategy. But right now I agree with seeing how a balloon dilates.
Okay, get us a floppy wire, right?
Any idea from Europe? No idea from Europe. How about Long Island?
I agree. I think, a 3.0 non-compliant to start or 3.5. I'm just not sure what a 1.25 is going to do.
How about the Wild West of Oklahoma? Any idea from Oklahoma?
Yeah, I think for this kind of a case, certainly would consider to avoid the proximal trauma, maybe getting your guide extender down and burring through that with a 1.25, and then I think you would still probably need to do more, maybe lithotripsy.
Get me a run-through wire. What's the balloon you have?
Dr. Duvuri, any ideas from New York, back from New York? Any more ideas from New York?
Okay, this is
again, see
7
how
French?
the wire goes.
Why did you do that?
And
So
then,
you destroyed already.
Direct imaging may be difficult, so maybe get the guideliner and then image and see. Looks like the calcium is mostly in the prox and mid, and the lesion itself doesn't, at least angiographically, doesn't seem very calcified, so it may be good to know what that shows.
All right, so...
No, it's calcified even at the level SD. See that?
Calcified all over.
All over.
And these kind of lesions, when you have that big of an artery and it becomes like a sausage link, it's pretty high risk for no reflow also. So I know
You want to take a picture?
vasodilators and stuff, and you see pacemakers, you either give them or you need pacemaker in here because otherwise you're going to have issues.
Okay, so This is another thing. You see, already there is a concertina effect. So
Yeah.
it's good that we took a picture now.
Yeah, how you gonna deal with the possible rotablator and the concertina effect?
Yeah. Yeah, 100% it will cause a dissection,
Yep.
not 99, 100%.
It might be time
So
to
let us
just do
see
balloon.
how the Godzilla will behave now. Okay.
it causes
If
a
I can
dissection-
get past through that. Yeah.
If it causes that dissection, we're pretty lucky. If it causes a perforation, is a concern. The dissection
Yes,
is a
that's
given
true.
here. No matter what we do, this vessel is going to have a major dissection. We're going to stent that. That will be a good thing because this means we're going to expand everything. So let's see how it goes.
Now, once you have a concertina effect, sometimes the double wiring is not easy.
Yeah, no.
Okay.
Well, you made it
Went
look
through.
easy.
Huh?
You made
No,
it
this
look
is in the
easy.
PDA. Yeah, good. Now get us a balloon and 7 French. Godzilla.
3512.
And also what happens is now once we start this route, we got to be fast speed. Vessel can,
But you can see
Slow
that
flow,
the
lot of
vessel
things.
actually conformation has changed, which means that you have a good chance of getting balloon to yield because it's a flexible vessel rather than very, very calcified. So it's straightened out pretty decent. So it may be more deep than superficial than you think. We hope.
no, how you're doing? Okay. That's a excellent suggestion.
Yeah, Anu, now that you have the rota down there, why don't you just balloon and see if it with a 4.0 and just stand and leave the rota in case it doesn't yield? Make it easy.
Okay, I have a Godzilla going up. Let me get it a Godzilla down there, okay?
Now the Godzilla, what size is that?
7 French.
7 French.
7 French.
7 French.
Are you putting it over both
Okay, get
wires?
a balloon, 3.5,
I-
3.5, what balloon you have?
Are you putting the Godzilla
Okay.
over both wires or over one wire?
Yes, no, both wires.
Always,
The
yeah.
plan was both wires, and it's not going to go forward. Don't get, see, just stay there. Let's
That's what I'm making
balloon,
sure
and
we
then
understand.
if everyone is telling me try with a balloon, let's try with a balloon.
Yeah, I mean, this is very good technique. So 2 wires, and then when you take a balloon down and you inflate it, you actually trap the other wire, and then the guide extender inches in so nicely. So if you have a tortuous artery like that, this is the technique Anu is showing. This is what we should be using because it's very, very important. Look at that. So
Yeah. And I think the balloon will expand. What's the size of the balloon, Anu?
3.5.
3.5,
Okay.
yeah.
Yeah, this
Go.
That's 10, 12.
this big
Oh,
vessel.
man.
This big vessel always
You
works.
see that? You see that, Anu? There you go.
Are we
Yes,
too high?
okay, go up again.
Yeah.
So yeah, it's dilated. I am slowly advancing. You see that?
Yeah.
Gentle
I-
advancement.
I wouldn't advance any further from the
Yeah,
thing.
yeah.
Okay,
because
okay, down, yeah.
I would
Okay.
I would try this balloon, come back and push it again. If this goes, your stent will go.
Yeah,
Okay, so it's telling get into the Godzilla,
yeah, yes. Advance the balloon.
guide extension. Okay.
Yeah, your stent goes, no problem.
Question is the size of the
Okay.
stent.
Yeah.
Which size?
Okay,
are
yeah,
you
now,
thinking?
no, stent, I think what length we took?
3.5.
23 or 28?
28, we said.
4.0.
4.0 only?
Okay, the
You-
thing is, IVUS is
You
open
can
if you want.
you can
to put
actually
IVUS, we
IVUS
can
it
do an
now.
IVUS.
Your IVUS will go.
I think
So I would
IVUS,
IVUS it.
IVUS, okay.
Why don't we IVUS now? We
Yeah.
have all
Yeah, it's gonna be more
all
than
the
a
equipment
4.0.
ready.
I'm not taking a cine, okay?
No.
No. Just IVUS it.
Good idea.
Yeah, we're gonna be a little disappointed with
Take
the
the
Senate,
rotor wire.
so not
Let's do, let's do a IVUS guided.
Cine after the wires are out.
Yes.
The radiolucent part are out, yeah.
And your pressure is good. You see, when your pressure is good, your flow is good around it. So I mean, that's important. So I
Richard,
think-
IVUS on the screen.
Yeah.
Okay, Kiski.
Check the image. Okay, start pullback, huge vessel. It's coming.
Yeah, look
Huge
at this.
vessel. Yeah. It's true there was calcium, but it's modified.
Do we need a IVL or you think we can do it just direct stenting? Go
No,
back to the tightest
Yeah.
area it is.
no IVL.
So this is a
just
distal
stent.
reference is like a more than 5 vessel. And this is our lesion, but looks like there's a
Okay, looks like
plaques.
we have modified the plaque, right?
Yes.
Yeah.
Okay.
Looks
the
like you
vessel?
did IVL there, it cracked everything.
The vessel size, distal,
Superficial
size?
calcium, like Jas mentioned, yeah.
Dr. Kenny, there's also another tandem lesion just after the guide zero. There's
Is it
another.
tandem lesion or is it a
No, that's
I think that's pseudo lesion.
that's a pseudo lesion, yeah.
Yes.
There is no plaque there.
Yeah.
Yeah, there's no plaque, it's a pseudo lesion,
Yeah,
which
we-
Kiskil, come here, look at this. This
Yeah,
is something, another teaching point. When you
graphically.
that kind of a tortuous vessel, after you wire, before you get any of your devices down, document a cine. So you know what is a true lesion and a pseudo lesion. See, look at the angio.
Angiographic, yeah.
Yeah, you see that? Yeah, that's what I'm probably seeing with IVUS. So what should be the IVUS? So we probably wanted
Yeah.
to do a 4-row 28.
No, but what's the size of the
okay, so-
vessel? What is the size of the
Yeah.
vessel distally?
So this is distal to the lesion.
The
Even
diameter.
Okay, lumen is 4 vessel is
Okay.
like 5 vessel.
Vessel is 5-0.
Maybe
No,
four, five.
no 5-0. I think it's probably going to be 4-0 stand,
No,
right?
no.
Probably end
It's
up
a
with a
larger
4-5.
vessel.
You know what? It's ectatic. Even putting a 4-5 stent, I'm a little worried. Why
Yeah.
don't we go 4-0 and it's easy to post?
Yeah,
Post,
No,
4-0,
Pedro,
4-0,
what do you
because
think?
the
No, that
artery,
is what I think we should do. No?
artery is remodeled, and if you take a bigger stent, you'll perforate it. You don't want that. You just want to make sure you size it
So
according
did we
to the
decide length?
vessel.
I said 28. Hiski, what's your?
Shortest normal to normal minimum length is 22.
Why
20?
so long?
22.
22. Okay,
That's
give
the
me
size
28.
of the lesion,
quickly.
22, the length?
4-0, right?
Yeah, 4-0-24 then. Or
No, he's saying that,
4-0-23.
no, 23.
Yeah,
What
23,
also,
yeah.
we are not going to give dye. We don't have that luxury. So just put a long stent, then remove the axilla, and then you decide. But you need to post it, right?
Yeah, but maybe post it before we come out with the Godzilla.
Okay, then what, 4-5 you want?
Yeah, get a 4-5, 12 high,
No, 15. What do you have, 4-5?
15, yeah.
Okay, so we have to remove the rotor wire.
Beautiful.
Okay, I'm taking out the rotor wire. You want to give a little, I'm going to get the Godzilla back a little bit of dye. Pressure is okay, right?
Yep.
Just
Ready?
a gentle, yes. Okay, wait. Okay, good. Okay, now here.
It's good that the stent doesn't come near to the proximal tortuosity, so we're not going to have this
Some more dye?
straightening effect. Perhaps a dissection at the edge of the stem. A little bit further in.
You want more in? No.
Yeah, it has to go
that
more
seems
in.
okay. That seems okay.
Yeah, I think we are good. We're good.
A lot of pseudo lesions.
Pulling back a little bit. Yeah, that's a pseudo lesion there. Yeah. Pulling back. Okay, good. Okay, it didn't move. Okay, go up.
Going up.
Came back.
Get us the high pressure balloon. Down. Yeah, what length? Okay. Yeah, 12 is good. Go up again. I advanced the Godzilla just because if the high pressure balloon may not go.
Yeah.
So we had the rotor wire there, which we took it out. And now we post dilate and then we image. It's a big balloon, wait for deflation. Give me this syringe. Deflation may take time.
And double deploy.
And the EKG is behaving, so.
Yeah. To get us a post dilation and then we do a quick IVUS, then final picture. What's are we doing a next case or are we doing next lecture?
We have 3 cases in a row. I'm waiting. I think I'm waiting to hear if the next cath lab is ready.
Can you check?
I haven't gotten a confirmation yet, but seems like from your point of view, we may be ready to go to the next case in a few minutes.
I think the beauty here is going to be when you remove that wire, the radio loosened, and that thing goes away.
Yeah. Is the wire too far, Anu? PVC?
Done. We are done. We are all telling.
It's probably the pacemaker going in and out.
Okay, go up here. I'm going to remove the pacemaker. Okay, stop
Turn
the
the
pacemaker.
pacemaker off.
Yeah, there you go. Take it
Since
out.
it, okay, yeah.
That's 14.
And
Okay, done. I was ready.
Yep.
pre-dilate the more proximal too, Anu. Yeah, beautiful.
Yeah, I am here. Yeah,
Sure.
here.
Yeah, I would probably go
We're
for
not
sure.
going. We are not going real high pressure. We are like 16. Okay.
I think it's going to be on the IVUS. It's going to be well opposed on the plaque,
Okay, good.
but it's going to be undersized for the vessel size. With the 4-5, maybe okay.
Yeah.
We go up here. We want to go higher.
You know,
Let's
16, 18.
let's give a little nitro and see how.
Okay,
we
good.
do.
I was ready. No, I think let's IVUS EKG good so far, and at the end we will remove the
No,
wire.
I'm saying
remove
we
the
got to give a
calcium.
little nitro before the IVUS. That's what I'm saying.
Oh.
a little verapamil, but we don't have the pacer anymore, no?
No.
You guys wanted it out.
Now we want it back in.
Now it's a mega RC.
Yeah.
Okay, so nothing wrong if somebody says I want a
The
pacemaker.
next case is not ready,
If
so we
there
have
was-
to extend our time. Put pacemaker back in.
You're going to IVUS now, Anu?
Yeah, I'm going to IVUS now,
Yeah.
and we're going to give a little bit of nitro. Okay, nitro here to keep everything going.
It
Okay,
just,
good.
somehow I don't like that Godzilla down there.
No, they'll come up because listen,
Your-
after
your-
IVUS,
your
I'm
pressure
taking
is
it out.
good. You know, you have a big balloon, 4-5. Sometimes you pull it out. You know, Anu is very methodical. You want to let it bleed back
Yeah.
because otherwise you suck in
Yeah.
so much air.
Oh,
When
yeah.
you inject nitro and stuff, you cause no refill
Yes.
with
Okay.
air. So
Can you show the IVUS?
Okay, hold on.
Yep.
Look,
It's not there yet.
you don't
yeah.
have wire purchase? Yeah, it's not there. It's going now.
It's, you may have some plaque protrusion. That's why you're having difficulties. It's a lot- it's a
Okay,
huge-
just do what you can.
Yeah.
It's not that aggressive.
Start to look.
Yeah, pull back. Does it
Yeah.
look okay?
I see the protrusion.
Wherever we
there.
are.
Looks great.
Proximal edge,
They're expanded.
well opposed.
Well, we can't see
Now-
because it's foreshortened. So let's take it out and release some
No.
some
Let me do one
tortuosity
thing. Let me
before
take
we
this out.
see what's
So,
happening.
yeah.
no, the stent looks perfect. There is no dissection,
Yeah.
and stent is well opposed.
Yeah.
And
MSA
Exactly.
is like 10.5. So, Dr. King, can I show it to you again, please? So, this is proximal to today's lesion. There's also another calcified lesion, nodule lesion.
Okay, what's the MSA there?
It shows like a
Okay,
two
now,
something
Yeah.
before our lesion.
And just bleed.
okay, bleed.
Now
Looks like this is a focal
Okay,
calcified
then
nodule
we're
lesion.
going to give some nitro.
Yeah.
I think that was the area where you had
Exactly.
a wire bias, right?
Yeah,
And
yeah,
then
yeah,
That's the
Wire
that's the
bias is
pseudo
making
lesion.
it 2.7.
Yeah.
Okay.
Oh, let's see now. Why don't you give a little dye now? Yeah.
Okay.
Yeah, looks
Yeah,
good.
it's gone.
Case is done. Case is done.
case
Go
is
to the
done.
next room.
Yeah.
Wire
Okay, ready?
out, good picture, low mag.
Go.
Let's go for the next case.
Yeah.
Hold on. Low mag.
Low mag.
Hold on.
So okay, and we need to get the orthogonal view as well.
Beauty. Bravo.
Well, the distal is just a little
What we
bump.
learned, complex
good.
case made simple.
Absolutely.
Right? No, orthogonal
Well,
view
it
given.
was
So
a
let
thought
us do an
process.
RAO view
No,
here.
it's how the things behaved and how the bias was. You avoided complication. I mean, this is a very, very instructional case. You don't get hell bent on doing orbital or rotational and stuff. Just see how the artery responds, and that's exactly what you did, which is
I don't think
which is
it's helping
amazing.
us. Maybe the straight cranial would be better.
But the
No,
teaching.
we want to one thing that is it a true lesion or is it a pseudo?
Yeah, that's
and
right.
let us bring this what's called as Hitchcock's window so that you can see poor man's IVUS.
You're going to
Yeah.
do RAO?
Yeah.
Go
just,
more, go
I don't like
45.
normally.
Go more RAO.
Yeah,
Okay.
maybe little.
No, it's no more. I'm more going Mario.
Little caudal. will
Well, let's
open up
take
that
this
area.
picture and we adjust because it's
Yeah.
tortuous very eccentric.
Yeah,
I would leave everything alone.
I think it's great.
Right?
Your proximal edge of the IVUS looked amazing, so I wouldn't touch it. It looks
Yes.
good.
No,
Yeah.
I will not.
Yeah, perfect.
Okay, low mag, because
All right,
Bravo, Anu,
who
bravo.
wants low mag.
excellent. Are we ready in the next cath lab? We can proceed.
We also clap for
Hold
Dr.
on,
Sweeney.
otherwise I have to show you something, because when I
Terrific.
did my AI presentation, the
All right, very good.
video never played.
Excellent, thank you.
show you
And
the
before
video.
you
Good
start
job.
your next case, you show us the result of the previous one. Dr. Sharma in the next room, please.
Okay, are we on?
Yes, we definitely are on.
Okay.
We see Dr.
All right,
Sharma,
so-
Dr. Huda, and the chief fellow
Yeah.
next to you.
And all the fellows here, the both Gaurav and Tushar. And this is a case number 7, 77-year-old female who had a angina positive stress test and has a LAD and very tortuous circumflex disease. And we did the LAD, and now we are here for the tortuous circumflex. Let me show you. If we can go to the angiogram, good from point of view, appropriate because patient has a chest pain and positive stress test. You can see there, see on the top, the circumflex with the lateral ischemia after having done the LAD PCI continue to be symptomatic. So we try to do many different views to kind of unmask it. The tortuous very calcified, looks like a very simple, small, short lesion, but look at the proximal circumflex tortuosity. So here you see, right there at the center below, here, this view actually shows it.
The best.
Where calcificate proximal, 90% lesion, we were able to wire with the fielder wire, and actually fielder wire did not make a first turn. Then we wired with the run through, and you see it going to show. Actually, run through made this gradual turn, and we have a fine cross that time. And after the wire is sent, and it's surprising. I mean, you will think that it is good for hydrophilic wires, but it was a run through finally made. But that's where we were. The fine cross will not cross the lesion. All the torquing, everything we did not go forward. So we felt that now do what? So let's ask what people will do. One, of course, when you have uncrossable lesion, you think about the laser. We are getting the laser warm up. And what are the other choices which people will have? You ask your panel, and then we'll show what we are trying to do. In
how
this
about,
uncrossable lesion, wire has gone.
How about the turnpike? Is there any difference between the different categories?
Good. So that's where we are going with the turnpike now.
Dr. Barman?
But anybody else had any
other
idea?
microcatheters in the west side of New York?
I mean, I think there obviously are differences between these, but I think
Wire
it's
is
a
out.
cumulative support. Obviously, you have a femoral. I mean, I don't know if putting even a very proximal lesion, a guidezilla, probably is not going to help. But yeah, I would try that, or potentially a Corsair. If I use a teleport, if that doesn't work, I'll upgrade to a Corsair. But I'm pretty bothered by the tortuosity in terms of how we're going to modify this lesion and the decision making there. So,
Dr. Singh?
The wire is stuck.
Yeah,
Went a little bit.
You know, I think you're gonna probably end up putting this microcatheter, take that wire out, put a rota wire, and probably go with a 125 burr and do it. You know, if you really wanted to do it, the other option is just leave that run through in there, take a laser, inject a little bit of contrast, modify the plaque, and then cross it. That might be those are the two options to do. I think rota is tough here because that band is there. You have to be careful, and Samin has done so many of these. So I think that's probably the way to go. Otherwise, I don't think you're going to heal this lesion.
agree.
Yeah. Okay. So we were able to get our, but it's stuck. Wire is stuck.
Well, let's see if it goes a little further.
Yeah.
No, the counterclocking, yeah, maybe it goes. A little bit more counterclocking.
Good.
So now look at the tortuosity of this catheter.
Very good, excellent. So, you know,
Okay.
micro
So now,
catheter-
as suggestion made by Jazz, we're trying the 1.25 rota bar, see how it makes the curve. If we start seeing a much deceleration, I'll stop, because by the time in about next, 1 or 2 minutes, we'll be ready with the laser, right? Or 4 or 5 minutes.
Yeah,
and so-
when you see these tortuosities, when it folds onto itself, when you put the burr and you push the burr and the wire buckles, sometimes you can actually cut the wire.
Cut the wire, yeah.
And the burr will go right through the circumflex. We've seen that before. So I think, you know, but now it's straightened out a little bit when I saw that. So I think you may be okay there.
I think to that point, it's also important while you're burring to change the position of the wire so that you're not at the same spot on the wire for each pass.
It says, you think this is all calcium or is super fibrotic?
Calcium,
lesion?
very high calcium.
Yeah, looks,
Yeah.
even the LED looks very.
Very high calcium.
Yeah.
Yeah,
Again,
very
it
high
is
calcium.
very
So let's try
challenging,
1.25 bar, very cautiously 1.25 bar. All right.
Very challenging cases, both in a highly tortuous and highly calcific. The other one is a little bit bigger, able to deliver the balloon, and we didn't have to see the rota challenge against the tortuosity, but here it seems like we will see that.
Yeah, and this is one scenario you don't want to go 1.5 because of the bias. You will gutter the whole artery proximally where the tortuosity is. This is one scenario. Really, when you have this kind of anatomy, I think starting with 1.25 is probably, you know, the best way to do it.
And you navigate that.
After the,
Yeah, question. You navigate that proximal tortuosity with the high speed?
well, let's see, maybe try to bring it down with the low speed.
Yeah, just Dynaglide
Dynaglide,
as
yeah.
far as you can, and then
Yeah,
just
Dyna.
gentle pullback, and then do it at 150, whatever. You know, I usually do 180, but you know what? 150 probably where to go.
Very nice teaching case.
Is frozen?
This is kind of the type of case that a front-facing shockwave device where we can deliver energy through the tip of the catheter, because ideally that would be the safest, but of course there's no chance of the current device being
Absolutely. I mean, that's the
deliverable.
same scenario as a laser with a little contrast, which gives you close to, you know, more than 50 atmospheres. And if you really are careful, it gives you 100 atmospheres. So you can modify the plaque and break the calcium and then do the stuff too. It's very similar with the forward javelin kind of thing that you're talking about.
A small explosion.
The other question, it says, you thinking rotatripsy here? Or
Well, I mean, yeah, that will be the plan once we get the rotor. So I'm not even sure, we'll see that how it behaves. Remember, the deacceleration, you get the triangle yellow. At 5,000, 10,000, you get the filled yellow triangle. And then, of course, the burr stall become red. So we'll try to see how the burr behaves with the tortuosity. And if it has a trouble, many of the tortuous, like Anu showed the case, you need a 7 French Godzilla or guideliner, and then you can get 1.25 bar. Will not go through the 6 French. So we are ready here, 1.25. And as I said, we'll start cautiously, the low speed of 150, and a lot of challenges.
yeah, and also the decrease in the speed, we learn and we practice with a high speed. If we're planning to navigate that tortuosity with the Dynaglide, what will be
so clearly that you're absolutely correct. So that if the proximal area, maybe we pass with the Dynaglide, and then when the lesion comes, there we can do our regular speed. Okay. So what we are going to do now, the same 3 steps, back and forth here, and then usual, rather than the Dynaglide, we just see the tap, and here. I'll try to advance on the Dynaglide.
Oh.
Yep. Wow.
Wow. Advanced quite a bit.
Yeah, beauty.
Yep.
Surprisingly.
So far, so good.
Yeah,
Which
but,
I says SFSG.
Yes.
Well, the problem becomes is you better you have to careful, come back, and then sometimes you can get trapped like this if they go through tortuosities.
Yeah.
So you just want them to come back, and that's why that might be, you know, advisable to do 180 in there, just to make sure you have purchase and you don't trap the burr.
What speed are you now?
That's the speed
jumped.
right there.
Sorry.
You like that speed?
The right
Come out.
appropriate.
We worry about this kind of a jump, but there was no choice here. Our balloon is ready.
Just a little die now. Huh?
Well, when it jumps like that, it gives an impression that it passed by being ablated. So
We
we're
don't
going
need
to
the
see how
lesion.
things go.
Stop it. Yeah. So get a over the wire system in case in this particular case. Remember, we may have to, the channels, our same.
Fine cross is fine.
Take a little angio now.
All right. See to believe it. Ready?
Yeah.
All right.
Okay.
Not too bad.
Fine cross.
Much
Let's put it-
larger
no,
vessel
no.
now.
No.
Yeah.
Well, it's
Big
much
vessel.
better.
Wow.
Well, I think it did ablate.
Yeah, it must have. Looks huge.
That's why she has so much angina.
Yep.
Yeah,
So now I'm going to pass my run through which originally crossed, and then we have a 3/12 balloon, right?
Yeah.
Yeah.
I mean, as somebody was saying, sometimes it can dart in and out, and you may not ablate, but this looks like it did, right?
Yeah.
Yeah,
But
it
perhaps-
had a little bit of resistance in the proximal part, so I think when that happened and then it jumped, so I think you got decent amount. I would probably bet, shockwave would probably not cross this. I just do balloon and see what it does.
No, I don't think it would deliver with
Guideliner.
what Josh did shockwave. But
It will
let's
not
see
go
how the
without
balloon
guideliner.
goes.
Maybe it's time for a
Godzilla.
show.
But-
Maybe it's time to show what the lithotripsy can do here with
What is this?
navigating that. Question here is, should you go with the balloon or you go with the IVL now?
No, I think first the balloon.
Balloon,
because-
okay.
No, I
Yeah,
would,
and
You won't- you
you
won't
may
cross,
still need
huh?
IVL. No, you may still need IVL. But first we have to go balloon because I don't think this alone has done the full job.
Okay.
We still have to open the lesion.
Yep.
And then IVL, we already have the plan that we're probably going to use a 3O IVL, and we are starting now with the Godzilla right here.
Yes.
Good. Got the balloon.
you have two wires in place. If you have two wires in place, if you have the thing, you just use it like a poor man's cutting balloon, and I think it should yield.
Yeah, but this is a 6 French guide, so the 2 wires won't
Yeah.
hold the Godzilla, that's a problem.
I mean, very tough, because remember, wire movement was very tough.
Forget it, yeah.
You're going with 3.0 or 275 balloon?
It was a 3O we had earlier.
Get it.
Yeah,
Get a
2.5
2.512 compliant balloon.
Hmm.
2.512 compliant balloon in this case right now.
Wow, it's going to be a lot of work here.
Yeah. It was very tortuous. No, but how can we hearing AK in this?
SS, is the wire a little more free now, or is it still?
It's still very tough. It did move earlier a little bit, but it's stuck between two things. Okay, let's try again. Now this is a 2.512. Remember, that is the answer for the
Yeah.
IVL, because even
Yeah.
these balloons are giving a trouble.
Yeah.
See?
So laser is still an
No,
option,
no,
right?
but what's the wire? The wire comes by all the way back. We need to have
Yeah.
a lot of wire.
I know.
Yeah.
Maybe a smaller balloon.
Yeah,
This
well,
is-
I mean, the other thing would be to take a wire, another
Or
wire,
1.5.
and straighten it, and then you'll
At
go.
any time, we have a break for a couple of minutes. Dr. Kinney wants to show us a video of case number
Okay.
5.
Go,
Why don't
go.
we do that, and then we come
Yeah.
back? Okay,
Yeah.
Dr. Kinney, you're up for the video.
Laser is still an option.
Where is Dr. Kinney, though? Where is the video? We see the video somehow.
They're done.
Gotta take the trash out.
Oh, you just want to listen? Okay. Yes.
Parasuram, do you hear me?
Yeah, we can hear you.
Yeah, we're asking for Dr. Kinney here.
Dr. Kinney has to
She just
show a
stepped out.
video.
Okay.
But where is the video? We have a situation there that we get.
Yeah, a video is coming.
The video is coming. Very good. Very good.
AI is preparing it.
No, let's do future direction.
It's
I don't know if we could see it.
AI brings the video.
No, not yet, right? Not yet. Don't show it. Okay, no, go take it out. Take it out.
The video is playing already. We see the ambulance.
Yeah. Okay, good. So this is where, no, hold on.
Okay, now we see the
When we
slide.
mentioned all the future direction for all the AI work that we are doing in Mount Sinai, if you see the fifth one, which is care coordination, which includes a combination of the AI's, sub part that I had discussed. So care coordination will be a combination of agentic AI and the natural language processing. So we're going to show you what is the STEMI 2.0. We are starting with STEMI, but it will be expanded to the other. So this is the person walking on the street, falling down, calling EMS. STEMI is going, EKG done on the field, and then you have the phone call from the ER doctor to me. I'm accepting the case. There is Sophia doing all the coordination, patient already directly in the cath lab, and we are doing the STEMI. So instead of 90 minutes, we hope we will make it 30 minutes in this kind of cases to really save lives. That is the STEMI 2.0, including Sophia into
you will inject it or we will
agent
inject?
that's going to coordinate everything.
We need the assist, right? Okay. Done.
Very good. Excellent. Let's go back now. Can you show us, you
Beautiful.
ready to show us the final result of the previous case, or we'll go back to Dr. Sharma?
No, Sharma, because we are late.
No, previous case we already finished, RCA.
No, the one from the morning, I'm saying. Okay, we'll do that later when you join
we
us.
can show that.
Yeah.
We can show that.
Let's give it to them.
No.
All right, let's go back to Dr. Sharma to see where he's at. All right, he's made a lot of progress.
Oh, look at him.
The balloon is there, and the
Look at him.
Godzilla is there.
Okay. Yeah, so we are able to get our Godzilla dilated with the 1.5 and then 2.5 balloon, and that's where we are now. Very slow injection once you have it.
Beauty.
Yeah, I think it's okay.
No,
We just
very
put a stent there. Now, we have gone quite a bit, right? Lesion is proximal to the...
Proximal to the bifurcation.
Perfect.
Yeah. So we can dilate. Maybe we are not dilated completely here, because we have to bring back...
Yeah.
1 second.
Yeah.
One second.
The lesion is clear of the bifurcation, so that's a good thing.
Yeah. Go up, yeah. All right. What was our plan with the stent strategy?
Yeah. We were thinking maybe.
What is stent?
3 or 20 synergy.
Good. Get it. Get it.
We can take longer now. What do you think?
No, 20 is good. 3 or 20. Get it. No. So question was that do we need to do any other adjunctive ablative therapy? To me, if you put a stent, looks good. If somebody wants, is very dying to see IVUS, we can do it. Although we have shown so many IVUS, maybe people developing some IVUS toxicity. And next one, we are going to show the OCT.
Dr. Baber will talk about that.
All right.
Very nice.
1 second. Let's adjust it correctly. This is the 3-0-20 synergy, right?
Yeah.
They'll die. I think good. Go up.
Can we come back?
Well,
Tell them, are they ready? AK, they're coming there. Yep. Okay. See it to believe it. We have to just dilate extra there. Right? 3.258 high pressure. And then if we want, we can do the IVUS. If they are not ready, are they ready on the other side?
No, they're not ready
Yes.
yet. Oh, room 3?
No, we are ready.
Okay.
We are ready, room 2.
Room 2.
So then,
What is this?
There's a run through
Yeah.
now.
Here
and
and then
OCT is coming up.
No, come.
okay, you are
Oh, we are
live.
live?
Dr. Singh,
Okay,
any-
case number 8, if you can show the case number 8.
We are seeing case number 8.
Yeah.
Go right ahead. 72-year-old male with dyspnea on walking one
Yes.
block.
Guriev,
Dyspnea on walking, and if you see, what happened is the dyspnea was walking was related to significant coronary risk factors, but normal EF, okay, severe aortic stenosis. So he had a mean gradient of 41, okay, and then what happened is came to see me as a part of TAVR workup, had coronary angiography, so which had shown 2 vessel disease, calcified significant disease of the LAD as well as the circumflex, OM1, OM2 bifurcation. So syntax score, if you see borderline, so this is where I am, the discussion always comes when they see us somebody with a young age means, not young, borderline, less than 65 should go for definitely surgery, 65 to 80, 85, somewhere where we zone where you have heart team discussion, especially if it's 72, significant CAD, that should we consider for AVR plus bypass. So the heart team discussion happened between physician and the patient opted for PCI plus TAVR. So since the lesions were tight, when we say tight, about 90-95%, and a young guy, we decided let's do PCI first and then TAVR. And I think during the top 10, Dr. Sharma did mention, because in Europe, I know most of the time PCIs are done at the time of the TAVR, but we try to do it before and then do the TAVR later. Borderline cases, sometimes we do it afterwards. So now the question comes, LAD was done, RCA was non-obstructive. So you see the LAD that was, your cranial picture?
Yes.
Nicely done.
Very good.
Calcified. Yeah, so now we have this lesion.
Yeah. Well, it was
Yeah.
definitely a dominant
Bifurcation,
branch and a side branch.
yeah. So in the CT scan, it said calcified, but here in angiography, looks borderline in the sense that we don't think we see any calcium. What is happening?
Setting up the OCT.
Okay. Can we do hands?
Yeah.
Okay, so we have OCT ready just to understand, plaque morphology.
Yeah.
It's going to be very, very thick superficial calcium with AS and stuff like that.
Come.
Chances are that's
Bring
very
the
bad calcium.
OCT closer to us. Where is the Kiski?
Yeah, I'm
Okay.
here.
So you're going to tell me when to inject?
Yeah, I tell.
So Dr. Singh thinks it's superficial calcium. Let's see what the OCT says.
Close.
Now, a couple of points before we do OCT. 2, if the lesion is tight, you have to, when you are...
Can you show that OCT on the...
No, we're going to see that there is a...
Yeah.
You see a blood flow clearing.
Yep. Can you check the path?
Ready?
Yeah.
Good. Go. Do you see clearing?
Yeah, good.
Okay.
Okay, 1 second. Enabling, 1 second. Calibrating. Yeah, please, cine, inject. Yeah, beautiful image.
Good.
You can take it out.
All
So
right.
it has to be done right.
Dr. Moreno, get ready to comment on the OCT.
Okay.
Okay, flush.
The quality is high.
Whatever it is the OCT says, Dr. Singh is right.
I did angiocholesterol.
I don't understand this superficial and deep calcium. Yes.
Why is not taking you're saying re-enter?
Well, it looks like
Okay.
the software, the acquisition was good, but some kind of reconstruction is
Okay.
high quality, that's for sure.
This is our lesion.
Yeah,
So this is the
it
plaque
has
subset.
both.
It's definitely, this is
Very
like
deep.
360, not that thick, but it's calcium.
Yeah.
And our tightest lesion is, this is definitely something protruding. and the surface is kind of smooth. But anyway, it's a calcified nodule. Calcified nodule.
Nodule?
Yep.
And go to, where is that calcium you showed us?
Yeah, proximal to the nodule. You see the like 360 calcium here.
Yeah, 360
Not
calcium
thick,
there, yeah.
Yeah, but this is calcium. So substantial calcium proximal to the and distal to the lesion, and something protruding inside. Sometimes it mimics the red thrombus, but based on the OCT criteria, it's calcified nodule.
Okay.
No. Yes, we understand, but based on the OCT criteria, does it meet your
Well, do we need to do the rota is the question.
The rule of 5. Can you discuss what is the rule of 5? What are the rules that we use?
Sure.
That if your calcium is 180 degree, which is 0.5 of the circle, right? 0.5. So that is 1. Then the thickness of the calcium has to be 0.5.
Yep.
And then the length 5 millimeters, right?
Yep.
Then you give the points. So
First, like this orange color, this AI integrated ultrasound, it detected almost 360 calcium. So it's anyway more than like 180 degree calcium. So arc is more than 180. And the thickness I measured, this is more than 0.5. And the longitudinal length is also
all 3 points.
This is the start of the probe.
3 out of
it's
3
more than
made.
5 millimeter.
okay, so what we are saying then you have to
3
do
out of
rota.
3.
Yeah, this
4
is
out of 4.
Top of that, you have a calcified
it
nodule.
means that the non-compliant balloon chances of yielding this lesion is very low.
Less.
It doesn't
Yes.
mean that you have to do rota. You could probably lithotripsy this thing.
Yes, and I was thinking the MLA, what's the MLA?
Yeah, I think you're okay with lithotripsy. I
No,
think.
diameter. Go get us the diameter of the vessel.
Yeah, the MLA is larger than the diameter of the
Give us the
Where's the diameter of the tightest area?
1 second.
Yeah, here.
I
Minimal
come back to
diameter.
the nodule part. So
Yeah. Nodule is right where the ectasia
Sure.
is. You don't need to worry about nodule right there. You just need to worry about 360 calcium, which is, the lumen is enough. I think shockwave probably will go through this.
Is 1.45 the
Ah, shock wave will.
No, diameter is 1.7.
nodule part MLD is 1.45, and a 360 calcium part MLD is 1.9.
Not
No, that's
MLD.
the diameter.
You mean
Yeah,
diameter, 1.9.
1.9 he says.
Diameter, yeah.
Okay, so we actually have published, and what is a publication that if you have 360 degree arc of calcium at the level of the nodule. Now at the level of the nodule, he is telling us, can you show us the nodule algorithm by the side? That at the level of the nodule, we are probably saying is 2-quadrant calcium here. In that situation, you have to do rotational atherectomy or orbital atherectomy. Then you decide you want to do IVL or no. So let's go. So, but about the burst size, we probably will use like 1.5 or 1.75.
Well, given that he has severe AS,
1.75.
well, let's given that he has severe AS, maybe you want to go with 1.5, but let's give it a shot. 1.75 she wants.
Yes.
What's the size of the vessel distally? Is a 3O vessel?
Yes, just after the lesion, 2.9 vessel.
2.9.
No, 3O vessel. Give me another
No,
thing.
it's a very
or
big
another, the diameter MLD at that 360 calcium?
1.9.
1.9. Okay.
Yeah.
Your primary lesion is 360 calcium. Your distal nodule is really luminal compromise is not that much. So shockwave may not be unreasonable, but I understand the algorithm that Anu is trying to teach us is when you have that, because of the nodule, I think, atherectomy probably is better in those scenarios.
It's real.
Okay, give us a rota, open 175.
What balloon? 3.5.
Huh? 3.5? 3 to 5, right? That is the 3 to 5, 15 high pressure balloon.
Yeah.
Now there is that side branch, right? I think for the side branch, that's also reasonable. 2.5 millimeter vessel.
I will forget about the side branch.
Yeah. These AS patients, sometimes we give them aminophylline and stuff because, with AS patients, they brady down with rotaplator, so you have to be careful with that. I don't think they have pacemaker, but, sometimes you want to give them aminophylline because sometimes they spiral down very quickly when they brady down. So just be careful with that.
Yeah, let's go simple, provisional, rota to make people happy, stent, and we're done.
And that's a good
So
point.
you're saying, don't forget about the side branch?
Yeah, I
How
wouldn't
many
worry
people
about
are
the
telling
side
me,
branch.
forget the side branch?
Yeah, send flowers.
Don't flowers? No, I don't like flowers for the branches. I like flowers, but okay, if everybody says so. Okay, ready?
Yeah, off carpet.
Yes. Okay, done.
So for the audience, Dr. Kinney, remind us your algorithm to use ROTA instead of the lithotripsy, in this case by the OCT. More than 1.5?
Okay, so yes, so if you see the algorithm that's playing by the side, right? So what is the key is the MLD at the lesion, that's one, and the calcium plate around the level of the nodule. So the so MLD is giving me is 1.9, right?
Yeah, 1.9. Yeah.
1.9, 1.7. So let's do ROTA from here. So in that situation, you definitely need at least 1.5 bar. No, I'm saying I'm doing rotational atherectomy. If someone tells me, no, I want to do orbital atherectomy, since the arc of calcium is 360 degree, that's okay also. Okay, good. We are the one also, we published that shake it or shave it. That how do you handle nodule? Because there's always a question, how do you take care of the calcium nodule? So in a nodule, you always see some calcium around it. So that is the key. So if you have more than 180 degree calcium around the nodule, you need some kind of atherectomy first, and then plus after imaging, you can decide if the atherectomy has done a great job. That means you have nicely shaved it. Then you go and just do a balloon. If it has not taken care, then you may want to consider IVL, especially if the plate, the calcium around that nodule is more than 180 degrees, like we're talking 3 quadrants, 4 quadrants, you definitely need something more than just a ROTA or IVL for the nodule. But again, the point we are making is that nodule will, respond to either ROTA or OA.
Somehow the
Slow pecking motion.
somehow the bird looks larger than 1.9.
Yeah. Oh, wow. I'll try once more. I think we did majority of the area, right? And then we come out.
You increase the speed? Speed is how much?
Now, 175, I would not want to increase the praise. It's giving 155, right? Yeah. Oh, go up.
What's your speed right now, Dr. Kinney?
155, 155.
Maybe you need a little more, no?
No, but you know what Anu is doing is patience. I mean, this is what you need is patience. Just take your time. There's no reason to rush to go through the lesion. We make mistakes. We just want to push through the lesion. Let it behave. Let it walk. It's going to cross. So you just got to be patient. Any atherectomy for that matter. We just get impatient, but this is a good illustration of just being patient. It's very thick calcium, so that,
And also there's a bend there.
Yeah.
So.
Okay.
Undersized?
May not be unreasonable going to 1.5 and coming back for this?
Come down. No. Okay. What we'll do is run through, and then we can just balloon it.
Yeah, that's the other option. You rota the mouth or the entrance of the lesion.
We rota probably 80-90% of the lesion, so we can just.
Yeah, if the rota had
175
going, the
maybe was a little
balloon probably
too
won't
aggressive.
yield the lesions. I might consider just doing lithotripsy now.
Okay, you know what? We can repeat with OCT. Give me a run-through wire.
If you think it's going to cross, the lithotripsy may not cross.
OCT ready? Yep. The only reason of multiple runs of OCT is dye use. But Kiski will like it because he can now give a clear idea of the lesion modification, right?
Yep.
Kiski? This is going to the side branch. It's telling me, save me. Okay. OCT is ready?
Yeah.
We can do hand injection only.
Sure.
Okay, give me. So I have the rotawire, I did not take it, and let us just do the OCT, see how it is. Ready, Kiski?
Yes.
Ready?
Yeah.
Okay, tell us.
Yeah, can you check the path again, please?
We are not ready yet. We are attaching the syringe. Forward. Okay, you tell us when we should go.
1 second. Can you
Okay?
check the path?
Okay.
1 second. Can you check the path?
Okay,
Yeah,
puff.
clearing now.
Yeah, good clearance. 1
Okay,
second.
good.
Okay, enabling. 1 second.
Mm.
Enabling. Yeah, cine, inject. Yeah,
Nice.
great image.
Just tell us how far from the side branch the nodule is, distally.
What size balloon? 3 to 5? Yeah, 3 to 5.
Training and your calculation. Yeah, confirm. Okay. Check the image. So this is a distal normal landing zone. This is a nodule part. Yeah, I mean, this is just after the loader. We didn't balloon.
Correct.
But see, Dr. Kinney, so like 11 o'clock, there is like a dissection and a fracture, and the surface is like shaved.
That's a nice
yeah.
fracture.
Well, okay, nice fracture. Where, can you see the nodule?
So nodule part, like here, still some radial
So
blood.
the entrance.
But yeah, but here, okay,
distal,
so
yeah.
here looks like the shape, the surface of the calcium nodule.
Yeah. Where is
shaped
your
by the
side
loader.
branch?
So we have shaved it. That's it.
Yeah,
Now
you did,
Let us go
you
with the
did.
balloon.
Yeah.
And just, stent it.
Yeah.
Yeah. And there's some
So that's
dissection in
exactly
the.
what our publications are. And actually this algorithm, both have been published. The calcific nodule algorithm Kiski actually presented last year in ESC. And if you download the Calcific app, which is we have upgraded in a recent version 2, everything is mentioned.
Yeah. And now distal reference lumen 3.3, so we can put at least 3 stent. Lesion length by OCT is 12.
Okay, good.
Like 11.2. So 3 or 12 is the recommended stent sizing based on the OCT.
Beauty.
And the proximal part, you can do at least 3-5 post-dilatation.
Look at that.
Yep.
Beautiful.
Example.
Yeah.
If you modify the plaque and you do these micro, breaks, that's all you need.
So IVUS is telling me you can take a 3.5. My eyes are telling me take 3.5. What is the?
This balloon
Yes,
was
so
3.0,
this balloon-
Anu? The size of the balloon?
3 to 5. 3 to 5. High
3
pressure
to
3 to
5.
5. We went up to 18 atmosphere. Yeah. Now let's see what the side branch is doing.
Good.
Whoa.
Beauty.
Okay. Side branch is listening to Pedro Moreno.
Yeah, if it goes down, it's my fault.
We're long now, right? Yeah.
3520.
20.
Yeah.
Get us a 3.520.
Maybe longer?
Synergy.
Look at that lesion below, like.
Now
see
then
it?
you have to go 3.0 because distally, then if you want to do something longer than that, will be, I think there's no disease, right, Kiski?
Yeah, just eccentric disease distally, I wouldn't mess
Yes.
with that. I would just put a shorter stent right past that branch.
But I think the distal vessel was 3.3, wasn't it?
3.3, yeah.
25 maybe too big.
20, 3.5?
Yeah.
What does the OCT tell you, Kiski?
Distal difference EEL is 3.8, lumen 3.2, so 3.5 is yeah, exactly recommended one based on.
So the EYE, IVUS, and the OCT are matching. Let's go. So everybody agrees we are not doing anything to the side branch. Actually, side branch looks much better. We're not even going to wire the side branch.
Yeah, the only thing I would say is, you know, when there's calcium and when you have fracture of calcium, sometimes you shut the door, even though there's no disease and the vessel is good. So in this calcium, because of definition criteria, sometimes I put a wire in when you stent it, because if you pull the carina and a fracture of calcium goes in the lumen, it can completely shut it down. So putting a wire is not unreasonable, but I think your big balloon didn't do much, so you think you're okay.
Okay. We are having trouble with every single stent delivery today. Okay. So you see what I did? I made the guide more coaxial, yeah. Luminal, okay. We took out the rota wire out. Some dye. Okay, good. Go up.
Yep.
Final OCT?
Yep.
Down. Okay, and what's the next round now? Lectures?
Yeah, we have lectures.
Okay.
But we want to see, before we move on.
No, we are going to do a final OCT. Let us OCT. Since we are going to do a cine with the OCT, let's not do another cine right now, save some dye.
Yeah, we recouped the delays. We're only 7 minutes behind, so we have time.
I think the first two cases
Yeah.
were the tough cases, which we still did manage, and everything else we are good. Okay, good. Hold the wire. Ready? Ready for the final OCT and the final picture.
Yeah, there will be a little bit of under expansion at the proximal, but I will probably leave with it because post-dilating. Let's see.
Yeah, can you check the path?
Clearing.
Yeah,
Wow,
good.
okay.
Okay, one
Now-
second.
Mega vessel.
A second. Okay, enabling, 1 second. Calibrating. Yeah, please cine, inject.
Nice.
Beautiful.
Got image.
Looks beautiful. Any questions regarding the algorithm? Anybody from the audience? I've never had a question from the audience yet.
What's going on with the audience? A lot of people here. Questions? Okay, will be a question. Show us the stent pullback.
Yes, so.
Can you show 3D or no?
Yeah, we can.
Okay.
1 second. Yeah.
A little dissection there.
Yeah, well expanded. Yeah, I'll show you the proximal edge. Yeah, here, well expanded, and normal position, and no dissection. And I see some calcium fracture behind the stent. The
Yeah,
stent is well expanded, like 7, 8. Yeah.
Looks good.
Yeah, looks great. Well expanded.
Okay, Kiski
Okay.
is super happy. We are
Yeah.
done.
Yeah, everybody's happy here. Dr. Kinney, thank you so
come on.
much.
Very good.
We're going to move on. Yeah. Applause for Dr. Kinney. And it's really my honor to introduce the speaker, Dr. Moller, who is professor at the University of Southern Denmark, but he's also a senior consultant of the cardiac intensive care at Copenhagen University Hospital. He is Mr. Cardiogenic Shock. He published in the New England Journal of Medicine last year the seminal trial, Danger Shock Trial, that shows a significant benefit, saving lives in the cath lab with the Impella CP. So, Dr. Muller, welcome.
Well, thank you for having me here. These are my disclosure. I have the same disclosure as one of the former speakers. I'm not an interventional cardiologist. I'm a cardiac intensivist, so the last 45 minutes I've been mortified that somebody would ask me a question how I would manage that case, which would have been really embarrassing for me. So I'm going to talk about something I know a little bit more about, which is cardiogenic shock. And of course, it starts in AMI shock with the occluded coronary artery, but what really triggers all the disaster that's happening after that is that the cardiac output decreases to a critical point where the body is not supported with enough oxygen. And then all of these disasters happen, and if we don't interrupt that, the patient will most likely die. Given this, it's kind of intuitive that mechanical circulatory support could be beneficial. We have to realize that these patients come in very different phenotypes as well. So there's the LV predominant phenotype, which is a large myocardial infarction with extensive loss of contractility, and these patients usually have more than one diseased vessel, or it's a left main problem. And the predominant way of dying for these patients is from refractory shock. The other phenotype is the cardiac arrest phenotype, which is very different from this. In that case, there's a sudden loss of circulation. When circulation is restored, the heart recovers faster than in the LV predominant shock form, and the main mode of death in the cardiac arrest patient is from anoxic or hypoxic brain injury. So what are the evidence to treat these different phenotypes? So this is the ECLS shock trial that most of you are familiar with. 417 patients were randomized. Inclusion criteria was a lactate more than 3 and a systolic blood pressure of less than 90. And it was allowed to be resuscitated for up to 45 minutes in the trial. It was a large multi-center trial. 44 sites was enrolling patients, and they ended up with 78% cardiac arrest in this study. And I think that surprised Holger Thiele and the study group that there was such a high rate of cardiac arrest. Likely it was the high lactate level, I would guess, that drove this high rate of cardiac arrest. Most other trials and registries have 40 to 50% cardiac arrest in this type of population. But a very sick population, lactate was very high. Blood pressure wasn't that low, which means that some of these patients were probably responsive to vasopressors. As you know, there was no difference in 30-day mortality. There's no difference in 1-year mortality, and there was an excess of complications. The IMPRESS trial in 48 patients compared balloon pump to Impella CP. It was also a cardiac arrest trial, really. 100% of the Impella patients and 83% of the balloon pump patient had suffered cardiac arrest. And in this scenario, the mechanical circulatory support did no benefit. In our practice, we don't see that many cardiac arrest patients need mechanical circulatory support. So this is data from the BOX trial where we in Copenhagen and Odense randomized almost 800 patients with cardiac arrest. We had a 2x2 factorial design. The main intervention was a blood pressure intervention that we published a few years ago. But in that population of 800 patients, about 40% would have been eligible for ECLS shock trial. And we used mechanical circulatory support in less than 1% of these patients. And they actually had a pretty favorable one-year outcome with a mortality of 37%, which is not too bad for a cardiac arrest population. So when we designed danger shock many years ago, we really wanted to target this LV predominant shock phenotype. And we did that by targeting patients with a high lactate as a sign of hyperperfusion, low blood pressure. But then we excluded comatose cardiac arrest, which made the study a lot harder to do. We didn't really realize when we designed it how much harder, but more than 50, like for enrolling these 360 patients with AMI shock, we excluded 450 patients with cardiac arrest. So doing this, we made it tough, but I still think it was the right choice to do. Patient could have arrested, but they just had to regain consciousness, and then they could be randomized. We only had 14 sites, and for the first 5 years, we only had really 3 active sites, and it took us 5 years before we got funding to be able to expand to Germany and the UK, and we never really came close to the 44 centers that they had in ECLS shock, which is also a reason why it took us so long to enroll these patients. 20% had some cardiac arrest before randomizations. There was a lot of multivessel disease. The lactate was quite high, and blood pressure was a lot lower in our population than in the ECLS shock population. We had very little crossover, which is a strength of the study. We met the primary endpoint just barely. We heard about the fragility index. It was 4, which means that if 4 patients had crossed or had different outcomes, we would have had a neutral trial. But still, it's a pretty powerful signal, I think, in such a small population. But it is, of course, fragile. And we did see a lot more complications with these devices. We collected, or we went together with Holger Thiele's team and did this meta-analysis and tried to find patients in the other MCS trials that looked like the danger shock patients, and with a larger sample, we still had a significant sign of benefit in these highly selected patients. This has been hugely discussed since the publication. There's been so many discussion, and even just now there's a paper coming out in JACC Heart Failure that only deals with danger shock and all the things we did wrong and the things we did right. And it's just incredible how much focus it has gained. I'm just going to touch about a few subgroups. This is not a study of pre-PCI versus post-PCI. We randomized when we saw shock, so it could be before or after PCI. We did not see any interaction with the timing to the effect of the device. But we saw an interaction that if the time delay from onset of symptoms to the patient was randomized was more than 12 hours, there seemed to be less effect of the device. The other thing that has been discussed a lot was the fact that it looked like there was no effect in women in the study. I discussed it quite a lot with Roxana at ACC, where we presented the data, what the cause of this was. And at that time, I thought it was women are smaller, they have smaller groin vessels, smaller hearts. It's more difficult to have the device running well there. this was completely wrong. What was the reason for this was that women are 10 years older than men when they get their AMI shock. And really importantly, they come much later with their shock before they are admitted. So the time delay from onset of symptoms until randomization was more than twice as high or twice as long in women as in men. And this really, to me, explain, given the data we have looked at with age and time delay, that was the reason why it looked like women had no benefit. And if we look at women in the study of less than 77 years, we see the same signal of benefit of the device. So I don't think it's a sex difference in the treatment effect. I think it's the phenotype of women and men, the way they present with shock, that is different. This is a PCI meeting, so I want to share a little bit data from the PCI results of the study. So there was a lot of multivessel disease, and curiously, there was almost 50% or 47% of the patients in the study had multivessel PCI at the index procedure. So it was not staged PCI, it was at the immediate revascularization. These data we just presented at EuroPCR, and opposed to the culprit shock trial, where it was, as you obviously know, was more complications and higher death with multivessel revascularization. We kind of saw the opposite signal in our study. This is, of course, hugely biased data, because you would likely not mess around in a lot of vessels if the patient was in really severe distress in front of you. But it is an interesting signal that kind of challenges the culprit shock trial a little bit. What was really curious was how little it changed the culprit shock. So this slide shows how often there was multivessel PCI in the patients before and after culprit shock, and there was no difference. It didn't change the behavior of the PCI operators, and interestingly, it was identical in Denmark and Germany. So it was not that the Germans followed. This is what people did. There was nobody did CTOs or rotablation in these patients. So lastly, we should not forget that this always comes at a price. When we put these devices in, it cannot be without a price. So there's a downside to mechanical circulatory support, and we saw that very clearly in danger shock. So this slide just shows how much the rate of complication increases with the complexity of mechanical circulatory support, with Igmella patients having 64% BARC 3 to 5 bleedings, 75% were on renal replacement therapy, and 11% had limb ischemia. So when we use these devices, we should really use them wisely. And that's why kind of the way I envision this, and we did this paper together with a lot of good colleagues in Europe and David Morrow from Boston, is that when we evaluate these patients upfront, decide whether or not the patient is an MCS candidate. And then is it comatose cardiac arrest? If it's not, it's reasonable to go the danger shock way, you could say. But if there's an RV failure or an oxygenation failure, you should go for an ECMO. If it's not, it can be reasonable to use an impeller. If it is cardiac arrest, be more patient, revascularize, optimize the hemodynamics. And if that is working, you should just continue what you're doing. If it's not working, evaluate cardiac output before the patient is put on these devices. And I think it matches pretty well with the guidelines that were discussed earlier today. And with that, I thank you for your attention.
Well, that was a wonderful presentation. Now we're going to move to our interventional controversies number 2. It's going to be 30 minutes of interesting data, and the first speaker is Dr. Ichapuria. She is endowed professor at the University of California in Irvine. She's the past president of the American College of Cardiology, and she is really a fighter for innovation and fighter for equality, making a lot of progress at the California Department of Public Health and the World Heart Federation. Dr. Ichapuria, thank you for coming.
Thank you very much. Thank you to the organizers for having me. So I'm going to talk about intravascular ultrasound, making it a class 1 indication, not just what the guidelines say now for the high-risk cases, but for all cases. I have no disclosures. As we know from just this conference alone, the evolving role of imaging in PCI, as you see, the PCI complexity has certainly increased with certainly more challenging anatomies, indications in high-risk patients. And we have certainly made advancements in physiology and imaging that now span the pre, peri, and post-PCI phases, right? And we know societal guidelines have increasingly endorsed physiology-based as well as imaging-based lesion assessments. So we know that angiography alone has limitations in terms of lesion and stent assessment, and intravascular imaging, including IVUS, OCT, has demonstrated multiple benefits in multiple studies. And during this talk, I'm going to talk about some of those. And this is widely now being used not only to assess vessel size, but plaque morphology, lesion severity, guide us with stent placement, as well as optimize procedural outcomes. So, and we know that despite all of the technological advances we've had in PCI, guess what? Peri-procedural complications still occur and late adverse events remain non-negligible. And for these reasons, I'm making the case that intravascular imaging should be considered class 1 indication in all coronary interventions because of improved safety, enhanced efficacy, and long-term outcomes. So we already saw this earlier today, both the European guidelines in 2024 and earlier this year for ACC guidelines. Now intracoronary imaging is now considered class 1 recommendation, up from the class 2A that it was in the past. But for both the European and American guidelines, it's mostly for complex lesions. But we know from this paper that was published in JACC last year, 2023, or 2 years ago, intravascular imaging provides information that improve procedural and clinical outcomes. So if you look at the pre-intervention assessment, we can assess the plaque characterization. We did that today, looking at the cases. Do we have 180 degrees worth of calcium? What are the things that may have, what are some of the reasons that we may have failure in terms of the intervention? What is the reference zone, and what is the right size stent that we can utilize? And then during the procedure for lesion preparation and stent deployment, we want to know what that landing zone is. We want to prepare the lesion, determine what the preparation strategy, and really make sure that we are going to optimize the vessel for optimal stent expansion. And then post-procedure, determine if the stent is under-expanded, deformed, or maladapose. We want to make sure there's no edge dissection, hematoma, or tissue protrusion, and also make sure that we did not have any geographic mix. So you can see how it is utilized throughout the whole process, pre, during, and after in terms of imaging. Well, in terms of intravascular imaging, there has been an accumulation of supporting evidence spanning from 2011 to now. Various studies that are listed, large randomized trials that have shown IVUS guidance significantly reduces major adverse cardiac events, MACE, down from 5.8 to 2.9. These are some of the studies. I like to look at it visually. And one of the things you'll see is that when you look at the target vessel failure cumulative incidence, you see these studies have shown an improvement by utilizing intravascular imaging, and not just in any lesions, but in long lesions and all comers in the ultimate trial, and then the renovate in complex lesions. So the intravascular imaging data helps us with helped with consistent, meaningful reductions in terms of target vessel failure. This was a study that Greg Stone put out in Lancet last year. This was the network meta-analysis of 19 trials, 13,000 patients, 1,021 events. And what they did was they looked at the target lesion failure. This was angiography compared to intravascular imaging, PCI, and what you saw in the primary endpoint was a 31% reduction in the target lesion failure driven by 46% decrease in cardiac death, 20% decreased target vessel myocardial infarction, and 29% target lesion revascularization. So really good heart endpoints. The secondary endpoint, interestingly, 52% decrease in the stent thrombosis, and then a 25% decrease in all-cause death and 18% all-cause myocardial infarction. So these are all the reasons to do intravascular imaging in all patients. We've just shown data for improved outcomes, decreasing that major adverse cardiovascular event. Enhanced precision. These studies have shown that we do better stent sizing, apposition, and we know that IVUS leads to further optimization of the stent lesion in up to 30.2% of the lesions, and also in terms of making sure that there's no complications such as dissection or malapposition. We know there's a safety advantage because underpinning the safety advantage of intravascular imaging guidance is this 50% decline in the risk of definite or probable stent thrombosis. And then low risk. Complication rates for intravascular imaging are less than 1%, shown in the PROSPECT trial. And we know in general that intravascular imaging complications are uncommon, but certainly can have vasospasm, dissection, perforation, arrhythmia, or thrombosis. Just like any time that you instrument a coronary vessel, these are possibilities. And certainly we have to be careful if it's a highly tortuous vessels, as we saw today in some of the cases that we looked at. So I know what Dr. Baber is going to say. There are going to be skeptics out there that says, no, 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 you cannot do imaging, and everybody, imaging is unnecessary in simple cases. Well, I'll tell you, even simple lesions benefit from imaging to optimize stent placement and reduce the complications. The central illustration shows you the clinical uses of intravascular imaging. There are many, many reasons to use intravascular imaging for pre-intervention guidance, peri-procedural post-PCI, as I've mentioned to you. So certainly something for us to think about, particularly if we're interested in, as what Marty said this morning, it's all about the patients, and what we want is to reduce complications and do best by our patients. The skeptic is going to say, well, I know, maybe you're right, but it just takes so much time and it's so costly. I don't really want to. If Sunil Rao was there, he would say, wait, Dipti, what about the cost? Well, we know it's fairly time efficient. You saw today in the cases, it only really adds 5 to 10 minutes to the procedures, so there goes your time issue. What about cost? Well, although I think initial cost and learning curve exist, it really improves long-term outcomes, as I mentioned, decreasing restenosis, decreasing the revascularization rate, and don't forget that 50% decreased stent thrombosis. So ultimately, this decreases the repeat interventions and hospitalizations. And the data does show that it doesn't matter what type of patient, general coronary disease patients, diabetic patient, ACS patients, impaired renal function, there's cost. If you look at the cost incurred to treat patients through the lifetime, they do better with intravascular imaging. What about the last skeptic, which says it's a risky procedure? I mentioned to you earlier, it is a low-risk procedure. The data shows from all of the trials that the complication rates are less than 1%. And then the last, and I know this is the one that probably most people say, well, you can use it, but there are lots of interventionalists out there that don't know how to read these data. What if they make a mistake because they don't know what to do with this data and they may cause more harm? Well, I will tell you that conferences like this, and certainly ACC, ESC, they all have training modules and things. The training is, there are many, many opportunities to get trained. And then certainly for our fellows, the training has become fairly straightforward. The guidelines support a broader adoption. And the table 3 that's shown over here is programmatic recommendation for the intravascular imaging. This was put out by the Interventional Council for ACC. And this says what operator level education should be, institutional level, and then national level. And the national level, it says training programs should prioritize exposing trainees to an adequate volume of intravascular imaging to achieve competency. And then the last bullet, professional societies should continue to develop and offer lifelong training opportunities and competency tools. And I know ACC does that, even with hands-on experience. So these are things that we can overcome. This is not something that should be a roadblock. So I would say in conclusion, I think this is a call to action. Intravascular imaging improves outcomes. Clearly, there's data to support that. It's safe, it's feasible, and it's cost effective. And I think it's essential in every case because better imaging leads to better outcomes and better care. And what did we hear from Marty? It's all about the patient. Thank you very much.
Okay, so we have a good argument here. Dr. Usman Baber is going to say, no, we may not need that for everybody. He's the director of the University of Oklahoma Health Science Center, but most importantly, he's a pearl from Mount Sinai Hospital. He was director of the Cath Lab Quality Outcomes Research, and paired with Roxana Meran, really exploded the amount of science of that specific center. Dr. Usman Baber was co-author of the Twilight Trial and many others. Welcome, Usman.
Great, so wonderful. So thank you, Dr. Moreno, and I really want to thank Doctors Kinney, Sharma, and Moran for inviting me here. It's been gone for a few years, and it really is special to be back in New York with friends, colleagues, and my mentors. Dr. Chaporia has done just an amazing job, and I've got to confess, I essentially agree with her points, so I have the unenviable task of hopefully convincing or at least providing a rationale for why our current guidelines and societal recommendations are a bit more restrictive in how we deploy both IVUS and OCT. These are my disclosures. Now I'm going to start off with a framework and a couple of points that in 2025 are really not up for debate any longer. Point number one, I think we all can accept that intravascular imaging certainly improves the efficacy of PCI. This is principally by reducing TLR and TVR. I think we can all agree that intravascular imaging enhances the safety of PCI, reducing target lesion MI and stent thrombosis. And as Dr. Chaporia just mentioned, procedural risk is certainly not prohibitive. There is an upfront cost that is incurred. And so the debate, to the extent one exists, is really centering around whether we should be a bit more restrictive in utilizing these tools in those patients and lesions most likely to sustain ischemic events post-PCI. And I'll try to support that premise by reviewing a few of the trials that have substantiated the benefits of IVUS and OCT and illustrating that they really have enrolled high-risk patients and lesions, illustrating some data that shows the variability in clinical benefit as a function of patient and lesion risk, and then finally, the financial calculus, which is again driven really by patient risk and the perceived magnitude of benefit. So let's go through a study, Renovate Complex PCI. So this is a trial conducted in Korea that compared intravascular imaging predominantly with IVUS use versus angio guidance. And in this trial, the authors define complex lesions or PCI's true bifurcations, long, severe calcium, ISR, multivessel PCI or CTO, about 50% presented with ACS. No question, these are high-risk patients. And after a 3-year follow-up, you can see that the primary endpoint of target vessel failure is significantly reduced in absolute terms by almost 5%, relative terms almost 40%, and you also see about a halving of risk in cardiac death and numerical reductions in target vessel MI and TVR. So very positive result. What about OCT exclusively? Here are the data from the European trial, the October trial, which compared OCT versus angio guidance. Now this is again complex lesions, this is complex bifurcations, and left main bifurcations were actually 20%. Side branch stenting was needed in 2/3 of these patients. And over a 2-year time period, you can see the primary endpoint of MACE, which is really target lesion failure, was again reduced by a large 4% absolute risk reduction, relative terms 30%. Some excess contrast and procedure time with OCT, but certainly not sufficient magnitude to mitigate any benefits. Another nice positive result, again, highlighted in complex lesions. Now, as has already been mentioned earlier today, is the ultimate trial, from which we, of course, get the ultimate criteria. Now, this was a trial comparing IVUS versus angio in a quote-unquote all-comer cohort. I put that in quotations because if you actually look at the features of these patients from a lesions perspective, about 2/3 were AHA B2C, average stent length was 50 millimeters, and that perhaps is just a reflection of the reality we live in today in the contemporary PCI era, where the majority of patients actually will fulfill some type of complex lesion definition. And in these 3-year data, you can see the primary endpoint of target vessel failure is again significantly reduced by IVUS, again about a 4% in absolute terms, 40% relative, and also significant reductions in stent thrombosis. So these trials and others similar to that have really demonstrated the clear benefits of these technologies, but again, in high-risk patients and lesions. Now, what about insights on the variability of benefit in relation to patient lesion risk? Do we have any data to suggest we'll get more benefit in higher risk patients? Well, we do have some insights. So here are 2 trials comparing the exact same strategies. On the left is October, OCT versus angio. On the right is Illumian 4. Both of these trials, again, comparing the exact same strategies, both of these trials recruited, enrolled, and followed up patients in a time period that overlapped with the COVID pandemic. And both trials had almost the exact same endpoints, target lesion versus target vessel failure. The big difference in these trials was whereas the October trial focused on complex bifurcations, Illumian 4 was a bit more heterogeneous in the types of patients they included, diabetes or complex lesions. And you can see that in these trials, the control event rate in the October trial was right at 14%, yielding a large reduction with OCT, whereas in Illumian 4, the control event rate was 8%, yielding a non-significant result with OCT. Now, there are many other cited reasons that perhaps led to the null result in Illumian 4, but as the accompanying editorial suggests, I think we can't ignore the fact that the difference in outcomes was certainly maybe related to the types of lesions included in each trial. Now, again, this is a between-trial comparison. What about a within-trial comparison? So this is, or these are data from a post-hoc analysis of the ultimate trial at 3 years. And what the authors did here is examine the event rates in IVUS in vertical blue versus the angio guidance in vertical red in relation to procedural complexity that was defined, as you can see at the top of the slide. And you can see on the left a clear reduction, about 5% in absolute terms, significant subgroup p-value. And now on the non-complex on the right, again, there is a benefit. It's just much more modest, and at least in the subgroup, p-value is non-significant. So we see at least some insights that there is a variability of benefit in relation to patient and lesion risk. And for these reasons, we see a consistent theme that is being articulated across societies and recommendations. ESC giving a class 1 for IVUS or OCT in left main true bifurcation long lesions. The ACC Interventional Council in their paper does promote and strongly advocate for the use of intravascular imaging, but again, as an essential adjunct for specific lesion subsets. And then finally, the most recent iteration of the ACC AHA ACS guidelines, a class 1 recommendation, again, predicated on left main or in complex lesions. Now, what about the financial calculus? This is something that kind of, I think, makes us a bit uncomfortable. We don't like to think about finances impacting what we do, but the reality is they certainly do, and we have to understand where these costs originate and how we can get cost effectiveness or benefit. So when it comes to these technologies, obviously there is an initial capital outlay. If you want to install any one of these technologies, there's a significant upfront cost, which does render some labs unable to have both and some to not even have one. Every time we use one of these catheters, there's a cost there. We all know that when we use IVUS or OCT, what we're ultimately doing is either using more or larger balloons or perhaps adjunctive devices, which add additional cost. And at least in the U.S. healthcare system, these upfront costs are unfortunately not reimbursed. They are borne by the hospital or the cath lab, whereas the financial benefits are realized by the payers downstream. Now, from a societal perspective, this may be really just fine and not a problem, but this framework and this construct is certainly not ideal when you're trying to run a lab or a hospital department. And as Dr. Chiporia mentioned, we do have cost-effectiveness data. So these are data from the Renovate Complex PCI trial. Again, these were high-risk lesions and patients. This is from the Korean healthcare perspective. And as you can see in this simulation, in this graphic, after about 7 years, the cumulative costs in the angio arm in red begin to exceed the cumulative costs of the IVUS-guided arm in blue. Now, in this simulation, this cost-effective analysis, like any others, are essentially predicated on some key assumptions. And one of those assumptions is, what is the event rate in the population that you're studying? What is the durability of benefit? And what's the magnitude of benefit? And in the accompanying editorial, the authors highlight that the rates of mortality in MI have the largest effect on any cost effectiveness. Again, standing to reason that it's those patients and lesions where we're going to get the most benefit. Now, finally, perhaps we don't need to be debating, should we be using IVUS or OCT in complex or non-complex lesions? I completely agree with Dr. Chipuria's point. We're simply not using these technologies enough. Even if we made the bar complex lesions, we're nowhere near that. This has been cited in multiple studies. These are data from the National Readmission Database looking at over 1,600 hospitals, 1.3 million procedures, and you can see in the vertical blue that illustrates the profound, substantial variability in IVUS or OCT use across hospitals. Only 15% of PCI procedures were guided by intravascular imaging, and what was really insightful in this analysis is that the authors controlled for patient level, procedural level, and hospital factors, and there was still a 4-fold variation in use, indicating that it's something about us as operators, perhaps training, perhaps lack of comfort, perhaps perceived other barriers that I think is really the call to action, as has been mentioned. And I think the authors' points are exactly on correct, that their results highlight the need to improving adoption, training, and application of intracoronary imaging to guide PCI procedures in the United States. So I don't know if I won the debate, but hopefully when I go home, my son will at least think I did. So I'll end there. Thank you.
Very good, Usman. Fantastic talk. Now, it gives me great pleasure to introduce Dr. Greg Stone, who's really a superstar in the interventional cardiology field. He's Director of Academic Affairs in the Mount Sinai Health System. He's Professor of Medicine and Population Health Sciences, over 130 multi-center randomized trials, 2,500 publications, Dr. Stone. Welcome.
Thank you. Well, great. Thanks so much, Pedro. And now for something completely different. And I'm glad I don't have to debate anybody. So what I'm going to talk about now is something you've heard a little bit less about, but that is referring to the potentially upcoming and practical use of post-PCI physiology to improve outcomes in patients undergoing PCI. Okay. So we think we do a great job with PCI, but for a variety of reasons, a lot of patients have recurrent angina. And actually, the more and more you look at this, the more you see that about 20 to 40% of patients within 1 year have recurrent angina. And yes, some of this is because of microvascular disease, and or vasospasm and other phenomena we're really learning about. But a lot of the reason is that we don't do as good a job treating epicardial coronary artery disease as we think we do. So there have been a number of registries that have actually looked at this with either FFR or with IFR, and in about 10 to 20% of so-called successful PCI cases, just in the target vessel alone, the vessel is still ischemic. So these are several of the registries here showing some of that data. And we wanted to really prospectively define this. So Alan Jeremias and I ran a study called Define PCI, where we, in a multi-center fashion, took 500 patients with both stable and unstable angina, and we did a spot IFR, and we found significant lesions. The IFR was less than or equal to 0.89, and then we told the operators to do PCI per standard of care. They could use intravascular imaging, but just get an optimal PCI result. And then we did a blinded IFR with an IFR pullback. So the operators were not being biased, and treated the patients with medical therapy and followed them for 1 year. And what we found was the baseline IFR was 0.69 was the mean, and it rose to 0.93 after the procedure, but 24% of the time, it was still less than or equal to 0.89. So about a quarter of those vessels that had, quote, an optimal PCI result still had an ischemic IFR. And when you looked at whether or not those abnormalities were focal or were diffuse, with focal being defined as a step up of 0.03 units within a 15 millimeter segment. About 82% of the time, it was a relatively focal lesion. And in about a third of the case, the focal lesion was proximal to the stent. About a third of the time, it was within the stent. About a third of the time, it was distal to the stent. So you could actually come up and say that, well, we could probably make those focal lesions better. Either you have to put another stent in to treat focal areas of ischemia, or you can improve stent under expansion or whatever is causing the problem in the stent. And if you could treat all of those residual focal disturbances, you could theoretically reduce the rate of residual ischemia from 24% to 5%. And as usual, as we've learned with everything in physiology, you can't tell from the angiogram which of the vessels are ischemic or not. Looking anywhere up and down the vessel, whether or not the QCA diameter stenosis anywhere was always less than 30% or greater than 50%, that did not reliably predict an IFR of less than or equal to 0.89. So here, for example, is a case from defined PCI, and you could see it was a tight distal LAD lesion. The IFR in the distal vessel was 0.39. And we're talking about trying to normalize the IFR in the entire vessel, because that's ischemia. So of course you say, well, there's the severe lesion, and so the operator treated that lesion with a long stent, okay, 2.5 stent, post-dilatation, got a nice result. And the IFR blinded now is 0.74. Okay, so still highly ischemic vessel despite that. And when you looked here, where was the problem? Believe it or not, most of the problem was actually in this one area, proximal to the stent, that looked like it was about a 30% residual stenosis that wasn't treated, but it actually was a very severe lesion with a very severe step-up. Now, we actually looked to see what was the optimal IFR that then predicted long-term outcomes, in particular cardiac death or spontaneous MI. And it actually wasn't 0.89, it was 0.95, suggesting that if you could really get nearly normal of course is 1, but if you could really get to 0.95, you would minimize the likelihood of patient having cardiac death or spontaneous MI. And here are the one-year curves of spontaneous MI or cardiac death, 3.2% if you had an IFR of less than 0.95, and 0% if you were above 0.95. And if you look at death, spontaneous MI, or clinically driven target vessel revascularization, again, a significant difference. So it's not just repeat revascularization, it's more hard events. In addition, if you took patients that were severely symptomatic, and I won't go through all the data on this slide, but the bottom line is by getting above 0.95, you could make patients asymptomatic. Where if you were highly symptomatic and you were below 0.95, in this series, there was still about a 12% incidence of angina at 1 year. So here's another case example. Here's kind of a diffusely diseased LAD, and the IFR was 0.88. Okay, and here is the post-PCI result. Okay, so think to yourself, is this pretty good? Do you want to leave this? Do you want to put more stents in it? Well, here, the blinded spot IFR was 0.9. So not 0.95, but at least it's above 0.89. Okay, and when you look to see where the lesions were, you can see there was a 0.05 step up distal to the stent. The stent was pretty good. There was no step up in the stent, and then there was a 0.05 step up proximal to the stent. So now look carefully, and you can see, yeah, there's 30% stenoses proximal and distal to the stent. But the operator already put in a really long stent, and he didn't want to put in 2 more stents. So he left it alone. And what happened? 41 days later, the patient came back with a target vessel myocardial infarction with what looked like a thrombotic lesion distal to the stent. And then what did he do? Then he put in 2 more stents, 1 proximal and 1 distal. So IFR co-registration has made this much more facile when we're trying to assess these lesions, and it lets us do interventional planning to see how much of the ischemia can we eliminate. And you've seen this in the Philips system, where when you assess the IFR on a co-registered pullback, it gives you all these dots, and each of the dot represents 0.01 hemodynamic units of the IFR. So here, for example, is a distal IFR of 0.63, 3, and across this selection, you could see that's a 0.32 drop. So most of it is right in there. And you can see at each point, the dots line up on top of each other. So you can imagine that if you were to eliminate all of that, all you've got left is these 3 little distal dots. So you should be at 0.97 when you're done. That would be fantastic. On the other hand, here's a more diffusely diseased vessel in the LAD, and the operator was planning on stenting across this white line with a 38 millimeter stent, and you would see that would improve the IFR by 0.16. So that would get you to 0.91, but that wouldn't get you to 0.95, kind of our magic number. And to do that, you'd have to treat either more distally or more likely you would treat the more proximal lesions. So, as I mentioned here, you'd expect the IFR of 0.97 after a 24 millimeter stent, but here after a 38 millimeter stent, you only expect an IFR of 0.90. Not terrible, but not optimal. So with this in mind, we have run the defined GPS or guided physiologic stenting trial, where we took 2,151 patients with either chronic or acute coronary syndromes, and we randomized them 1-to-1 to either IFR co-registration guided PCI with GPS or standard of care PCI. You can use intravascular imaging in both of these cases. And in the IFR co-register guided PCI, we would do an IFR pullback. We would do planning, as I showed you with the co-registration, and then after the procedure, we would do a pullback to see if there's any residual disease that we've left, with the goal of trying to get to an IFR of 0.95. So we would do much more aggressive stenting to do this. We would treat a lot of lesions that you would probably normally leave alone, and we would also really try to optimize the stent. And if we saw problems with physiology, that would actually prompt use of intravascular ultrasound or OCT if the operator had not used imaging before. So it's really a much more aggressive approach to treating coronary disease to try to really optimize physiology. The primary endpoint is MACE at 2-year follow-up, and I'm really proud to say that we've finished enrollment in this trial, and we're now in the follow-up phase. So probably in about 1.5 years, we'll get you the results of defined GPS. So in summary, invasive pressure wire-based physiology is currently used principally to assess the hemodynamic significance of focal stenosis to guide lesion selection prior to, but for PCI. A substantial proportion of vessels after PCI remain ischemic, which may in part explain recurrent angina and contribute to increased MACE rates during follow-up. IFR pullback can be used for interventional planning prior to PCI and to assess residual ischemia after PCI, the optimization of which may improve patient event-free survival. And we've now completed enrollment in the pivotal defined GPS trial in more than 2,000 randomized patients to answer this question. Thanks very much.
Well, that was a fantastic exposition of post-PCI physiology. We're going to start doing that. Now, we may have time for one question from the audience. It's a very quiet audience. Feel free to interrupt whatever we do if you have a question. If not, let's see how are we doing in the cath lab for our last 3 cases of the day. Dr. Sharma, are you there? And what about Dr. Kinney? Well, while we wait, let's raise your hands. How many of you actually know what percentage of your cases you do intravascular imaging? Okay, what percentage? How many? I mean, we use it here and there, but do we know our personal percent? That's a good way to start, to see if you are in the low 10, 5%, or if you're doing 40, 50%. Somehow we have to motivate ourselves and to do a class 1 indication. And one way to do that, believe me, is to see your own data. Very good. Now we're going to break for 15 minutes, and we're going to move on after that.
We have to call the precinct, 110 precinct, to find out where Dr. Moreno is. Okay, but where is he? Is he arrived?
ここ先にやるんですけど、次あっち OCT するんで、もしかしたらしてもらうかもしれないし、僕が散ったらここの、で、レフトメインは狭くなかったんですよ。で今からサークの IVUS をライブでします。あ、わかりました。あ、もう後でいいですもん。
IVL is 3.5 or you want to wait? Open in 3.5 IVL.
Okay, is Dr. Moreno there?
Samin, we're waiting for Dr. Moreno, I believe.
You want to moderate? You start, my friend.
You want me to do that?
You start. Yeah, please. Yes.
Okay, everybody, welcome to the last session on live cases.
All right.
I'm your relief pitcher. Go ahead and let's see the first case, Sabine.
All right. Okay, show the slide for case number 10. Good. So this is an 80-year-old patient, had a tower, sapia, evolute, just a month ago, and at that time found to have a left main and multi-vessel disease. And that's the question is, we brought this patient back, continues to have symptoms, and because the left main, even if you have no symptoms, every study has shown in the viable patient, you need to take care of it. So if we can just go to the angiogram directly. So you see that basically the groin was fine. We are through the evolute valve. We are supposed to be FX plus, but I don't think it's the commissural alignment. Look at that hole, which should be the diamond of the FX is not against the left main. And this is where we are. We are able to get, this is the VL30. And we can see there, I was able to, what you do in these cases, there's not enough support, so you advance your wire and the Godzilla. So this is where we are, actually, the advance with the Godzilla. Now you see the left main. There's a clear-cut 80-90%, very calcific left main, 80%. And then we thought that it may be, we did the IVUS, that it's a left main, and Kiski can show the IVUS run before we show the other cine. Okay, IVUS now, please.
Okay,
good.
Start to work. So this is approximately, this is a previous stand, some calcified ISR borderline area. Now come to the left main bifurcation. Here's some eccentric nodule, but I show you the tightest left main.
But left main is not tight, right?
Eccentric lesion, but area-wise it's 6.5. It's more than the cutoff. So.
And what about the LED?
Sure. So now go inside. This is a bifurcation, and this is the osteo LED.
Yeah.
Wide open. And here is the previous stand. There's a 360 calcium, but area-wise it's like around 3 point something. Like it's a borderline LED.
Okay. So now, this was a little surprising to us. So we said, you remember, we saw the 70% left main in the RO view. So I said, why that is? So this is now with the second injection. We go back to injection now. We did in RO caudal view, injection now, and look at that. To our surprise, it is more of the circumflex. Look at that. Left main going into the circ. Looks like this is a tighter lesion, and we are ready now to do the IVUS with a little support, as you can see there. Now we put a run-through wire into the circumflex. Godzilla is there, and I'm doing an IVUS of the circ now.
Yeah, it's a good point about having to get multiple angles on a bifurcating left main.
Looks like the circ is
Easily
missed.
Easily missed when
and
it's
all panelists have come to the stage there now?
Yeah, all the panelists here.
Except Dr. Moreno.
Yeah, I'm here.
No? We just call 112% to find out where you are.
So the IVUS show like an 8 is an oblique.
Yeah, except the, yeah, so
area.
the left main is very good. And now this is the, let's say, where is the wire going? This one going. Yeah, good, good, yeah. So we are there. I don't want to bring back my guideliner. Okay, let's start.
Okay, I check the image. Can you, okay,
1 second.
start to work.
Start pull back.
You see this, sorry, can you first? Yeah. Okay, I'll show you. Looks like osteocirc is tight.
And what about the left main there?
1 second. So, yeah, osteocirc has eccentric like cursor nodule.
2.9.
Then this, oh, it's a, sorry, guideline I engaged, so we don't see the left main of this pull work. But
Yeah.
we saw the osteocirc and
And there's a circular calcium or how?
eccentric calcified nodule, osteocirc.
There's calcified nodule.
Yeah, and the other half is plaque free. Like 6 to 10 log is the calcified nodule.
High pressure balloon first, always.
No, I think that's the shadow of the wire. The shadow of the wire is impending into the measurements. Try to measure again.
No, but here, but look at that. But there is a almost circular calcium in the circ, and we have what? 3.1?
3 of 15.
3 of 15 high pressure before we go to the IVL. I don't think it's a case for rota because you saw the guide is miles away from the origin of the vessel. Look at this one. See, the guide is so far away. So this is all work being done by using the guideliner. So this is why we have our published paper in 2018-19 by UD in the JAC, how to engage the coronary arteries, and of course then intervention with the various catheters. And we made the very clear-cut point that lot you will need in these cases, particularly more so for the self-expanding valves, that you may end up in using this guideliner the way we are using right now. Okay, go on.
So it says you're precluded by
8,
the
10,
by the
12.
guideliner. You cannot use 2 wires or balloons. So you're
Yeah,
not
exactly.
protecting the LAD.
So that's why I
here.
took the wire out. I took the wire out. I
Yeah.
mean, you can use it, but in this particular case, it will be a little tough.
Correct.
Because remember, the guide catheter is probably pinching on the guideliner.
Correct. Now the plan is to stent the distal left main or just the ostium of the circ?
Yeah, to me, no, but to me, our plan is distal left main to the circumflex now.
Correct.
Based on the lesion, because LED is the borderline for this patient. Go on.
That's it. So you,
just
you-
a great
After the
example.
balloon and IVL. Tell us if anybody else feels differently.
It's just a great example of how limited you are when you don't have that alignment that allows you free entry into the left main.
Are you able to manipulate
Yes.
the guide at all when the balloon's inflated? Sometimes you can add the coaxiality.
Yeah, no, we tried actually earlier. On the Godzilla, the guide does not go through the diamond.
Gotcha.
Yeah.
Samin, I think
But yeah.
this is going to be educational in many ways, but I think the best teaching part of the case has already been established. Dr. Babar just showed a slide that 15% of the operators are using imaging. Just imagine if without imaging you would have just entered the left main and probably gone totally wrong.
Yeah. So question is the very good point. So before we became so, I would call it a gung-ho on this imaging, what we could have done? We would have done with this kind of a picture and try to do
Rota off the
I
left
think
main.
circ is the tight lesion. Yeah. Circ is the tight lesion, and here our this is a 3.5 IVL. Go.
Right.
4.
My other observation is that we are going to be encountering a lot more of these cases.
Oh, quite a bit. Yes. And actually, many of the cases are referred to us because they could not keep going.
Yes, I'm just waiting it to.
I see. Okay. Yeah, 4, and you can go up to 6 in this one. It's a large vessel. What is the vessel size?
So proximal is 4 low. In the
4,
part
yeah.
of the pullback is 3.8.
Can we see the screen of the IVL? Which side?
It's fenced, yes.
I see. Okay.
Samin, as a rule, you normally
3
select
kg changes.
size of the guide 0.5 millimeter smaller.
Yeah, exactly. So this is the 3.0 guide. And many of them we have shown that some cases, because of such a narrow route now, because of which is from the tower, you can even use the Akari right to engage your left system. So that was my next guide if this would not have come nearby. And you don't have to be selective injection. Your classical example we showed. You're miles away, but you can advance the wire and then you advance your guide liner. You see this now. If you're so far away, we advance the wire and this will not come out of the shell. Negative. Right?
Remind us the vessel size of the circ distal to the lesion.
They say about a big vessel. It's
Yeah,
a 3.5 to 4.
Yeah, so, and your distal left main is on that area, a little higher maybe?
Yeah, exactly.
So you're planning to put a 4.0?
4.0. Yeah, I think we put a 4.0, 20, let's get a 4.0, 24.
Megatron.
Giant, negative. What was the plan in this case?
Megatron. 3.5.
Megatron, yeah. The idea was, go up, that to use a Megatron.
Now,
So we can take a 4.0, 24. 4.0, 24 Megatron.
With your balloon inflated, would you try to go with your guide or no?
Okay, we can try. Next one we'll do now.
Yeah,
I'll
let's
go a little
try,
further down.
because if you got that support, then the
Go up.
bifurcation, potential bifurcation issues may be resolved.
Yeah, because I would be concerned if we have to kiss here at the end and you only have
Exactly.
that guide extender.
Very good.
There could be
Look
some
at that.
issues.
Now the
This,
guide.
You have to do it
the guide
individually.
extender will go. But question is, can the guide go?
Yeah, that's the question.
Guide, no. No guide.
What about if you balloon that cell of the tower?
That will disrupt that.
That may disrupt. Yeah, we may have to do a few funny
Okay,
things, but I
okay,
think we
okay.
are okay right now.
Futuristic approach.
Do you ever use a JL3? I've used that a couple of times where I do the stiff part of the wire, get it down below the ostium, then let it unfold and try to look up into it.
No, but the JL3 will not give you support to go through the circuit.
Once you get
That's
through,
the only problem,
you will.
support-wise.
But
Support
once
is
you,
The
bad.
VL was in the direction, get the center.
You have quite a gap there between the struts and.
yeah, I know
the,
you do, but
the
once you
left
get
main.
through the strut itself, then you can pull your guide
Give me
up.
the stent.
Andrew, can you hear me?
I'm not sure this was aligned properly.
We hear you here.
Can we show the animation
I'm not sure that was aligned.
from the tower cathode, if you can?
We have it here. We're showing it right now.
How to engage the coronary both in self-expanding and balloon expandable stents.
And that was a major paper which had been quoted quite a bit in this field of coronary engagement post-tower. Okay, so far so good. We call SFSG.
So 4.0.
Let's move it a little bit back. Here, once again, the 4024 Megatron. Will die.
Nice.
So far, I think, want to give a little die?
Yes, ready.
Want to make sure, yeah, good. Go up.
10, 12,
14.
14,
Negative. Look up 408 high pressure,
14,
or 4.5 actually.
4.8.
High pressure.
In anticipation, it says if you need to recross to the LAD, we'll pull the wire from the circ.
No, I would say I will try for a little bit, just the second wire, because you can put two wires, but you
Yeah.
cannot put a balloon and the wire. That's the only thing. So if it looks good, we won't get too crazy in this case.
No. Looks beautiful.
I think we are done.
So beautiful.
I think we are done. You are ready. AK is ready in room 2. For the
Okay.
next case.
Great job.
Dr. Kinney, are you
We'll just
ready?
post dilate and that's it. Yeah.
This is a beautiful case. Thank you so much, Dr. Sharma.
Thank you. Thank you.
Sorry for the delay.
I think it was in good shape to begin with.
Can you,
Anu?
case number 9, we are back in room 2.
Yep.
Same, I'm with Parasuram, Jason, and Maria. So this could be the last case in this room. So we're going to introduce our staff. Where is Will? Will is the chief, I would say. You see that? He is the chief live case nurse. So every time we do live case, he is on here. Yes, and then we have who? Kim and April. Yes, Peter and Asif are our techs. So if you see here, case number 9, a 90-year-old male who had angina class 4 and he's referring, didn't do any others because of, limiting angina, significant risk factors, was sent here directly for cardiac cath without having any of the previous tests. So EF was mildly reduced. And then when he came here, he had significant 3-vessel disease. So prior stent and RCA was totally occluded. LED had a proximal disease and circumflex also had multiple lesions. Of course, because of the age, despite syntax being high, patient and the referring doctor, after discussion, patient, of course, did not want bypass. So we did circumflex at that time. And today he's here for PCI of the LED. So if you see angiographically, this is where the circumflex, all the prior stents look good. And you see the calcium, tight lesion. It's not any stent, it is just a tram track calcium. He has a diagonal disease also, but I think given his age, we can just focus on one lesion. Now, having shown so many complex diseases, the theme here would be, again, how can we manage calcified lesions using imaging? His creatinine is good, so we decided we will do OCT, but let's take how would you approach this case that you have? So significant disease, short, focal.
The landing zone after the lesion, has that like a calcium nodule there or something?
Yeah, that's what we also felt, that even on the angiography, we can confirm it with the
OCT.
imaging. Now, if we,
the OCT, of course, will give us all the clues as how to proceed, but completely agree with your decision to leave the diagonal alone.
Possible.
Is Kiski here?
Yeah.
Okay, now we're doing OCT when
Can you check
you
the
tell
pop?
me, right?
Yeah, it's very tight stenosis, so.
Yeah, can you, okay, you have to give some dye?
Yeah, good clearance.
Okay.
Okay, 1 second. Enabling, 1 second. Waiting. Yeah, cine inject. Yeah, we got image. You can take it out.
Is there any prior stents?
Looks
Or
like
it's all calcium?
1 second, please, sorry.
No, a little bit more. Middle AD.
Oh. No, you're not going to do that, right?
Yeah.
Flush it.
Okay, angiocoagulation. Okay, start the pullback. Yeah, mid has some previous stent, but here is open.
So it's prior stent?
Yeah, this is, but not much intima. Big, so this is the tightest lesion. So it looks like not calcium.
Where is the calcium? Yeah.
Do you see calcium or no?
Okay, 1 second. So first, the OCT didn't show any orange line. Like a little bit here, like 90 degree. But the tightest part, it looks like it's not that much calcium.
I don't think the OCT is giving the truth here.
Well, if you look at it, it has a glow like it's soft tissue right in the core of
it looks, yeah.
angiographic.
You see that, but this is proximally is look all like lipid-rich plaque in the proximal.
It really
segment.
does have that kind of glow.
So look
to
at
it.
that; it's totally diffused.
Yeah, and no like a well-delineated border and like attenuated plaque. Yeah, looks like possibly lipid plaque.
Maybe we just cut it then.
Yeah, we can check the dilatation.
Let's see the fluoroscopy.
It does though on angiography.
You know,
there's a soft tissue glow to it.
Maybe. Well, what about the experts here, Dr. La Sala? Tell us what to do now.
Well, if we've agreed upon there isn't a whole lot of superficial calcium, all of it's got to be deep based on the angiography, correct?
Change it.
No.
Yeah, for some reason, this is the first case in my life in which I don't believe the OCT. I think there's that, that lesion is calcified. You know, look
In
at
our lab,
that.
we would say, get the IVUS.
Yeah, that's what I was gonna
Yeah,
say.
that's,
Take the eye.
that's a good one.
Or just take a non-compliant balloon, go up, see if it expands. If it
Yeah, I think
doesn't, then
that's-
do shockwave.
Shockwave doesn't care whether it's superficial or deep, so that's always an option.
Yeah.
But I think you could just balloon it and just see how it looks like on a.
If it
Okay,
balloon-
get us a cutting
if it
balloon. Let's
balloons
go
well,
in
I think
between.
you're
3,
done.
5
Just
cutting
that.
balloon. Yeah. Yes.
Yeah, so there's the one limitation of OCT, the depth of penetration.
What do you think, Kiski?
Yeah.
Now that we have done so many OCTs, we have analyzed so many calcific lesions, why you think we are getting this?
So first,
Look at the fluoroscopy. I just did the fluoroscopy cine.
yeah, I mean,
Track,
first it's a very tight stenosis, so the blood clearance is not perfect. And I see some small calcium, like a distal to that lesion.
Did you
But
do
the height-
this? Did you do this pullback on manifold or automatic injection?
We did.
we did assist. Earlier the case we did it with hand. Okay. I think it's right there, right?
Yeah, usually OCT is better for detailed calcium assessment, but the presence of the calcium IVUS might be better than some moderate OCT.
Okay, let us see how it behaves. Oh.
No, but this, yeah, opened up. What size balloon is this, Anu?
3.5. We went up to 18. Let us do another round of OCT here, okay? Go. Are you telling me this is a proximal edge of the stent?
Outside of stent. Like 5 millimeter proximal to the previous stent.
So you think there was no lot of dye clearance, that's why we could not see it?
That's one possible.
Okay, so let us do another run of OCT.
Yep.
Okay, done.
It makes sense that it may be a new plaque if there's a previous stent there, right?
Are you think it's a lipid rich?
I do.
What is the
No, I'm on the
vessel
OCT also.
size distal to the lesion? What is the vessel size up there? Up there?
So actually, after the lesion, it's kind of like an aneurysm. The lumen is like 3.9.
3.9, okay.
Yeah, but looks like proximal is smaller.
And what is the length between the ostium and that landing beautiful zone you just measure?
We didn't come to the ostium, but ostium to that distal reference is like 10.8.
Okay.
Oh, sorry, not ostium.
I think it's the manifold.
Okay, second run of OCT.
Yeah.
Yep. So can you check the path again?
Oh. Should you increase the...
No, we can do. Good clearance.
1 second.
One second.
They have a dye.
Okay, Dr. Kinney, enabling, 1 second.
Circling.
Bleeding.
I think we have a dissection.
Yeah,
yeah,
Cine,
dissection
inject.
Yeah.
Oh.
Yeah, good.
Big dissection, yeah. Contain.
Yeah, perforation. Forget
I
dissection.
know,
Contain
I know.
perforation.
Contain perforation, yeah.
It's a deep wall
This is
dissection.
it. Oh, so it was a lipid rich. The cutting was too much. I go with a papyrus up front.
No. What do you see?
Okay.
We have,
So-
deep cuts.
Yeah. A lot of plaque modification. Yeah, a lot of dissection.
There's a
Okay,
section.
get us a Megatron.
Okay. Dr. Kinney, now I see some calcium here. Here.
Yeah.
Eccentric
Okay.
calcium and a protruding inside.
First, let's stabilize this lesion.
Yeah, this is much better image. Now I see definitely calcium nodule.
Okay.
3.5.
3.5 is a good one, or you want us to put a 4.0?
Proximal lumen is smaller and it's less than 3.5.
3.5.
Yeah,
Yeah,
better
I
to
just
go.
said-
3.5, 16, quickly. And then let us see, we can then decide, you need a papyrus or we stabilized it. They have that or open a,
It's kind of interesting.
Bleeding into the
Looks
plaque.
like a
This
hematoma.
plaque here is rather interesting that it's
Do you
so-
see anything?
Yeah.
Like a hematoma?
Yeah, it's
Yeah,
a
I
intramural
see.
hematoma.
Dissection,
Big dissection,
intramural.
but
So the
evolving
There's a
into a
hematoma
hematoma.
Some another lumen.
Deep dissection, right?
Yeah,
measure
another
that.
lumen behind the previous stent. So, but the lesion start at our tightest lesion. So there is some medial dissection. Like it propagates through the previous stent, behind the stent.
Okay.
Interesting.
16, right?
Yeah.
Okay, so the
I think the OCT was
EYE
right.
length is 16. What is your imaging length?
Wait,
Have a papyrus ready?
go back to that image.
1 second. Yeah.
5 you gave me, right?
Actually,
3, 5.
30 is enough, so 16 is enough.
What happened
enough
is
to
that
cover.
the hematoma is make you think that the vessel is larger, but the vessel is not that big. So
Yeah.
So I will go.
Connect. Some die. Yeah. Some die.
A lot of contraction.
And the tightest part is again the one half is plaque free, so don't go aggressive is better. So it might cause another perforation.
Okay, so we are not going to go. No, we are 3, 5.
Yeah, so that's the great safest one.
See if we cover the whole
4,
thing.
5, and then make it bigger if you need to.
Oh, wow.
Oh, gosh.
Yeah.
Really bad. Okay, go
I
up.
think you're right. You're good.
90-year-old tissue, you know.
Don't go to 18.
Yeah, 218. No, we did not. Yeah, now we are 12.
We've got the right size
Down.
papyrus ready?
Yeah, the papyrus
Yes.
is ready.
Down.
I think it's just deep into motel.
I think we will deep
I think it's
intimal
just-
tear.
you
We
can't be
will
sure until
stabilize
after
with
you
the
see
stent.
this.
Yeah.
It's just bleed.
We knew it was a
I
deep
think it'll
intimal
look
tear.
better after this.
Okay. Go a
That's
little bit inside there,
Basically a
right?
perforation.
Go up there again.
Yeah.
Don't go too high. Yes.
As long
Okay,
as
down.
it doesn't squeeze down to the circle.
Yeah, the shape of the balloon on the stent is very encouraging. There's no bulge.
Okay, let's take a picture.
Yeah,
Stabilize
I
it.
think Dr. Singh is right
It's
again.
in. Okay, ready?
Yeah.
Yay!
Okay, everything under control.
So it was just bleeding into
No
that
need to
soft
worry.
tissue plaque.
I don't think
There's,
another OCT is required.
yeah.
Eyes are telling us things are looking good.
You can still see that there's a pocket of contrast there, but looks like it's contained.
Yeah.
I'd get a different view there, yeah.
So this one, and then I will take a.
Just for the
LA
fellows
order.
and things,
Yeah,
you have to be
go.
careful post-dilating something like this that you don't start to expand it proximally.
Go caudal. Also take multiple views. I know we can image and confirm everything, but this is the view that's going to tell us anything. Ready? Kiski, you want another OCT?
Yeah, we can show.
I think we are good.
Okay.
Yeah.
That is a little, you see that?
I think retrospectively, the OCT was right. It was a super lipid-rich plaque. The cutting went through the media into the adventitia, contained rupture, now sealed with the stent.
No, actually, after we did the cutting, the second OCT did show lipid. Go back and show the lipid.
A little plaque, a
No,
little
not lipid,
calcium.
I mean calcium.
Calcium, yeah, a little calcium. But all these diffuse.
How much was it? One quadrant?
Yeah, one calcium nodule.
Oh. Again, nodule.
Yeah.
The nodule. Yeah,
Everywhere.
but that we saw in angiography, the nodule. We suspected it. But it's a very illustrative case. Don't believe angiography, believe in imaging.
Just remember
But this is
how to
not-
do angiography, though. Looking for calcium is that you
This is-
start to cine, then give Diag,
Good.
and then you can see the different
Do you need
shadows.
another OCT?
Let's see.
We can show.
How many
Okay,
vote
he
for?
wants another OCT.
How many will do OCT
Give me
again
last.
from the podium? None.
No.
Forget it.
Okay, nobody's. Okay, Kiski,
Dr. Marina,
you're alone.
how often do you see with neoatherosclerosis, how often do you see calcific neoatherosclerosis versus
Often.
soft plaque?
We see a lot of calcium behind the stent too. And within the stent for neo is near infrared the way to go. OCT can give you some idea. But in order to diagnose neo, you do near infrared, and we have a publication with kidney in circulation about that.
But usually it's not calcified, though, right?
Okay, we are done here.
Is it,
And now we'll go to the next room.
Morphologically, is this a little unusual that a 90-year-old who's got diffuse calcium angiographically had nothing superficial?
Say that again?
Isn't it a little unusual from a morphologic standpoint that a 90-year-old who has calcification throughout their whole vessel angiography does not have anything that's superficial?
I'm not so sure this is not related
This
to
is
the
a
stent
very
process
good
that was already put in.
observation
So I
from
don't know if
Dr. La
this is
Sala.
native
Okay, are we moving on with the next case?
Yeah, we can move on, or do you want a quick, right?
You're doing the second run?
No, I have to do the case number 11 also now.
Oh, sorry,
Do a
just
lecture
manual,
in
right?
between, right? Did you tell him? Don't put me on.
That's why you always have to look at the
You can hear me. Pedro, can you do one lecture? Is there a lecture?
No, no lectures. We only have the conversations over complex cases with expert faculty.
Okay, I'm going to the next room.
We can have a discussion here while you're ready. So.
Ready here,
Done.
Pedro.
Case is done. Why?
You guys are ready, Joe?
Yep, we're ready.
You want to show us the case, the summary of the case?
Sure. So this is a 65-year-old female who comes in with no significant CAV risk factors. She has a BMI of 27. She presented initially with worsening shortness of breath and epigastric pain and reduced exercise capacity. She had an ETT that was done that was very positive for ischemia with ST segment depressions. And she was sent for a cath, which was done in April. And the cath showed two vessel disease with a mid-RCA CTO. And at that time, the syntax score was 24. And we elected to open the CTO of the RCA at the time. And she's done very well, but she continues to have disabling symptoms, despite being on both metoprolol and isosorbide. So the plan today is to go ahead and fix her LED Diag bifurcation, which is a Medina 111, which we'll show you here.
Oh, okay. So this is the, hold on, RCA?
This is the RCA CTO.
Yeah, we want to see, we don't see the angios. We're
You don't
still
see
on
it?
the
See the
slide.
angio? Yeah.
We're still, okay, now we're talking.
Fielder, yeah.
Okay,
Oh,
good.
beautiful result.
Okay. Yeah, so that was the CTO. I think
That was the
like he
CTO.
presented, this patient young, when you have a CTO, always try to do the CTO vessel first. Because you still, if you're unsuccessful or something, you can always consider referring for bypass. So this is where we are with the LED diagonal.
Beautiful case.
Significant disease. Yeah.
Yeah.
So now you know why she was still having symptoms.
Appropriately so.
Dual LED
Yeah.
system, huh? You have septals
Yes.
coming off the diagonal.
So let's discuss how would we handle. So why I'm thinking the last case, can we do it without imaging? Okay.
I will ask Dr.
Can
Babler.
we use our eyes?
Okay, what's the plan here? Two stents or
We will, two-strand technique based on all the criteria, especially
Mini
definition
crush?
criteria, significant disease, side branch is large, side branch lesion is almost just about 10, 12 millimeters. So every criteria is telling us you
Yeah,
need two stents.
and here you have absolute no calcium by fluoroscopy.
Yes.
This is a diagonal that's almost as big as, if not bigger than the LED.
Yep.
Plus the angle is
You've got to
very
use a
acute.
two-stent
You're
strategy.
going to have to do two stents. No matter
Yeah, that's a good point. Dr. La Sala is highlighting when the diagonal is so big, don't think about provisional.
No, two things. One, large, significant lesion, and side branch lesion is long. So three criteria, all three criteria are positive, will require two-stent strategy. Now, somebody can ask, how do you decide which one will you wire first? Will you wire the side branch or the main vessel? Most of the time, it is main vessel. In rare situation, we will say maybe side branch. If it's really takeoff is angulated and we think the wiring the side branch is difficult, you will try to do the side branch. There are pros and cons, like here, I wired the LED, now wiring the Diag, now that, like we mentioned, the vessel may straighten up, wiring the Diag may be
twist the
difficult.
wires too.
So let us see how it behaves.
That's your filter?
No, I'm going in. Yeah, that's fielder, yeah.
Okay.
Always try to use polymer jacketed wire to the side branch.
I have a very simple algorithm. I use a different color on the side branch so I don't pick up the wrong wire.
Yeah. So that is true too. So the fielder is green and our main workhorse wire, which is run through, is black. So you can see the difference. That's one. And that's where we are. Here, what we say is which side branch will you, or which branch will you open first? You can do main vessel side branch at any time because we're going to stent both. So that's how it is.
No,
but if you decide you're going to do provisional, always do the side main vessel first and the side branch last because you want no plaque shift
Correct.
after that.
Now, are you planning to do IVUS or OCT here?
Well,
Wolverine.
no, I said our eyes, EYE, eyes.
Oh, the eyes.
Hey, yeah. Not ICE.
They have it written.
Where are we going? LED?
Yeah, no. So we have a 275 cutting balloon. So we'll tackle the Diag first, ostomy of the Diag.
Are we okay with that? Because the only thing we will need is the sizing here,
well,
right? Because we know there's no calcium.
Get the 3O balloon for the LED.
Is the panel in
215.
agreement to use
215
the
on
eyes?
complaint. Your wire came.
I think we have a quiet panel. Nitin Barman.
Imaging, we should do OCT.
It's easier to say. I think this lesion would have qualified for a renovate, and I think that really post-imaging is probably more important here. And then we talked about this earlier. If you're going to post-image, then it doesn't make a lot of sense not to
Post-imaging,
image.
that's a good idea.
Yeah. That all said, I mean, I agree. I don't think that your upfront strategy is going to change too much. Just the kind of diameters and lengths, which are important, but modifiable post.
Get the main vessel balloon ready.
Okay, we negotiated here for a post-PCI
post-
imaging.
I think post-PCI imaging, just so you're sizing it. I agree with Nitin. I usually tell my fellows, wherever the wire goes first, don't pull your wire back, just take the branch. So which one you're going to wire first. The big thing
What
here
happened is there's definitely entanglement of the wires.
Yep.
So let us see. I'm trying to get the cutting balloon. It's not going. If it still does not go, then means the lesion is
went.
tight.
You
No,
went
so I had to
through.
rewire. You see that? We rewired. Okay, go. This is a
275.
Okay, good.
Anu, you always
use the
cut
same
balloon the side branches, huh?
Yeah, we are going to do
When-
that.
when you're gonna
see,
stent
there's a
it.
little bit of calcium. You see that now? Just at the ostium of that side Diag. Yeah, there.
Yeah.
Okay, good. Down. I think 275 a little large.
And when you have two wires and one's a fielder, you just have to pay attention moving in equipment that wire doesn't go distal. The fielder wire will go into really small vessels.
It's not opening?
Yeah. No, it opened up. It
air
opened
bubble.
up.
That's the bubble, no?
Yeah.
That's a bubble.
No, that's a bubble, yes.
Okay.
Okay, let's take a picture. Yes,
Just,
big vessel.
yeah, get that wire out of that
That's what you have to be
septum.
careful with.
Small one.
Nice.
Would you ever consider the Diag as the distal main vessel here? I mean, the burden of disease is somewhat equivalent, but
Yeah. This is a good question Dr. Berman is bringing up. You know, for the syntax score, the main vessel is the largest vessel. In our field, the vessel that is in the interventricular groove, in the anterior interventricular, is the LAD. So what do you think? When you have a larger diagonal than the LAD, you treat the diagonal as your main vessel? Not in this case.
We have done that in situations we have done it, but not in this case. I maybe they almost same, maybe slightly bigger. You see that?
Yeah.
You know,
I meant
if you ask our European colleagues, they may say they would do a culotte here. Go
Exactly.
from
I was going to say
the
that.
left main to Diag and then, you know, stent the LED later. You know, they like culotte. BK crush is not a bad choice. So like we say, you know, the various technique, you just master a technique and just keep doing the same technique.
3015 NC.
For what?
Yeah,
LED.
best advice for the audience.
Not the cutter?
For the LED using them.
So now, stenting wise, I heard somebody say do OCT. What was the reason they wanted OCT?
Oh, somebody wants?
No, post I know, but there was someone else mentioned they need OCT.
PPC OCT in bifurcation, it helps in giving the exact angle of branch. Just to,
Oh, yeah.
And how will that help?
that will happen if it's a provisional. Here it's not a provisional. We are having a two-stent strategy beforehand. Otherwise, then help in predicting side branch loss or plaque shift, help in assessing the plaque shift to the side branch.
So that's if you weren't going to stent. To decide whether if you were going to.
I guess there are simple bifurcations.
That's a 3.0.
Complex bifurcation.
So what's the size now?
I think
This
a
is from the first group,
3024.
What did we decide?
Synergy. 3024, 3016.
16 to the side?
Yeah.
We need 30. Oh, yeah.
Yeah.
So we are taking a 16 to the side branch and a 20 to the main vessel.
Need NC
20 or 24?
Oh, 24? Okay, 24 they want. Fine.
3024 for the main, 3016 for the side.
No, give me the side branch first.
Patrick, what do you think
I'll
about
say always same thing. Go to the side
Somehow-
branch or the vessel you think the delivery of the stent will be the hardest.
AK, the circumflex is crossing over the proximal portion of the LAD. The proximal portion's 3.5.
Yeah, or 4.0.
Yeah, we put a longer stand in the LED. I agree with that.
No, we are putting 24. You want a longer than that?
24.
Longer with the 3.5.
I think you have to cover the first septal you see there.
No, with the 24 will cover all that, no?
Maybe.
Yes.
3 to 5.
16.
Okay, give
Gotta
me
go
the
right
16.
back to that
It's
first
a great,
septal.
it's a great balloon result.
Right to the
though,
first
that
septal.
diagonal.
Yeah, the little tiny
You may,
septal.
yeah.
Little tiny one.
The issue is you may have a little dissection proximally. That's a good observation here. It doesn't matter. I mean, we just do the OCT at the end.
Okay, now give us I think 28 will be too long. We don't carry 26. That's it. Can we show the non-left main mini crush?
Get the other. Stent. 24.
Yeah, we have it in
24.
the,
Two,
in
24.
the slide
Okay,
right
3 or
now. We
24,
can
yeah.
see it. So go over the technique, Anu. You park your stand on the diag after pre-dilating both.
Side branch. We use the word side branch because it could be anything.
Yeah,
Could
side
be
branch.
PDA, RCMA, distal, could be OM1, OM2, or a circ. So we say side branch. Always, like I said, on the side branch usually we say because delivering devices to the side branch is harder. Sometimes could be other way around.
Yeah.
Right? So this is a 24. Now you see that 24 is covering what we wanted.
And this is a 3.0 also.
So, and always what's the size you will pick based on the size of the distal vessel. Now we are parked there. Now we are going to bring, see it?
Yeah, your dot has to be in the LAD. At least one.
Not really. Yeah, we focus on micro crush. Okay, ready? Take a picture.
Yep.
You're still too far in.
Yeah, maybe a little more LAO.
I'm going to pull back.
Yeah.
You'd need a
Pull back
little.
into the LED. A little bit of mega crush here. Yeah, some dye. I think we are good. Right? Okay.
You want to go to that view?
Why don't you get another projection?
I would deploy it right now, but let's go.
Do more
Let's go.
AP. This is RAO cranial.
Okay,
no?
good.
Yeah.
How about
I
a
wanted
cranial
to do
LAO?
that. LAO? Okay.
LAO brings it out well.
See? You're not covering the ostium.
That's okay. What happens is, once we dilate, remember the LED stent is going to do, I'm going to pull back a little bit, okay? I pull back, okay. You don't want too much crush, yes. Go up in the side branch.
Side branch stent going
Because
up.
of the angle of the bifurcation, yeah.
This acute angle, you're right?
Yeah.
Okay, good. Down. Go up again. I think this is what John Lasala was mentioning, that they wanted a modified where I don't do it, but I know Nitin Barman does it, Samin Sharma does it. Go up. They bring the balloon back. Dilate here. Go up.
And now you're doing it.
To show them.
Beautiful.
Why are
What
you
it
against
is.
that step?
Okay, so this is the most important part of the technique.
Now we have to take out the wire. Okay, give some dye to make sure the distal edge of the side branch is okay. And now let's make sure. Okay, good.
Ready?
Some dye. I don't want to take a cine. Good.
Beautiful.
So I'll take this wire out. LED is good, right? LED is connected? Yeah.
Yep.
Give me some dye, so proximally we are okay.
Okay. Yeah.
Okay,
that's
good.
Perfect. Yeah.
So there's a trio. Go more.
Looks 1-to-1, no?
Yeah. No, distal is 1-to-1. Proximally we may have to post. Get us a 3-5, 12 high pressure balloon.
Get a 2.0 mini truck.
You're going to use your same fielder to recross, or you're going to do a new one?
Yeah, I will use the same fielder to recross. But before that, because there's a discrepancy of the proximal vessel, let's just optimize and then recross. If you don't optimize, they will always say that it is likely the wire will go behind the proximal part of the
Spool first?
stent.
No, we're going to pot it first. 3.5 first.
Yeah. Probably had to pull back more.
So they're great vessels to work on. Everything's expanding well and they're large size. So this is kind of ideal.
The only case today without calcium.
Yeah, it's the only case without calcium.
Yeah, we want the audience to take note of the fact that there's no rotablator.
No, last case also. Oh,
I mean, the case isn't over yet, but.
No calcium, no
Good.
rotablator.
Oh my God. Yeah, I think we missed the. Okay, let's post dilate.
Yep.
Yeah, and
3.5, 12.
reaccommodate
And
the
then
LED
we-
wire too.
I'm going to fix that wire.
Oh, again issue. Yes. That's with the injection.
Yeah. No, it was in there before.
Going down a diagonal.
Nice.
We missed the
Okay.
ostium of the
Beautiful.
diag. Okay, let's do that. And we're going to use the same fielder wire to recross. Can we do, you want the imaging, final imaging, right?
But you're going to optimize the proximal?
Yeah, I'm going to optimize, then I'm going to recross, kiss, and then final imaging.
What's the length of your balloon? I don't want
12.
you to...
3.5, 12.
12.
Better not to balloon that ostium again.
Okay, go up. No, we want to, because I think a millimeter maybe has been missed of the ostium. Down. So let us see. This was ideal. Now let's recross. You have the 2O balloon.
2.0 mini truck. 2, yeah.
So this is the
Ready?
side branch.
Beautiful.
Now don't even get me started with the crossing proximal and distal cell. You cross the optimal cell.
See, on
So we are going
fluoroscopy,
to
you
go with
see
the-
the line, the radio-opaque line at the ostium that the LED stent creates. That means you have not kissed balloon yet.
I'm going to contrast.
That's important.
No, get it from the assist.
2 or 12 going in?
2 or 12.
Okay. And then we go with the 3O, high pressure to both vessels. I mean, 3O would go here. But if it's left main,
No,
you don't need to do like a small balloon first. But since it is non-left main, we are going to do a small balloon and after that we will go high pressure both.
You starting with a 3-0 to recross? I'll go.
No,
2-0.
I'm going with a 2-0.
2-0, perfect.
Yes,
Yeah.
yes.
Never.
Oh, you gave
No,
me
you
the-
went into the other one, yeah. That's okay.
It went into the LED.
Happens.
Okay, fine. I'm going to the.
Well, one thing you
So
can't do-
the same thing.
No, I was just going to
What
say,
was
okay,
it,
one thing you
Nathan?
can do, I know you can tell with tactile and you did a pot which facilitates
Mm.
this, but sometimes before you recross the side branch, you can put that wire down the distal main vessel, make sure the balloon passes freely, and then pull the wire back and.
What did we open? IVUS?
OCD.
Oh.
Nice.
No, I'm not sure. You think we'll be able to get the OCT into the side branch?
Yeah.
Go. Okay, 3-0-12, both balloons, 3-0.
20.
Okay, down.
Mm-hmm. I think you covered the osteum, Manu. Let's see.
No.
Let's see a little bit more. The next injection, you didn't do
Yeah, let
another?
us see after kissing and well, let's do the imaging and see.
What is this?
This 3 or 12.
3-0.
Yeah. 12?
Okay, so we're going both 3-0, high pressure.
That's a 20?
It's
No,
a-
12.
Okay.
It's a pretty acute angle. The more acute it is, the more you have to crush, right?
Yes, that is a thing. So I think that's why we might micromillimeter the upper part. Let us see how it looks after we do the kiss. Okay. Okay, give me a 3-0 to the LED.
You do.
Okay. So let's do the OCT of the LED first and then the side branch.
Yep.
If we have difficulty in wiring, right? So many times the balloon may not go into the side branch. So then you take out your wire and recross to a different cell. That's why we use the word optimal cell. So, although there's a decay crush, non-distal and provisional, you go to the proximal, but as long as you've gone to the optimal cell and the balloon is crossed. If the balloon is not crossing, go to a different cell where you think.
Yeah.
We have to watch this part.
Okay, good.
Beautiful.
So we
Simultaneous?
can show.
Go in a little bit
So
on
actually
the-
bifurcate. What did you want?
You gotta come
I
back on
think
that,
you
or
should
in a little
go
bit on
in
the
a little bit on the
LED.
diag.
Diag, yeah. There you go.
Okay.
Okay,
And
good.
advance the
Go.
LED balloon.
Ready?
Not yet. We are not going to kiss. Go individual.
Individual.
Go individual.
Diag
So
first.
diag has to be go high, right? Good.
Yeah.
Yeah, I can
20.
see the osteum.
No, enough. Yeah. You see that osteum?
Yeah, I saw it.
Despite us cutting and all that, I think
There you go.
it is not,
Angle. Yep.
didn't crush it well.
10, 12.
Okay, down.
Good.
Go to the osteum again. No. Go to the osteum of the diag again. We have to put another short stent there.
Would you consider a DEB there just for that, to spare a second layer in the side branch?
Okay, down. Yeah, we could.
やってもらっていいですかルーム2。
Okay, now kiss again, right?
Ready.
Go 8 both.
8.
Don't
Eight.
get crazy, or 6 maybe even,
Go
because
six.
that's a 3 is too big. Down. So now you see that what's happening, side branch, right? Go lower. You're not allowing to kiss. So many times maybe you can just do a serial. Okay, go lower on the LED.
You're on the LED.
On LED. Oh. Yeah. We're barely 4 atmospheres. 3030, the proximal vessel is barely like 3.25, not accommodating. So let's take a picture, the image. Ready?
Go.
So we're gonna end up doing culotte for that diag?
Not culotte.
But what else can we do? The 8 millimeter
Let us see.
will.
You have to put an 8 millimeter stent.
Yeah. Oh,
Right?
Yep.
yeah.
Oh, leave this there. Get us, no, he's saying use a DCB, but I think now it will be a tap if you have to cover that.
Well, yeah, it happens.
There are questions in the audience about timing, but we want to
What?
see this. We want to, because we're 15 minutes late, but
Okay, okay.
let's go ahead
Fine.
and.
Let's do the OCT of the main vessel. Good. And then you guys start your cases.
So just for people who use heparin, you have to keep an eye on your ACTs when the cases get like this and you have a lot of equipment in.
So it will be like a T approach for the 8 millimeter, Anu? Because the angle is not good for.
Yeah, it's a tap. Yeah, tap. Even then, look, the angle, you see that is so acute.
Yeah, the angle is
Likely
not
to
good
miss. That's
for
why I
a
was
T.
going back and checking. We pulled it. Acute angles, not the best. Okay, ready for OCT?
Yep.
Okay,
We'll die.
Yeah.
ready?
Yeah, please check
Yeah.
the path.
Good, right?
Not coming yet.
Huh?
Laura?
Can you
Not
check the path?
video.
Hello.
My fault.
Ay, ay, ay.
Yes, again.
Mhm. Okay, we have to connect.
Yep.
Give me.
Yes, the last case.
Okay, Proc, go forward.
6 speakers.
Go forward. Contrast? Yep.
Yes.
Forward. Good.
Okay. Now try now.
414. Okay. Yeah. Guy.
You try?
Good.
Okay,
Yeah,
good.
good. Okay, 1 second. Enabling. Calculating. Yeah, Cine, inject.
Injecting.
Cine inject this side. Okay.
Yep, perfect.
Okay.
You don't have the angio.
Looks very good.
Yep. We'll see.
Okay, you can start your cases, right? We're just going to balloon.
Just tell us what
Switch
you're
it to
gonna
the-
do with the 8 millimeter. You're gonna put it like
Is
a
it two?
T approach?
No, I'm going to, no, what I'm going to do is go back with the high pressure 3.25 balloon. If it still does not look good, we'll put a short 8 millimeter stand. Tap technique, can you show the tap technique of the LED diagonal, non-left main on the side?
Yeah, it looks good. No malposition, no dissection.
Proximal edge,
Yeah,
it's
both
looking
it
good.
looks
Okay.
great.
Yeah,
No malposition, no
So we're
dissection.
gonna
and
start.
distal edge.
Yeah, distal edge also looks good.
Okay, excellent.
And the area-wise is more than 4.5. It's an optimal result. Main vessel.
Okay, fine. So MSA is good.
Yeah.
OCT MSA is a little different, 4.5. IVUS has to be 5.5.
Yep.
Okay, Pedro, start
Okay.
your cases there.
We're inviting Dr. Singh to talk about my worst
So what do you want?
complication,
We have to put a-
optimal
325.
atherectomy.
High.
You think we're still here, look.
Okay, can we put the slides of Dr. Singh, please? Wonderful. Thank you, Professor.
Thank you, Pedro. So I'm going to show my worst complication of orbital atherectomy, and I'm going to show 2 cases, both illustrating really the same thing that I'm going to show in the cases as to how we can avoid complications like this. So 76-year-old male, sort of worsening chest discomfort and shortness of breath on exertion, hypertension, hyperlipidemia. And in previous angiogram had mild right coronary disease and mild LED disease. So there's the medications. EKG showed some very subtle key waves in inferior hypokinesis on echo. So these are his angiograms. So you can see cranial pictures. You can see vessels are calcified, but tortuous, but nothing really. The circumflex looks small. So and there's a reason for that, and you'll see next case, next slide, actually. So that's your right now. So 50% went to 99%, and now you have all these filling defects and calcium. So big right, supplying pretty much the whole circumflex territory also. So patient is symptomatic, so it's calcium, and you'll see another view here, angulated, looks like eccentric, nodular, and superficial calcium. So obviously these are the kind of lesions that are difficult to wire, number one, and second of all, probably difficult to cross with any balloon, and even if you cross, most likely won't really yield. So we actually wired with a microcatheter. There's another picture on the right. So wired with a microcatheter and changed it to a Viper wire, and then we were able to perform orbital atherectomy. So you can ask me after all these cases that we've seen is why did we do orbital, why didn't we do rotational? You look at the wire bias and all those kind of things. I'll show you. I think it doesn't make that much of a difference. I think technique is important, but I think there are scenarios where I think these devices really don't do what you really want them to do. So if you look now, this is after our orbital atherectomy. Looks pretty decent, right? He said, well, we crossed it. We did everything good. It looks pretty good. There's a little roughed up in the middle, but I think we have created a channel, so we feel pretty good about this. And then we said, okay, we're going to balloon it. So balloon expanded nicely all throughout. Looks good. Looks good. So we IVUSed it. And you see, why I show you in this picture here, you see the mouse going? No. So if you see that OCT image, you see with the way the wire is sitting, if it's an eccentric calcium, if you see that angle of it's greater than 90 when the catheter is touching the area which doesn't even have calcium, and the guide wire is touching that area also, that's classic bias on OCT. And if you have that, even if orbital atherectomy is supposed to bounce off, they say, it hits the hard tissue, it bounces off the soft tissue. It's wrong. What it does, when you have this much bias, what it does, it actually dissects your intima and your media and pulls it off. And the only thing you see is adventitia. And so you may or may not fracture the calcium on the other side. So that's your stent. Looks pretty good, huh? We feel pretty happy. Everything expanded. We did orbital. Very nice.
But with your, evaluation, yeah, we see what happened. But with your evaluation, you anticipated this?
Oh, this is what happened.
Oh, we saw it in the previous picture. Yeah.
Yeah, previous picture. So this is after stent. It didn't happen with orbital and stuff. And this is what happened is we actually gutted and removed that intima and media of the adventitia. So when the stent expanded, it had nothing to expand into, and it expanded into the path of least resistance and perforated it after the stent. So now, at this time, patient is not doing well. You can see it's as bad as the classification of perforation gets, and patient is not doing well, so obviously...
Jess, we didn't see that on the IVUS, did we? We didn't see everything removed. I mean, the three.
No, we saw it. We saw it. I'll show you a picture of it.
Okay.
Yeah, we saw it. Absolutely. We saw it on IVUS. Actually, and we look back, you saw it on IVUS that actually moved it. And what happens with orbital is when you do orbital, and if it crosses the lesion, okay, you have to be very careful, especially in tortuous. When you're cutting backwards, you have to be very slow. Don't get excited. You go in there, and I'm going to pull it back. And that's what happened. When you pull back, it actually knots it. And then when you take a next pass, you feel like a rubber band. Because your lesion is crossed already. So you take a next pass, you feel a rubber banding phenomenon. That is when it gutters it. So that's the only time you'll get perforation. So if you feel that, don't push it. So we were doing this, and we actually made a mistake. And we pushed it because we wanted to make sure we were able to deliver the stent. And that's exactly what happened. So
So you can see the pericardial synthesis drain. We, put a papyrus stent, obviously, in there. And we sealed it.
Usually several papyruses, right?
What's that?
Usually more than one.
No, I'll show you. So we put 2 papyrus stents in there. We sealed it. Patient is hemodynamically stable. Left the drain in. Sent him to CCU. And you'll see here, this was our post-IVUS after papyrus. I'm not going to go over this, but I'll show you. It looked like we sealed it. Everything looked good. And then patient was admitted to CCU. Then developed significant hypertension. I went to see the patient. As soon as we saw the patient, I called the surgeon. I said, listen, I think this is leaking. There's pericardial clot and stuff on the echo. I said, we have to take him to surgery. As soon as we took him near the elevator, started coding. So we were coding the patient, went to surgery. Actually, the surgeon was very, very quick and very good. He had found multiple tracks of bleeding around the papyrus stent. So they had to repair with the patch and glue. And patient did well. And was discharged 8 days later. And our patient actually last week saw the primary cardiologist and has having some discomfort and inferior ischemia, so they're going to get a CT angiogram. So I'm going to figure out what's happened. I wish we had CT that I could show you, but this is another one, and I'm going to show Dr. Lasala's case here real quick also, which is illustrate the same examples. This is a case that he did that had a mid-right, pretty simple. You say, well, maybe shockwave it, but it's eccentric calcium, so we decided to do atherectomy. And you'll see nothing happened after atherectomy, stent, and then this is what happens. This is exactly what the bias, it looks like. So this is what atherectomy does. So the key is very important to understand that these things happen, and the reason it happens after the stent is for obviously that nodule and path of least resistance. So when you are doing backward and forward, the technique has to be very, very important. So, this patient obviously did okay. And then what happens is, I'll show you, sealed it. Then the patient 1 week later had problem again, and you can see what happened. You see that pseudoaneurysm that forms in the stent?
And you notice the patient's an atrial fib too now.
Yeah, I see the fib.
The blood in the pericardium is a very potent irritant.
Yes.
Look at that.
So you know what happened? They put another one. So here, I want to illustrate the fact. So it says differential sending, reduce plaque while potentially minimizing damage to the layer. Don't believe that, okay? The technique is important. If you have a bias and if you have that OCT finding that shows you the contact of the catheter with the guide wire bias, you have to be very, very careful with the technique. Otherwise, you're going to have both these cases. Because of bias, you're going to have perforation. Also, orbital atherectomy, do not do high speed. High speed with wire bias and tortuosity results in perforation. Okay, that's the only perforations we get is from high speed because of the bias I showed you. Don't go 120, you do not need 120. CSI, Abbott needs to take away that thing from 120. Just make it 80, make it simple for people. It's very, very important. So, these are the complications of orbital atherectomy. You guys are familiar with. Perforation is the most common one. We had a live case from England, actually. They actually broke off the orbital bow. Crown. And it went down into because it was so tortuous, and they were pushing too much, it broke it off. So this is what I was saying. So frequency of orbital injury, if you look at it here, if you're OCT, catheter, or even IVUS, if you see the guide wire contact, and if you see that angle of where the catheter sits in the path of least resistance, that's where you have the most injury. 90-degree angle greater than end guide wire contact, you have a largest amount of orbital injury and resulting in perforation. So, and I'm going to show you one thing real quick here. Papyrus is not 100%. Okay? When you do both our cases, you had late leaks. So when you do papyrus stents, you got to observe the patients very, very closely. One had pseudoaneurysm because it's a single layer thin, right? As opposed to graft master, which is stent sandwich. Right. One, stainless steel, and this is cobalt chromium and only one layer. So that's why it fractures, and I'll show you why in our case here. Let me go back here. Look at this. So this is papyrus stent with a leak from the calcium nodule that there, it breaks the thing and it starts leaking behind.
Beautiful case.
So thank you, guys.
What a fantastic explanation. Three-dimensional. Now, the best interventional cardiologist of the west side of New York, Dr. Nitin Barman.
It's very limited zip codes, but I'm glad you had two interesting cases because mine is not nearly as interesting as that. Good. So I have no financial disclosures, but I do have some disclosures, and the main one is that I'm not very good at following directions because this is neither my case nor certainly not my worst case of radial complication. But I do think it's interesting and valuable, and that's why I decided to present it. It's a reminder that there's risk even in the most straightforward cases. The complication is not common, but likely to be encountered by all. It's a radial complication, of course, and as you know, radial PCI is now the majority in this country. It's been so in other places for a long time. And there's a lot of practical take-home points. So we'll go over the case, management algorithm, and some take-home points. So quickly here, this is simple 59-year-old. Risk factors, recent diagnosis of uterine cancer. She got a pre-op stress as part of her gyne surgery workup. Showed anterior ischemia, poor functional capacity, ischemic EKG. Presented thus for coronary angiography. So the operators obtained right radial access with the 5/6 thunder, as is our norm. Went up with a 260 centimeter Stork wire, which is a straight tip wire, soft straight tip wire on a 5 French JR, and it passed easily to the ascending aorta. With some difficulty, they advanced the catheter to the root. The wire was removed. They attempted to cannulate the RCA, but had difficulty manipulating the catheter. Lost the waveform and catheter control. They did kind of inadvertently, I think, pull back the catheter. The patient reported severe pain. And not surprisingly, there was a kink, not the 70s British punk group, but if you haven't heard them, you should listen to them, the Kinks, they're fantastic. But a kink here in the upper arm, you can see. It doesn't look terrible there. So initial management steps, okay, is what, obviously confirm this, determine is the catheter mobile, can you potentially push it into an area of larger space, manipulation. In this case, it was not, and it was extremely painful to move. Of course, we tried gentle untwisting, which usually counterclockwise, opposite the maneuver that caused it to get kinked. This was also unsuccessful. Concomitant with these, we're trying to pass an 035 wire. It's important to use a kind of soft but stiff-bodied wire. A stiff angle glide is typical here. It's really not too useful to use a coronary wire, as it's very unlikely to be successful. No luck here. And then, of course, external compression to kind of give some counter traction to the distal portion of the catheter. This is really only useful depending on the level of the kink. In this case, it was in the upper arm. You can try to pinch high up in the underarm, or certainly if you can get a blood pressure cuff above where the kink is. But this was too high for us to successfully navigate the kink. So we went to our next step, which was simple second arterial access to either snare the distal tip or balloon fixate the catheter. So we got RFA access and went up with our catheter. We actually did the diagnostic angiogram first and then went up and shot this picture and got a little more interesting here. As you can see, the left common originating from a common trunk, a bovine arch, and some kind of pretty significant tortuosity. Got the catheter up and took a picture, and we saw that the catheter tip was now not available to us. So kind of, still planning to try to snare it, but understanding that in order to snare this catheter, we would have to pull and free this tip from this, I think, thyrocervical trunk or some branch of the subclavian. So that's about how I felt when we were trying to navigate this. Ultimately got a wire in our diagnostic catheter with the plan to exchange for a guide, and I probably should have paid more attention to PK when he was teaching me peripheral. A longer sheath probably would have been helpful here. We had a 45 centimeter sheath, but we didn't have a sheath all the way up to the arch. So here's one of the teaching points. We brought the catheter up, took a picture to ensure that there wasn't an active perf or dissection, and what you can see clearly here, you can see the shadow hopefully on the screen, it projects, that our catheter is not traversing the brachial artery up from the wrist. And it wasn't clear to the operator here, but they had went through the recurrent radial, which is probably one of the culprits of why this happened in the first place. So you can see the kink is clearly embedded in the upper recurrent radial before it joins deep brachial artery. So after having lost our system a couple of times, ultimately was able to, you can't see here, there's a coronary wire that's anchoring our guide. And this is a stiff angle glide, which was now able to go, it previously wasn't. Retract the guide catheter up. A little light at the end of the tunnel here. We delivered our snare catheter. Very, very, very satisfying to finally get this thing around a loop. And then it's important to kind of bring this as far down as you can to grasp as close to the kink as possible. That's actually me, believe it or not, a couple months ago. So then our final steps, obviously cinch the snare close to the kink as possible. At that point, we advanced the 035 wire from the radial side, pulled on both ends while trying to pass the wire, and then ultimately remove the wire via the radial sheath, or the catheter and wire via the radial sheath. I would love to show you that, but in our excitement, congratulating ourselves, we forgot to floor save this. We got every step except like the money shot. So you'll have to trust me that that catheter is no longer in that patient's arm. Here are some final pictures. It's really important, obviously, to ensure that there hasn't been a major vessel disruption. And here you see the recurrent radial, which is one of the main, the fellows that have trained with me know that this is a gigantic pet peeve of mine, the recurrent radial and the lack of understanding and conversions that are attributed to spasm and things like that, when in fact you're just down the wrong road. But this is, well, the elbow looks okay as well. So kind of revisiting the algorithm, again, gentle untwisting, trying to pass a wire simultaneously. External compression, a blood pressure cuff is obviously your friend, a necessity for any transradial operator. And then a distal snare tip. There's a lot in literature of different balloon techniques to fix the catheter, but what you want is countertraction on both sides so you can untwist. And then if the kink is distal enough in the arm, you can cut the hub of the catheter, remove the sheath, and then take a longer sheath over it and then track the longer sheath up to the point of the kink to facilitate unkinking of it. Don't forget, obviously, sedation and analgesia and when to call for help, vascular surgery. We did call vascular in this case as we started to attempt to snare, not knowing if we'd be successful.
Have you actually done the step 6 ever?
I haven't. I'm a little skeptical of how easy that would be to track. I mean, we've done it in the setting of a stuck rotabur where we're tracking over free devices, and obviously there's a razor effect, and tracking it up the artery can cause more trauma. I'm sure there's a substantial amount of pain. The snare option is generally successful, and certainly vascular surgery, while not something you want to have a patient go through, it's pretty controlled. It's not a big surgery, and I'd be a little bit more worried about additional trauma, but
yeah, it makes sense. Like when you have a diagonal wire trap into the LAD stent, you put a little balloon, and then you actually induce the pressure at the tip of the...
The fulcrum is the most important. Like if you were to pull a weed out, you grab it from the base, not from the tip. So
very good.
So that's it. Thanks.
Okay.
Hope to see you soon at the boat.
So I'm introducing Dr. Reitman, who is another protege from the Mount Sinai system. He's the governor-elect for the ACC in the Georgia chapter and the chief of cardiology there.
Thank you. Already done with that part, thank goodness. So no more Georgia ACC right now, past president. Thank you for having me. I am keeping this very, very brief. What I'm going to show you are actually not my complications, but the most important lesson that I learned over the last year or so. Both of these cases occurred on the same day with some young guys that we had just brought into our group who told us they had been doing complicated work for a long period of time as interventional CHIP and then structural heart fellows. And we thought that that was the case and let them do some work a little more unilaterally than we should have. So the failure here certainly circumvents my inability to pay as close attention to them as I should have. So first case is a 59-year-old gentleman with multivessel disease, had a prior infarct with a staged LED PCI. All of this in 2015. He has an ischemic myopathy, is hypertensive, dyslipidemic, and has sleep apnea. A diagnostic catheterization reveals totally occluded stents in the LAD and a CTO of a marginal branch, diffuse disease in the circumflex. The right coronary disease has progressed as well. And by MRI, this gentleman has only viability in the circumflex territory. He's on an ARB, beta blockade, SGL2 inhibition, and the plan was an Impella-assisted PCI of the right and left circumflex. So this shouldn't all be going at the same time, but you can see the right coronary artery proximally. I told this young guy who's been out for a year now and very well trained I was available. He put an Impella in from the leg, as you can see in the top left. He fixed the right coronary artery. There's a prior stent in the short stent in the mid portion, and then stented all the way back to the ostium, seemingly doing fairly well. He turned his attention to the circumflex, wired all 3 branches, and ultimately was able to do rotational atherectomy of the circumflex and balloon the ramus branch. He pulled the Impella out and gave protamine, and the patient went to the recovery area. And this occurred, as you can see in the upper left-hand side, probably about 90 minutes later. So having pulled the Impella out at the time and given protamine, we had to look for alternative access for an Impella. We put an axillary Impella in and ballooned the large ramus that you saw, but ultimately this gentleman did not do well. Second case that I want to show you, 58-year-old with systolic heart failure, persistent fibrillation, multiple ablations, diabetic, chronic renal insufficiency, prior revascularization of the ostial and mid-LAD, still had diffuse disease, known diffuse disease of the right and the LAD. A separate young guy that we had brought to our group, shockwave lithotripsy of the proximal and distal right with 4 drug-eluting stents placed. He post-dilated this vessel with a 5.0 NC, and I'll show you the films now. Upper left-hand corner, you can see the diffuse disease within the LAD, the right coronary artery. This lesion had been here proximally for quite some time. The patient had been fairly stable, and then more distally. Unfortunately, what we are finding is sort of the ability of people to very accurately size vessels based on imaging is not as robust as we would like to see. And so teaching people how to more appropriately size, to put a 5.0 NC balloon in this portion, in this proximal portion of the right coronary artery, seems very difficult to understand, and you see the consequence of that with a fairly large perforation. So, after 2 papyrus stents, the gentleman, this appeared to be sealed, and similar to what we had seen previously, the gentleman went back to the unit, and on the way back to the unit had a VT arrest, was brought back to the lab, ended up spending the next 5 days on VA ECMO, and was subsequently discannulated. He was, his cannulae were taken out, and he was subsequently discharged. But I think the lesson from both of these cases is approaching all of this work as a team sport, somebody that's been doing this type of work that you've seen today with Dr. Sharma, with Dr. Kinney, and the whole team takes an entire team, and no matter how many times a young person may have seen this type of thing done, it really doesn't take the place of the level of expertise that is accrued over many, many years.
Thank you so much. Let me introduce now Dr. Sanjeev Sharma, who is coming from Jaipur, from the Eternal Heart Care Center, which is Dr. Sharma Hospital in Jaipur, India. Welcome.
Good evening. So I was supposed to present the LM complication case, but it's not a real LM complication, but it's a complex case scenario of the LM PCI. Yeah. To move the slide. The case was an 86-year-old male who's a long-standing diabetic and hypertensive for almost 30 years, and also chronic kidney disease with the creatinine hovering around 1.8 to 2 mg/cent. He presented with the acute coronary syndrome, inferior post AMI, LV dysfunction, ejection fraction in the tune of 30-35%, moderate mitral regurgitation, PA pressure in the range of 50 millimeter of mercury. On the basis of clinical background, he underwent coronary angiography, which revealed a heavily calcified critical left main distal with the 3-vessel disease and left dominant circulation. He had been referred for the CABG, but turned down because of advanced age and multiple comorbid conditions. Discussed with family about the CHIP PCI, with the PCI with LV support for the multi-vessel and also the critical calcified left main disease. But family didn't give consent for the PCI. They told that it's a very complex disease, so we want to have a medical follow-up. So he was optimized on the optimal medical treatment. But next subsequent 2 to 3 months, he presented to the ER with the recurrent angina and ischemic LVF with the left main equivalent changes, ST sagging in the precordial leads and ST elevation in the AVR and V1. And the last time he presented with the cardiogenic shock, acute decompensated heart failure with a systolic BP of 85, heart rate 52. This was late in the evening, and saturation dropped to 85%. And immediately, electrolytes at the time were 5. Discussed with family about the treatment modalities, like he needs hemodynamic support. He was intra-aortic balloon pump was put immediately, started on vasopressors, noted infusion. In next 2 to 3 days, he got a little stable. This was the presentation ECG, ST sagging in the precordial leads and AVR elevation. On day 6 in the CCU, who got stabilized on IBP and vasopressors, family still opted for optimal radiotherapy. They told that just wean off from the IBP and we want to be on optimal radiotherapy. As soon as patient was weaned off from the IBP, he started decompensating. He went into shock, cardiogenic shock, and developed tachycardia. And then again, we had to put an IBP from the opposite groin. Meanwhile, he developed ischemic stroke also from the right MCA territory. And the neurologist was taken to consultation, and he gave that you cannot operate for next 7 days. So on day 15, discussed with the family after neurology clearance that family had to be told that he needs a PCI, high-risk PCI under MPL ICP support. If we don't do it, it's very difficult to take him out of ICU. Eventually, family gave consent. And then this is the MPL CP from the right groin, and from the left side is the 7th guiding. You could see heavily calcified critical left main disease extending to both LAD and circumflex ostium. The circumflex is dominant. There is distal circumflex type disease. And this is the 1.5 rota, initially left main to circumflex, then to left main to LAD. Ablating both LM to LAD and LM to circumflex, and subsequently with the help of guide extension support, dilating the distal circumflex lesion, and the stent was deployed in the distal circumflex. No, he's not here yet. And subsequently, IVL from LAD proximal to the left main, 3.5 IVL. All the 8 cycles of 10 pulses each were given from LAD to left main and circumflex to left main, and then this is a mini crush, 4 into 16 ds into circumflex and 4 into 38 ds into left main to LED. So the mini crush deployed at 16 atmosphere, and subsequently post-dilated LED with a 375 and 4 millimeter NC, and the circumflex also 4 into 15 NC. Port was done with the 5 millimeter balloon at 22 atmosphere, and finally it was an excellent result. And this is the snapshot of IVUS pullback. It's a very well deployed stent throughout the length of LED to left main and also the circumflex. We can see nicely formed carina at point of confluence. And this is the final angiographic result. Very well deployed stents in both the LED circumflex bifurcation and also in the distal circumflex. Impellar support was weaned off on the post-procedure on day 1. Vasopressors were weaned off in day 3. And patient was mobilized, shifted to room on day 4 and discharged on day 6. His ejection fraction improved to 35-40%, MR reduced in severity by grade 1, and creatinine also came down. The patient improved, and this is the presentation ECG, and in the bottom is at the time of discharge. And the learning from the case is a 86-year-old male with multiple comorbid conditions like diabetic, hypertensive, CKD, developed stroke in the hospital with LV dysfunction, and with the critical left main, badly calcified vessels. He deemed inoperable by the cardiac surgeon. The complex PCI with the rota and IVL with impellar heart pump support has given new lease of life for the patient who has not been able to wean off from the IABP in the ICU. So meticulous planning and the careful execution with the latest intervention devices and the teamwork gives the best results in chip cases like this. Thank you very much.
Well, thank you so much. Let me introduce Dr. Samir Mehta, who is the chairman from the Lumen Foundation and an expert whole life experience of STEMI treatment.
Pedro, thank you so much. So I've looked at this case many, many times. I'm not sure what I would have done different. And that's why I thought maybe I'll show it to the experts here, or somebody in the audience would like to comment. But one of the, as Dr. Moreno mentioned, this is all I do. It's been 26 years of doing it. And one of the big lessons I can tell you for all of you involved with STEMI is that even in the best of programs, our communications are really, they need to improve, particularly with the ER physicians, and I'll show you glaring issues here. So this is at 10:30 in the morning. How hard could STEMI be at 10:30 in the morning? And I'm in the cath lab, and I got a frantic call from the ER physician that we have this relatively young patient, and they are doing CPR in the EMS, and that's all the history got, and there's no history of any PCI. So young patient, no previous history of PCI, and they are doing CPR in the ambulance. So let's try to see if something could be done, but here we go. So I come down, the hospital doesn't have one of these automated Lucas kind of automatic chest compressor. So two of the technicians are there, I'm there, and we're looking down the road looking for the ambulance. And here is the first mistake. We're looking the wrong way. So the patient is actually had a cardiac arrest on one of the cruise ships off Miami, a massive acute anterior wall MI, and it really is a tribute to how good the paramedics are that in this mode of delivery, transporting the patient. They've been doing constant CPR in the helicopter, and the patient is not young, it's 72, and has a massive acute anterior wall MI, and I'm not sure where exactly was this EKG performed, and there is another strip which shows a complete heart block. So we get the patient ongoing CPR. One of the nurses quickly jumped onto the stretcher and continued to do, and quickly took a picture. I don't know why I chose the left groin. I normally use the right. And quickly put in a pacemaker and placing the guiding catheter. Already this is happening with the CPR, and tried different guiding catheters. I think this is finally an EBU which will go there. And you realize, okay, so this is again going back to we can talk about the technical parts if something could have been done different, but just look at the history. No history of PCI. I mean, this lady has got something like 8 to 10 stents or something, and of course, the culprit here is the left main ostium LAD, and all of it is thrombotically occluded. And again, what is more challenging is the continuing CPR. Just about every guide wire which we had in the cath lab, we kept opening. I traditionally start with the hydrophilic wire. We used a choice PT, extra support, whisper wire, and then whatever else was there, going on to more and more stiffer wires. And I mean, just about every challenge you can, there's clearly a dense thrombotically occluded previously placed numerous stents, I think at least 3 or 4 overlapping, and the wire, of course, would not go through the occluded segment. And I think I proceeded, this may have been the 4th or the 5th or the 6th wire. The exercise will continue. I use a support catheter, tried wiring even the left circumflex to give a little support to see if something could be taken antegrade. And again, I think another view demonstrated that the only way the wire would exit through the struts. And just about every wire, every support, and here it's very deceptive. The wire is through the struts. And even tried to make a little loop on one of the wires and try to kind of daughter it through, but here, thought that maybe, let's see where maybe we can dilate with the balloon at the site before it exits, but again, nothing, no antegrade flow forward. Once again, trying to support the left circumflex. I think at this moment, I thought maybe quickly stenting the ostium of the left circumflex maybe would give some antegrade flow, and did that quickly. And of course, not only did that not improve things, but even the stent is down, the circ is down. Even tried something further, low inflation, I think 2.5 or 3.0 balloon, which I had. I inflated it in the very proximal and just tried to daughter it without any wire as a last frustrating attempt, but nothing. Got a little more flow there, but the patient never stopped resting. And this is almost back to where we were, and this is 45 minutes into the case we pronounced. We'll be happy to take any recommendations from
very
people
difficult
in
case,
the audience.
Tremendous difficult case. Let's look at the non-selective picture you had at the beginning of the case. Before you selectively engage the left main. Here, yeah. So it's terrible, yeah, the whole thing. Okay.
Dr. Mehta, do you ever think about, do you put an impella in first?
Yeah, look, if we had a
or a balloon
would have
pump
been
or,
one of the considerations. Did think about it, but in this case, would that have made any difference antegrade? Maybe. Look, I did think about it later. Possible.
I mean, I think that somebody like this, even if the blood pressure was so-so at this point, you've had multiple arrests, so the LV ischemia is really building up, and you really need to start with an impella first before you do anything else. The LED's gone, you got a stent thrombosis, and things just got deteriorated from there. It's impossible to get flow down a vessel, even if you open up and remove the obstruction, if you don't have any central aortic pressure, or very little.
Absolutely. John?
Yeah, I think that's the key. I think what happens is they've gotten so good at getting patients like this to us. And this is a person who would die in the field. And it's great that you bring it up because we're going to have to try now to save everybody. And you did, you know, and thank God it was you, and you know, we gave it the best shot. But if we're helicoptering people in, there's a goal, there's a standard here that, you know, is pretty high to meet.
Nathan?
Yeah, I mean, I agree. It's out of hospital arrest. I imagine a long CPR time never achieved ROSC. So, you know, even things like ECMO, which you would or should be thinking. I mean, obviously, I think we all understand that early on, then it becomes an LV problem, and that has to be managed first, but clearly not eligible. I'd be curious, you know, obviously, usually we're used to doing a lot of STEMIs. These are not hard to cross lesions. They're sick patients, but usually the technical aspects are not especially hard. But, you know, this is a post-stented patient, unclear history. The fact that it was so hard, I was curious if I don't know if there was an RCA shot done. We went straight with the guide, which you might have done. If we saw complete filling of the LED, that might have kind of changed a little bit of how it was approached. But I mean, I think it's clearly an LED infarct, but it might have been that it was a critical ISR that got the thrombosed.
Samin, would you have done anything different here? Well, let's
only
at
thing
least...
is LV support immediately, ECMO.
Yeah, clearly. No ECMO at this institution. Look, one of the issues which is happening is some of the institutions where you're doing it don't even have a surgical standby. So this is, of course, both Impella and ECMO were in the considerations, may have made a difference. Really, I've, as I mentioned, I have questioned myself what could have been different. But clearly, things which can be done different if you do a lot of STEMI is to continue improving the communications with the ER. Thank you so much.
Okay, so we're going to get the last for the best, or the best for the last, is Dr. La Sala, Professor Emeritus of many organizations, awards for Emeritus, Doctor at Yale University, American College of Cardiology, even the Miller Miami Lifetime Achievement Award. Welcome, Dr. La Sala.
Thank you, Pedro. You know, when you're last, you better be fast, right? So, a couple of interesting things. I know of all the complex cases that Dr. Sharma and his crew have done, there were no LIMAs there. So I thought I'd focus on that. I might focus on that. Okay, obviously the LIMA is considered to be God's gift to bypass surgery. 91% patency at 10 years. This is the other 9%. 51-year-old with a prior CABG has a new problem, expanding type A dissection referred with an anterior wall MI. So from the ER, rather than come right to the lab, goes to the CT scanner, and this is what you see. Whoops. Quick one, you got that? Huge ascending aortic aneurysm. Most of the native vessels are occluded. And you probably didn't pick up on something else, so I put down the radiologist's interpretation, that there is an intimal defect in the root in the ascending aorta without arch or descending aortic involvement. And there's a new long segment of severe stenosis in the left internal mammary artery to the left anterior descending artery at its interposition point. A couple of other things that you can see there. But he's pretty much dependent on this LIMA. So here's the first picture. To my esteemed colleagues, what do you think's going on there? Clearly there's a lesion in the mid portion, which it looks like it's adhered to the underside of the sternum. How about distal to that?
Show us another picture.
You can see that the LIMA's fitting the right coronary, so we're kind of in a tenuous state here.
Yeah,
so how about an IVUS?
It looks like a dissection.
Yeah, it looks like a dissection.
Good point, Pedro. How about the IVUS?
Spontaneous or, extended from the type A flap.
But you don't see
Good pickup, right? Even LIMAs can dissect spontaneously, particularly in somebody who has an aortopathy like this. They can easily go down. So first thing, of course, was to get a wire down, and that's no small feat when the dissection's that long and that extensive. And then we saw a lot of thrombus in there too, so we did thrombectomy first. And then you better get out the longest stents you have, because it's going to be a trail of metal. And this is eventually 4 stents later, and this looks fine. So this patient was allowed to recover, did fairly well. 3 months later, had a reduced sternotomy because we still got the main problem of a type A, of an ascending aortic partly dissection and aneurysm. Their initial ejection fraction pre-op was 20%, but with a prolonged recovery and support and guideline-directed medical therapy, was discharged with an EF of 35%. You can see that the surgeon decided to put in a 25 millimeter Magna Ease, replace the ascending aorta, and did a Cabral procedure to try to minimize any further involvement of the grafts going into the native circulation. Next quick one, 66-year-old prior CABG now presents with a non-STEMI. Initial diagnostic catheterization suggested there's a LIMA anastomotic lesion at the outside hospital, and so it was brought to us for PCI. The patient has an included native LED and a patent left dominant circumflex. Uh-oh. What's going on? So the first one was a endogenous dissection, naturally occurring. This is clearly more iatrogenic in nature.
See, you see the dye on the subclavian, yeah.
Very good, Pedro. That's why I got you up here right next to me. Okay, I needed you. Where were you when I needed you? So we've got a long dissection down a LIMA, which is totally dependent, the LED is totally dependent on this, and we've got a dissection of the subclavian as well. So you start out blind, of course, you can't really see where you're going. The wire, Murphy's Law says that the wire is going to follow the false lumen. So somehow you've got to try to work it out and get downstream. Get a few stents in there. I'm not able to cross the primary problem, which is the anastomotic lesion. I can't see anything, nothing goes through there. But at least I can try to get something going proximally and mid with a few stents, and then finally switch over to a hydrophilic wire, getting through the anastomotic lesion, and then go ahead and finish that up with a stent down there.
Wonderful.
What would you like to do next? Anything? Pedro, you're my vascular consult.
You want to do imaging?
Yeah, there's, well, we imaged that, it looked fine. The subclavian looked like on a few indirect shots, was like it kept flapping in the breeze here. So here's the non-selective shot.
Man.
Yeah, you got troubles there. So
A whole proximal dissection.
exactly.
Almost to the ostium, yeah.
Exactly. So this has to be stented. This is a 10 by 60 vascular self-expanding stent. Didn't compromise the vertebra, which is nice. Did not cross over the LIMA, which is also nice. But you can see how the dissection fills around the stent. Fortunately, we spared the ostium there without with the stenting to keep it patent. This patient did well long term. Last one. Case 3, 87-year-old female has a prior biologic AVR and coronary bypass grafting, has chest pain and dizziness. Local hospital does a CT scan, and according to their reading has a large 6-centimeter aneurysm of the left internal memory graft. She was referred to our institution for angiography and consideration of surgical management. So going into this, I have no idea really what they're talking about other than I'm supposed to see some LIMA aneurysm. Anybody ever seen a LIMA aneurysm before? Maybe at the ostium, at the anastomotic site. That's the only thing. I will tell you on a chest x-ray, I don't have this here, there seems to be this fullness that says, oh, there's got to be an aneurysm there. So I said, I went with it. Let's just take a picture of the LIMA and see what it shows. I don't see anything. But the LIMA is tracking over some spherical area there. See how it kind of goes up and over that? Putting a little tension on the LIMA, might be producing some ischemia. Well, nobody had ever bothered to look at the rest of her vasculature. She had an SVG to the marginal, and so I did a picture of that. Let's see if the marginal's open. What's going on there?
See that.
Yeah, exactly, Art. There is something, obviously the marginal graft is occluded, but there's something sort of injecting into this large circular object that the LIMA was going over and was misinterpreted as a LIMA aneurysm. So let's take it, do an aortogram.
Yeah.
That's big. So now the surgeon comes to me, I called him down, I said, listen, we didn't find what we were expecting to find, we've got this He goes, I said, maybe you should take them to the operating room. He goes, no way. This one's all yours. So what can you do? Of course, first let's take a better picture. So it's an AL1 guiding catheter. Put a Terumo glide wire inside of this. Got an idea to see what the size of it is, because it looks small, but the balloon kind of fills out. It's 7 millimeters. Gives me an idea of what size device I might need to close this off. Of course, the devices are not really made for delivery to this kind of area. So you've got to put an extra stiff wire like a Lundquist in the cavity. Neither can I deliver an ASD device through an AL1 guide catheter, so I have to exchange that for a torque fuse sheath. And based on the diameter of the balloon, just went with some fudge factor, increased the size, put a 12 millimeter ASD occluder in there, and get this, detach it. You can see how it releases from the tension, because this is under a lot of strain trying to get into this particular area. And this is the final picture, and that's without reversing the anticoagulation. So there's virtually no flow going inside of this. The patient did have a follow-up CT scan. It didn't show a LIMA anastomotic. It didn't show a LIMA aneurysm, but it did show that the aneurysm coming off the aorta is completely thrombosed off.
Wow.
It did well. So, conclusions, LIMAs are the best bypass conduit, but they can be fragile. Anybody who knows who've abused them once in a while, when they start dissecting, they don't stop. They just keep going and going and going. They're sort of like the ever-ready bunny, and they just don't stop. But be careful about that when engaging. Be cognizant of the fact that they can dissect spontaneously, and have fun. Thank you very much.
Beautiful.
Unbelievable case. So now, before we finish, we really want to see what happened with that diagonal. And Dr. King is going to show us the final, what she did and the final picture.
Okay, so you can see the angiogram?
Yes.
Good, so that's where we are. So we said that's the way we'll put a short 8 millimeter stent. You see at least 2 millimeters into the LED. We deployed. Now look at it. You see at least 4 millimeters, 5 millimeters. You see the roof, it's covered, right? And this is tap technique where the lower portion of this side branch stent is in the main vessel. We have a balloon across before we did that, you see? So that's how we deployed. We pulled back, deployed to make sure it's covered. So either you can leave it like this, means you have to do a kiss and come out. So you'll have a single layer of carina in the LED. So this is the tap. Tap is that you have stenting the side branch through the main vessel, stenting. But since it was at least 4 to 5 millimeters that was into the main vessel, decided let us crush it, which we did. You see that? Completely crush it. So this is called internal crush. Okay. So at the level of the diagonal, you will now have the LED stent layer and 2 layers of the diagonal, 3 layers of stent at the level of the ostium. So we have to recross. This is how it looked. Okay. So we have to recross. Kissed. Now this is what a trio looks like. We went up to about 16-18 atmosphere. If you see there looks like there's a calcium at the upper border of that ostium and not allowing probably the stent to fully expand. Kiss. And now this is where we are final.
Yep, looks very good now. All right.
Now, do you think ostium is covered or that calcium, whatever is not, but looks good. Final picture is looking excellent. And we had already shown you the OCT of the main vessel with good optimization of the main vessel. So we are going to just say, so now most of our fellows have left. Come, only a couple of attendings are here. Where is Hudaji? Can we go here live? And we have a Kiski.
Sure. All the...
Are they showing us?
Yeah. All right, let's get all our staff ready. All the hard-working crew. All the hardest working crew is already here.
Come, whoever is around. Oh, yeah, we have the chief fellow. And we have a young budding interventional cardiologist. on my right.
Yeah.
Beautiful. Fantastic.
Okay, good.
I mean, that
Thank
brings
you for this, I think, excellent session that we had. Okay, come, Gaurav. We have one more who joined. Everybody can see us?
Yes. And actually, I can tell you, about 125 plus people still in the room. And that's why I can tell you this has been a great success. Only thing is, this Friday, 2 years we did, last year Friday, this Friday, only problem is, but here next Friday, we always do at the Father's Day weekend, it's the Juneteenth, 19th.
Juneteenth, thanks.
How can you do it? That's the problem. So do we go to Thursday? Because it will be a long weekend anyway. So I think this we learned that do it on the weekend and has been most important, our extreme faculty and the cases, this complication. I call this a word as a complication because people always ask that, during procedure we want to see the complications. I say, well, we may disappoint you, but I'll make an agenda. So I may just call it next time, to our senior faculty, your most exotic case. Whatever you want to teach, because people want to see something different. I mean, run-of-the-mill top cases which we showed, and just basically teaching point of view, something different, and those cases which were shown, very, very educational and learning. And I think one of them is that never give protamine and the PCI. Never. Even you're bleeding and so you cannot.
Picture?
All right. With the cath lab, of course.
Good? All good? Yeah, come.
Yeah, so
That's
I
why we
think
are
from
taking
your
a final
side,
picture
once you
and
finish it.
bye-bye from all of us.
Okay, bye-bye. Good. So now last task left now. I had this iPad. It's a good one, right? Beautiful. Beautiful. All right. So somebody has to go home with this iPad. And guess what? Who is going to go home if they have their ticket? Please look into the back of it.
All right, so we got one number, 587744. 744.
The 744 is already there? All right, let's come.
744. Yay, we have a winner.
Now, they have actually something this punched. I don't know what to say on this. Maybe they'll tell me what to do. All right. Okay, your name is? And then, all right. 744 in the first shot. Never happened. But then, this, okay, so now, they say we'll announce winners on, and 2 winners will receive a $250 Amazon gift card. So these are the 2 people. I think this basically means that did you go to all the booths?
Yes.
And get the punch?
Yes.
You can punch yourself. But you didn't need to go there. You can sit here and punch it, but that's a technique, innovative technique. But don't try it. But anyway, one is the Nihar Jena. Nihar, all right. And second is Angelita Florendo. So both of you will get a $250 Amazon gift card. How would you get it? I do not know. But you'll get it. Then I can promise you. Our very good system. The whole. Yeah, it's very good. All right. Great meeting. Good. All right. Fantastic. So we continue to, innovate, learn from each other, and hopefully this meeting today were able to help you in various aspects or teach us on various aspects. And great day. In next half 1 hour, we'll see you on the boat. And next year, it will be on 18th, where it will be, based on the schedule, based on the things, whether it will be at Mount Sinai, with some different hotel or here. We will figure that out. But see you next year. Thank you very much.